Well, good morning, everybody, and welcome to PrimaryCare25. My name is Sean Martin. I'm the CEO of the American Academy of Family Physicians. And on behalf of our partners in Primary Care for America, we are excited to be bringing this program to you today. Primary Care for America came together in 2021 around three key issues. First and foremost was to demonstrate the value of primary care to individuals and communities. Second, we wanted to drive and feature innovation that was driving primary care to deliver high-quality care to communities all across the country. And three, we wanted to grow the primary care workforce to meet the needs of current and future generations of America. Today, you're going to see all three of these topics highlighted in our programming. To start the morning, we're going to learn a little bit more about the state of primary care in the United States. We're going to have an excellent presentation from Dr. Yalda Jabarpour, followed by a robust conversation from national experts who are going to talk about all three of those issues: the value of primary care, the innovation in primary care, and the workforce needed to meet populations on a go-forward basis. We're going to follow that by having a discussion around MACRA. On April 16th, 2015, Congress passed a law to change fundamentally how we pay physicians in the United States. We're going to look back on a decade of MACRA. Did it work? What innovation is it driving? What are some of the shortcomings of that program moving forward? Next, we're going to have a conversation about direct primary care, a model that has been around for more than a decade, but certainly a model that is gaining interest amongst both physicians and patients alike in communities of all sizes across the United States. And then after lunch, we're going to come back and we're going to have a conversation about a topic that is front and center in the United States Congress, the administration, and certainly in state capitals all across the country, and that is the role of primary care in addressing the growing chronic disease crisis in the United States. And then we're going to close out our afternoon with three innovation panels. One, looking at the concept of direct contracting, featuring Boeing and other clinic models that are contracting with businesses to change the dynamic of primary care and the relationship between those businesses, their employees, and continuous primary care. Next, we're going to look at independent primary care practices, specifically for rural communities. And then third, we're going to bring together a panel of experts and talk about the CMMI models. How have they grown? Where have they been successful? And where do they need to go moving forward to help grow primary care in the United States? Each of our programs will start on time with the agenda. They won't start early. We're really looking forward to being with you today. And thank you for joining us for this important conversation. So let's get started. It's my pleasure to introduce the director of the Robert Graham Center, Dr. Yalda Jabarpour.
Okay, thanks, Sean, for having me. It's my pleasure to be here today to set up the morning for you all. I wanted to spend about 15 minutes setting the stage for some great conversations that Sean alluded to that are about to come later in the morning and later on today. And I'm going to do that by talking about our findings from the 2025 Primary Care Scorecard, which was aptly named the cost of neglect. Let's see. Let's start with what we know about healthcare in the United States. This figure taken from the Commonwealth Fund shows that the United States, compared to all other developed nations, invests more in healthcare. And we would like to think that this higher investment per capita in healthcare actually leads to better health than other countries. Unfortunately, that's just not the case. This figure, also from Commonwealth, shows that despite spending more on healthcare in the United States than these nations, we actually have worse health outcomes, in this case, life expectancy. And why is there this mismatch between how much we spend on healthcare and our health outcomes in the United States? Well, in this year's scorecard report, we argue that it's because we're just not investing money in the right way. Namely, we're not investing in primary care. We know that primary care is the only sector in healthcare where more is actually better. Here, researchers looked at what would happen if we added more primary care clinicians to an area. and they found that it would increase life expectancy by anywhere from 50 to 150 days. And there are many more studies like this about primary care that show primary care, when done right, can increase quality, decrease cost, and result in more health equity. So this year, as in other years, we show that underinvestment in primary care is actually failing US patients. We do this by focusing on the 5 domains that were set forth originally by the NASM Committee on implementing high-quality primary care. We show how our payment system and our underinvestment really is impacting these 5 domains in a negative way. It's all about the money here, how the money impacts the workforce, how it impacts the training pipeline, how it impacts primary care office infrastructure like technology, and how it impacts research, ultimately leading to a healthcare system that's not meeting the needs of the US. So let's start with financing. This is the domain that sets up all the other data points that I'm going to talk about. We found this year that primary care spending in the US is low. It's about 3% of total healthcare expenditures that are going towards primary care in Medicare, 4% in Medicaid, and about 4.7% for all payers together. But it's not only how much we invest in primary care, it's how we pay for primary care. This figure on the left is actually taken from the HCP land measurement effort. They look at what percentage of payments overall in healthcare are done by fee-for-service or a non-fee-for-service model or a hybrid model. Those bars, the red bars, show any of the payments that are not based on fee-for-service whatsoever, so not hybrid and not purely fee-for-service. And it is growing, but still a majority of the payments done in the US are via purely fee-for-service. And why does this matter for primary care? Well, fee-for-service is a transactional model of payment, but I'll argue that primary care is not a transactional model of care delivery. Fee-for-service values those discrete, usually procedure-heavy based services that primary care isn't known for. Primary care is known for taking care of the whole person. It's that continuity we provide that allows us to know when a patient is truly sick and needs to come in to be seen face-to-face or just needs reassurance over the phone. It's that comprehensiveness that allows a busy mother to come to our office and get all her healthcare needs met at once instead of going to multiple specialists and having multiple appointments. It's that coordination of care between settings and between specialists that allow the primary care physician to know when treatment plans might be negatively interacting with each other. It's all that extra stuff that we do that is not valued in a fee-for-service system. And to demonstrate that, we looked at average per visit revenue for a specialty like primary care compared to a more procedure-heavy, organ-specific specialty like gastroenterology. And it's probably no surprise that in the current payment model of fee-for-service, primary care can only generate about 1/5 of the revenue of a procedure-heavy specialty like gastroenterology. And why does it matter that we're only generating 1/5 of the revenue? Well, I'll argue that it's because it really impacts the other domains that are important in terms of having a high-quality primary care system. So let's look at workforce. Again, this year, as in decades past, our workforce numbers are abysmal when it comes to primary care. There's only about 67 primary care physicians per 100,000 population. If we add nurse practitioners and PAs who practice primary care in there, the number does go up to about 103 primary care clinicians total per 100,000 population, but that's still lower than most countries that provide much better care. For example, in Canada, they're at about 120 primary care clinicians per 100,000, and they're complaining that they don't have enough primary care. Why is this happening? It's not a leap to draw the the straight line between how we finance primary care and what's happening in the workforce. First, the most obvious, if you're not generating revenue, your salaries are generally lower. We know that primary care physicians tend to make the lowest salaries in all of medicine, which makes it hard to recruit medical students and residents into our field. But probably more importantly, that low office revenue leads to primary care practices that are under-resourced but overworked. And when you have under-resourced, overworked primary care practices, it is hard to retain and recruit physicians into the field. We were hopeful that the growth of the nurse practitioner and PA workforce would actually help fill some of the gap in primary care. Unfortunately, we are seeing similar things happening with nurse practitioners and PAs. In the latest year that we studied, there was a drop in the percent of nurse practitioners and PAs working in primary care. Currently, only about a third of nurse practitioners work in primary care and about a quarter of PAs. And it's likely that the same market and monetary and financing pressures that are pushing medical students and residents out of the primary care space are pushing nurse practitioners and PAs out of the primary care space as well. And all these workforce issues are leading to access issues for patients. We looked at what percentage of US adults and children do not have a usual source of care. In 2022, that has grown to about 31% of all US adults saying that they don't have a usual source of care, and 12% of US children saying that they don't have a usual source of care. If we take usual source of care as a proxy, one proxy for healthcare access, then it's really obvious how that underinvestment fee-for-service payment model is impacting the workforce and ultimately access to care for patients. Unfortunately, there's not much on the horizon in terms of filling that workforce with training. So what we see here is that there has been a growth of the number of primary care residents over time. That's that teal line. There's also been a growth of the number of all other specialty residents over time. And I think the more important thing to look at in this figure is the gap that's growing between those lines. So primary care is not growing as fast as all other specialties. And complicating this is the fact that not everyone who trains in a primary care residency actually ends up working in primary care after graduation. Particularly for our internal medicine and pediatrics colleagues, there tends to be a lot of subspecialization after the initial residency. And so that's what the figure on the right looks at. We know that about a third of the current physician workforce is working in primary care. But when we look at all trainees in 2022, 3 to 5 years after graduation, only 24% of all trainees are entering primary care. If we take the hospitalists out from that number, only 19% of all trainees in the United States in 2022 are entering primary care. So our workforce is shrinking. Again, why is this happening? I'll take it back to the money. So if you are a medical student or a resident and you are rotating through an under-resourced, overworked primary care practice, and you know the salaries of those primary care physicians are lower than any other salaries in medicine, it's gonna be hard for you to make the choice to go into primary care. But it's not only that, it's how we are training our future pipeline. We are training most of our medical students and residents in large academic medical centers, which means that most of our training is actually happening in the hospital setting. We are only human. We're gonna choose what is familiar to us. And primary care generally in the outpatient setting is not familiar to us when we are training. To look at this, we actually looked at Medicare GME funding and whether that is creating a primary care workforce. Medicare is the largest funder of graduate medical education in the United States. Medicare funds graduate medical education to create a workforce that can take care of Medicare patients. And I'll argue that that workforce should be predominantly primary care. But is that what Medicare investment into GME doing? Is that what it's doing? So what we did here is we took all the money Medicare is giving to sponsoring institutions and rolled it up to the state level. Each of those dots represents a state. On the x-axis, we have Medicare GME payment per capita in that state, and on the y-axis, we have the percent of new physicians in that state that are entering primary care 3 years after graduation. And what we see here is a negative association. So a state like New York that gets $15.5 million per capita for GME training is producing only 15% of their new physicians that are going into primary care. Now, of course, there's outliers. There's states like North Dakota that get relatively small amount from Medicare for GME funding. They get $2.1 million per capita, and 43% of their physician workforce is going into primary care. So there are outliers. So what are we saying here? Are we saying that Medicare should no longer fund GME because it's not creating a primary care workforce? That's not what we're saying. We're saying that there needs to be more accountability back to Medicare to show what workforce they are creating from the sponsoring institutions that are receiving these funds. So I've talked about how our underinvestment in primary care and our payment system are setting up primary care practices that are not conducive to recruiting a strong and robust workforce. It's not conducive to increasing the pipeline of people going into primary care, but also the low investment in primary care and the payment models that we have are creating practices that just don't have the capital to invest in infrastructure that could help them take better care of patients. There was a promise that technology would improve the care for patients, make things easier for clinicians, maybe even improve access for patients through things like the patient portal, but it has not delivered on that promise. Almost half of family physicians view their EHR usability as poor or fair, and over a quarter are dissatisfied overall with their EHR. With artificial intelligence and things like ambient listening coming onto the market, again, if primary care does not have the capital to invest in robust systems, these things are not going to work for physicians and not going to expand access the way they're promised to. And finally, federal research funding for primary care is low, at about 0.3% of all total federal research funding. This includes funding from NIH, FDA, CDC, and AHRQ. So I'll take us back to the title of the report and my original question, what is the cost of neglect? Well, this year we showed that underinvestment in primary care and payment systems that are purely fee-for-service are resulting in primary care services being undervalued, which undermines the ability to provide high-quality primary care. It's resulting in increased workloads and practice inefficiencies that cause workforce numbers that are limiting access for patients. It's resulting in practice environments that are not attractive to trainees, limiting our ability to grow the workforce. It's resulting in things like burdensome EHRs that do not serve clinicians or patients. And finally, we see that limited research funding is really stalling evidence-based improvements in care. That was a fast overview of all the wonderful data in the Milbank report. I encourage you to go and download the actual report. There's a lot more data points on there. And if you go to the dashboard, you can see state-specific data as well. Thank you all.
Dr. Jabarpour, thank you so much. At this time, we're going to continue this conversation around the primary care scorecard. I'm going to invite our panelists, including Dr. Jabarpour, and our moderator, Dr. Margot Savoy, to come up to continue our program. Dr. Savoy.
Everybody. It's really good to see you. Thank you for joining us this morning. In addition to Yalda, who you've already been introduced to, I'm really pleased to welcome to our stage Dr. Erica Socker. Erica Socker is the Vice President of Healthcare at Arnold Ventures, where she develops and manages strategic investments in healthcare. She has significant experience, including in directing including in directing the health division at the White House Office of Management and Budget, and addressing health policies at the Congressional Budget Office. Erica holds a PhD in political science from Texas A&M University, as well as a BA in economics and a BS in mathematics from the University of Maryland, which happens to be my favorite university in the whole wide world. So I'd like to welcome Erica. Go Terps. And then also Christopher Kohler is joining us on the stage. He also went to a really cool university. So Christopher Kohler is president of the Millbrook Memorial Fund. Before joining the fund, he served for 8 years as the nation's first health insurance commissioner for the state of Rhode Island, where they were nationally recognized for successfully using insurance regulation to promote payment reform, primary care revitalization, and delivery system transformation. He has deep experience also as a past CEO of the Neighborhood Health Plan of Rhode Island and a founding chair of the Association of the Community Affiliated Plans, and he's a member of the IOM Committee on Essential Health Benefits. He is an adjunct professor of community health at the School of Public Health at Brown University, and he has a bachelor's degree from Dartmouth College and a master's degree in management and religion from Yale University. Not quite as exciting as Maryland, but it'll do.
Basketball's not as good.
So, Yalda, you did such a great job setting us up with your presentation, so thank you. You did a fantastic job. I'm imagining that our panelists have reactions. I know I had thoughts sitting in the audience. Could we kick it off with just sort of thinking about sort of what came to mind for you? Chris, could I start with you?
Sure, and thank you very much. Thanks to AFP for organizing this. I want to, first of all, on behalf of Milbank, thank Yalda and the team at the Robert Graham Center for the work they're doing with the scorecard. It's really good. I will say, Yalda, I think we want our money back. We wanted to pay for good news, and so none of this is like... Right, but we very much appreciate the collaboration with the Graham Center. This is important information that can be put out as a baseline to describe what's going on. I just want to sort of call out a couple of the highlights. So in some ways, this will just be a repeat of what some of what Yalda reviewed in the scorecard. But hopefully it'll kick off the conversation for the day. The first is just to note how serious the issues are around the trends that Yalda documented. This is not just about a particularly aggrieved party that's looking to get a little bit of political influence. We at Milbank work with state officials all the time. We've worked on this issue. I think what I want to call out is the increasing number of people who do not have a usual source of care. That is when this problem hits home. It ceases to be a pointy-headed policy wonk problem and is something that is hitting politicians. When your governor or your speaker of the House says, how come people can't find a primary care physician? That's when we've got some opportunity to move on this thing. And when people don't have a usual source of care, they go to the emergency room more often. They get admitted to the, but this is not an opinion, we got evidence. They go to the ER more often, they get admitted more often, they have higher incidence of chronic conditions that are poorly managed. So if we're really serious about making America healthy again, it starts with making sure that people can have whatever chronic conditions they have managed in an outpatient setting. It's fundamental to our health. And so I think for those of us who are interested in primary care, framing this, we got to come up with a better phrase than a usual source of care that doesn't exactly roll off the tongue. But folks got to have a place that they go when they're sick. They got to have a place that they can help them navigate what is a ridiculously complicated healthcare system, and comprehensive primary care can do that. The other piece I would say on that is, for those of us, we shouldn't get tied in knots about what exactly is that usual source of care. I think we have to trust folks that if we make the right choice, the easy choice, as they say in public health, people will find their way to high-quality primary care. We shouldn't get into sort of inside the profession battles over what exactly are the elements of high-quality primary care. Let's just make sure that people have a place that they can go when they are not feeling good. The second piece, and this is not rocket science, is I want to start where Yalda began and ended. This is about money. fundamentally, primary care, the reason we're in the box that we're in is because primary care is undervalued relative to other healthcare services, and that when it is valued, it's paid in a way that does not encourage the best of primary care. As Yalda and her colleagues like to say, the best things we do, we never get paid for. And so the fundamental solution to this is that we have to pay primary care more, and we have to pay it differently. More just means a higher portion of healthcare spending going to primary care. There's a reason why Yalda, that's the first measure she puts up there, is because compared to every other high-performing health system, we just spend less money on primary care than other places. So we need a redistribution. And the second piece is we have to pay in ways other than fee-for-service. We have to pay in ways that allow for team-based care, that allow for our nurses, members of the primary care team, to do whatever people need. Often they want the physician's expertise, but it can be delivered in a bunch of different ways as opposed to having to show up in an office. So pay more, pay differently. And then where I want to end with is this notion of what we need is a fundamental rebalancing of our healthcare system. We need to be a much more primary care-oriented delivery system. And again, for those of us who work in primary care, I would encourage us not to use the language of investment. Investment implies a return that's going to happen in a fixed amount of time. The returns of longer life expectancy happen and better health equity happen over time. They're not going to happen in the next 5 years. That's why primary care-oriented payment models did not generate returns in the short term within CMMI. So we need a fundamental rebalancing. I want to draw a connection between this and the debates that are happening down the road at Capitol Hill. Healthcare is bankrupting. Warren Buffett says healthcare is the tapeworm of the U.S. economy. It's also the tapeworm of the U.S. budget. And that's the reason why we're fighting these battles down the street. It's because more and more of our federal budget is going to healthcare. We need to fundamentally reorient the way that our system's happening or is organized. And that can happen one of two ways. It can happen either with changing the economic incentives across health systems and across payers. That's the payment reform argument. Or it can happen with a revaluation of Medicare. Medicare is the straw that stirs the drink. When I ran a health plan, the first thing I asked is, what does Medicare pay? Because that determines everything else. Medicare undervalues primary care relative to other places. This has to be a redistribution. We can't just ask payers to put more money in primary care and hope the returns come in 2 or 3 years. And so those are, and it's not either or. You can rebalance the way Medicare pays, and you can think about aligning economic incentives. But you got to do it at scale. You got to do it across all payers. That's what we've learned with the Medicare stuff. So I'm going to stop there because I've kind of gone on for a way. And note, as a foundation guy, I get to dwell in the world as it is, as opposed to like how you actually make it happen. Erica's the policy expert, so she's got to talk about how you actually implement this stuff.
So I agree with so much of what Chris just said around the seriousness of the primary care challenges facing the country and the fact that money and payment and how much and the way that we pay primary care is really at the kind of heart of this and really important to fix to solve the problems that y'all laid out. So at Arnold Ventures, our mission is about improving the affordability and efficiency of the healthcare system. And so 95% of the time, we're talking about ways to reduce wasteful spending and to take money out of the system. And I would say primary care is really, we think about that and approach it really differently. And to echo some of what's already been said, I think the evidence is very strong that primary care has been underinvested in systematically as a place where we actually need to be paying more, and that is essential to get to the outcomes that we want to see and to have a high-performing, efficient healthcare system overall. And so normally, I'm like rarely up on a platform talking about places that we should be spending more in healthcare with my Arnold Ventures hat, but would say that primary care really is a place where I think that is true to see the outcomes that we want to see. So just to echo a couple things that Chris said, I think it is both about how much we're paying for primary care, the actual amount, and that's true across kind of regardless of the way that we're paying for primary care, but we also really need to think seriously about moving away from fee-for-service. And when you're focused on trying to, how do I create a patchwork of codes that I can bill for and get reimbursed for to deliver comprehensive primary care, we're never going to be able to have the type of team-based care and for primary PCPs to be able to deliver like the mix of services and the variety of things that people really need to be able to manage chronic conditions, to get to better health outcomes. Maybe just talking a little bit about the policy landscape and where things are at now and where things are going. It was a really promising bill that I really consider a marker in the primary care space that was introduced last, I guess, late spring, early summer, called the Pay PCPs Act. And that was sponsored by Senators Cassidy and Whitehouse. And it included pieces that we're talking about here today, as well as one additional piece we haven't talked about yet. But it included, it would create authority for HHS to establish hybrid capitated payments for primary care. So continue to pay for some services. Think about things like immunizations on a fee-for-service basis. You could think about paying for office visits kind of as a hybrid. But then it would shift a substantial amount of payment to a capitated payment that really would provide some of this flexibility, could reduce burden, and not have to bill for all the services. And so that was a really important piece that there has been progress that CMMI and CMS has made on the primary care front, but really we need Congress to act to be able to scale those across the Medicare program, which does play the role that Chris mentions and kind of setting things up, filtering through the rest of the system. It also included it would set up a temporary technical advisory committee that I really see as playing a role in helping restore the RUC to its advisory role that it was intended to play when it was first established, but we know that it plays much more than an advisory role currently, and that the recommendations that the RUC makes are almost always accepted by CMS, and that has really resulted in we're underpaying for primary care services, for services that are cognitive services, and we are really overvaluing and overpaying for procedural care in many cases. And so I think that's a fundamental kind of unbalance that both Yalda and Chris highlighted that would be addressed in this. And then finally, that also thinks about how to better engage beneficiaries in all of this, which is the piece we haven't talked about yet, and would include the ability to reduce cost sharing for primary care services for beneficiaries that actually name their usual source of care. We do need a better name for that. It's quite a mouthful. I'm not sure beneficiaries really know what that means, but I think they understand the concept, even if not the phrase. So I would just say that is a place, like that is a bill that is out there. There's also work going on the Senate Finance Committee to rethink physician payment more broadly, and primary care and how to better manage chronic illness has been a really core part of those discussions. I know there's a MACRA panel coming up later, so I won't talk much about that. But I think right now we're in this very unusual political moment where it's just hyper-partisan and there's not a lot of bipartisan work taking place. But this is, I think, a lane where this work truly has been bipartisan, and there is an interest from people on both sides of the aisle in addressing the challenges that face primary care. And so in what might seem like kind of a dismal situation, getting things across the finish line and making progress on things, I do think this is a lane where we can really, where there is opportunity to make continued progress over the next couple years. I'll stop there.
I don't really have a reaction to my own presentation, except for to say, you know, when you do the research and you hear what's happening on the policy front, it humbles you when you're in clinic to actually see that happening in real life. So I talk a lot here about how the payment system is not valuing what's happening in the primary care office, and I'm not exaggerating it. It's true. When I'm in the primary care office, so much of my time that I'm spending with patients is not really doing these discrete services, but it is so valuable to their health. And when they leave the office and I go to bill, I'm like, how do I bill for this? You know, how do I code what we just did in the office setting? And Margot and I were talking about this earlier. It trickles down to what we can do in the office too. We are trained to provide pretty comprehensive care. But in 10 minutes, can we actually provide that care? No, unless we want the patients waiting in the waiting room for an hour and a half for us, right? And so what do? Because we're incentivized, we're paid in a fee-for-service system, we are naturally incentivized to refer out. And what does that do to patients? It makes them dissatisfied. They see us as the place that they come to just get referrals when we are trained to do so much more than that. So if we are going to if we want patients to come in to see primary care and not go to their specialists, number one, we have to have a workforce that supports that. But number two, we have to have a payment system that supports that. No patient is going to have a bad experience with a primary care provider because they could only spend 10 minutes with them and then referred them to 3 people and is going to think, yeah, I want to go back to that. We need to show patients, again, what good primary care looks like.
So thank you all. Like, that was a really great transition. I think I'm hearing some themes. So theme number one I think I'm picking up on is it's all about the money. So following the dollars is really important, and that you're not asking people to follow the dollars, for example, because primary care just wants to be a bunch of millionaires, but that truly you're talking about following the dollar to the practice itself and how you can invest in the practice in a way that allows that practice to maybe not have a return in 2 or 3 years, but to have a return that could last an infinite number of years if you were able to extend people's lives and really make them healthier in a community. I'm also hearing you say that it's bigger than just a practice and that there's actually this larger opportunity for us to think more like that public health, population health lens, where you're truly thinking about how to make the easiest thing the right thing to do, so that you're not giving the patient the experience where they're spending 2 hours in the office but only 5 minutes in front of you, but they're also not necessarily disincentivized from getting the care that they need at that moment, so they have the opportunity to get what they need. And hopefully it's from us because we've been put in a position to make that possible. And then the third thing I'm hearing is that there's levers. There's not just one lever. So we're here having a conversation today, but that conversation maybe isn't just about physicians, and it maybe isn't just about policymakers, but that there may be other people who could get engaged. And I think I'm hearing that maybe even Medicare beneficiaries, for example, we call them patients, they call themselves people, but like sort of the folks, I mean, that's us too, because you also end up being, at some point, even as a clinician, you end up being a patient at some point too. But that all of the people maybe have a role in this. And I don't know that I hear anyone talk about how a Medicare beneficiary might, for example, lean into this conversation about workforce, and why would they even care? Like, so why or how, or are there examples of how people have leveraged some of the policy things you've described or some of the sort of insurance structures that you've described to help other people get engaged besides just physicians or policy people having these conversations?
Do you want to do that first? Yeah, so I want to do 2 things about how to get other folks engaged in the conversation. The first is around beneficiary engagement, and I'm looking forward to the direct primary care discussion because I think that's something the DPC gets right, which is how do you set up how do you have the economics aligned with the idea of a relationship? I had the privilege of serving the National Academy of Medicine on implementing high-quality primary care. I'm not a clinician. They were struggling with this definition of primary care, and what they came out with was what Yalda and Margot are describing, this notion of an ongoing relationship between a patient, their family, and a team. That is where trust is built, and relationships are a 2-way street. It's not a free ticket, and so how do you set up behavioral economics? Erica's a PhD. How do you make it, again, the right choice, the easy choice? I think some of that is benefit design. We've learned that if you make primary care cheap in the benefit design, people use a lot of primary care. They show up there. They also use a lot of specialty care. That's when big self-insureds like IBM made primary care free, but only to a usual source of care. You had to designate who your person was. What happened? I went to primary care a lot. I got referred out some. I stayed out of the emergency room. I stayed out of the inpatient. That's a pretty good bargain in the long term. How can we apply those lessons to Medicaid and Medicare? In terms of engaging the policy conversation, lest we get, Erica accurately described sort of the changing environment, what's happening nationally. There is stuff going on at the state level. So what you see are conversations that are happening. Often it is in the form of some sort of a primary care commission or task force, a set of folks, both providers and consumers, that are paying attention to this over time, that are developing state-based scorecards, that are looking at what Medicaid is doing, that are looking at what's happening in commercial insurance, trying to get this, because often the states are where innovation happens and gives examples to the feds. So we're seeing some of that happening. We're seeing good work on Medicaid in Massachusetts. Rhode Island, where I'm from, was actually the first to say to commercial insurers, you will rebalance, you will spend more on primary care. California, because they're California, has taken it to the nth degree and says, well, we're going to be like 15% or something like that of our spend going to primary care. So I think there are opportunities at the consumer level around benefit design, and then there are opportunities at the political level among states, because you can motivate energy more readily around the policy change.
Yeah, maybe just to step back a minute and think about like the lessons from accountable care more broadly, because I think that is an attempt to really reorient the system to caring about population health. And I think one thing that we have not done very well in ACOs to date is the beneficiary engagement piece. But some of the things we have learned from ACOs and from kind of accountable care and value-based payment more generally, I think one is that it's really important for physicians to lead, and that is a place where we are seeing primary care really make a difference. So ACOs that are more primary care centric have a greater share of primary care providers. They're more successful at the ACO program. They get to better outcomes for patients. They're more likely to generate savings for taxpayers, and so I think that's an important lesson from that. We also see that with physician-led ACOs generally, relative to hospital-led ACOs, they have better performance in those programs. And so I think that kind of highlights, as one takeaway from that, just the importance of really having physicians lead this conversation and lead the transformation that we want to see. I don't think we can rely on health systems and hospitals to solve this problem for us. The reality is that kind of opens up a whole separate other conversation, because we have a real decline in independent physician practices. And so, I won't get into that too much, but I think it really does kind of highlight the need to also think about addressing consolidation and thinking about all the drivers so we can help keep more physician practices independent and hopefully even like reverse some of what we've seen so far in terms of that consolidation. Because I think that's really critical for making sure that the incentives are aligned, and that when PCPs and other physicians are changing the way that they practice, that they also really reap the benefits from that, and that those benefits aren't going to hospital administrators or kind of elsewhere in the system, but are really flowing down and being kind of used to make the kinds of care delivery changes that I think we all want to see. But I think the beneficiary engagement piece really hasn't been addressed very much in those models, and one lesson from them is that is something we do need to think about more. I think in two ways, both how do we even kind of engage consumers and do some of the education around what these are. Most people don't even know they're in an ACO that are in it, right? I don't think people really know what that means. ACO is a very wonky term. What does it actually kind of look like and mean to people on the ground? I think that's one piece of it. And then I think the benefit design, as Chris mentioned, is the other piece that's important. How do we think about kind of cost sharing, reductions, and other methods that we can use to keep people within the ACO for care, and make sure that they really have access to the doctors that they need to see to provide the best possible care. So I see that as kind of a next step for ACOs going forward, really thinking more about the beneficiary and consumer engagement piece, both from a policy perspective, but also just from an education and engagement, having people understand what these are. I guess one final thing I'd say is that I think it is also useful to look at, if we're thinking about how this affects people, to look at the experience with Medicare Advantage. And I think that has highlighted some of the friction points potentially when you move to more of a risk-bearing capitated system in terms of the prior auth, not having timely payments, the narrower networks than you see in traditional Medicare. And so I would really encourage us to think about how we can get some of these incentives right in traditional Medicare, because I think then we can preserve people's access to see providers. We're not dealing with prior auth at all to the same extent as an MA. So I think that's a really important piece to think about.
I mean, it's interesting because when you initially said, we should follow Medicare and sort of pay attention to what they're doing because they lead the way, it probably wasn't as sort of obvious to us in the room that Medicare doesn't just show up on the payment side, but they're also showing up on the innovation side. But then, Yalda, you alluded to this in your presentation, they also show up in the training side, so that Medicare is driving a lot of the decisions that might be getting made, or they have the opportunity to be able to make those decisions look a little bit different. And I'm also sort of thinking about the way you're describing it, things like value-based care or the models of care or what a beneficiary isn't necessarily something that's very big in training. So sometimes it's very difficult to teach physicians about sort of that part of medicine, particularly when you're early in your training, you're just trying to get your legs under the clinical part. Thinking about this bigger structure, this bigger system is really overwhelming. Yalda, I'm looking at you because you teach and you also are a practicing physician. Do you see spaces where that's making sense or playing in, or do you have thoughts about this idea where Medicare is sort of stepping in?
Well, I think going back to one thing you just said about the training of physicians, it's true, we don't train very well in the business of medicine, but that ends up being our whole lives when we're out in practice. We're learning the science, we're learning how to take care of patients, and that's important. We should be learning that. But we are the ones that are, us and the patients, are the ones that are impacted by the business of medicine. And so I think there is some importance there in terms of how to reform education, training, to incorporate some of that. I think my point in the presentation about Medicare's role in graduate medical education and how that can change is not that Medicare or Medicaid should start paying less for graduate medical education. It really is that they give this, a lot of money to these sponsoring institutions, which are mostly hospitals, and then don't look at their return on investment. Is that money creating the workforce that is needed to take care of Medicare patients? And we know with chronic disease growing, et cetera, it's primary care that's taking care of Medicare patients. And so there needs to be some sort of accountability metric back to Medicare to make sure that the slots that they are funding, the institutions that they are funding, are really invested in not just having primary care residents, because we know that they'll go on to subspecialize, but creating a primary care workforce that continues to work in primary care and in underserved communities. Another thing I'll say, picking up on some of the things that Erica was talking about, it's important to engage physicians in this, but it's also really, or clinicians, it's also really important to engage patients. We are all we have this idea in our heads as policymakers, as researchers, as clinicians, as to what primary care should be. This is what you should look for in primary care. But is that what the patients want? Is what we think of as how primary care should be delivered what the modern day patient wants in terms of primary care delivery? And I think we need to ask them more. I think as researchers we need to ask them more, as physicians we need to ask them more, as medical system leaders, as leaders in the policy world, we need to ask patients more what they want. Maybe it is not the continuity comprehensive care that they want when they're 22 and healthy. Maybe it's convenience care that they want. But maybe when they're 60 and they have multiple chronic diseases, that's when they want the continuity and the comprehensiveness. And we really do need to figure that out.
Oh, sure. Drop the controversial thing near the end. That's just crazy. I love it. So I think that is so exciting, thinking about the opportunity to actually, share the decision-making about how you get your care, not just about what the care is going to be. I mean, that's really amazing to think about. So we're running to the end of our panel, and today's theme is supposed to be see the possibilities, right? So we're supposed to be thinking about what possibilities could exist. And I'm just curious, like if tomorrow there was like a magic wand or some spell that we could cast and you could just fix this problem, do you have a thought about what your big wish would be? Chris, I'm going to look at you first.
Nice.
You looked excited.
No, we had a pre-meeting on this. I knew this question was coming, and I still don't have like a single answer. I'm gonna when we were on the National Academy of Medicine Committee on Implementing High Quality Primary Care, there was a group that self-organized around money, and we sort of elbowed everybody else out because we wanted to talk about the money. And it's not a new answer, but if it's the magic wand, it's go back to Medicare. I mean, because Medicare itself is a commitment that we have made as a country around solidarity, that no one should experience medical bankruptcy as they get older. It's the bedrock of, at least from a healthcare side, of really of our democracy. And within that, we have a really flawed way of allocating resources because we're humans, so nothing's perfect. But we've got to fix the way we do valuation within Medicare. And I hold hope for aligning the economic incentives, but even the payment reform that Erica's talking about. But when you look at ACOs and how they perform, they're going back to valuing it based on fee-for-service. Their comparator is fee-for-service performance. And what's the basis for that? How prices are attached to codes. And if we're not going to use the market to attach valuation, which I think we should not do for healthcare, because I'm not an informed shopper when I'm out there lying on my back in a Johnny, then we need some political process for doing it. And we have to fix the political process that revalues primary care. Lots of other stuff around training, but if we do that, then that's a statement about what we value as a country, as a people, and then we can go to work on the other issues that y'all just identified.
Yeah, I completely agree. So maybe that's not very interesting, but I think there's a number of things we need to do. But first and foremost, and I think this is something that we could accomplish in the near term, I think we have to fix the fee schedule weights in Medicare. We have to reallocate the relative values across different types of services. I think that's both fundamental for all the providers that are still getting paid for fee for service, but even if we can move more people to the hybrid capitated model, which I think is eventually where we'd like to go, we still need to get the underlying fee schedule right. If all we're doing is taking kind of retrospective fee-for-service payments and stacking that up, and now we're paying that prospectively, I think we really haven't fixed the problem. And so I completely agree with Chris. I think we have to fix the Medicare fee schedule.
But maybe I'm sorry, y'all, let me just jump in. We have to make it sexy. We have to attach AI to it or attach innovation or something like that, because grinding through the fee schedule is not nearly as exciting as talking about tech or talking about AI or innovation. So can we just slap innovative across the front of it and then we'll go to work on it?
Yeah, I'm not going
Tagline.
to. I'm not going to disagree with any of this. I mean, I think if we could pay for comprehensiveness and continuity and relationships the same way we pay for a colonoscopy, I think we would fix everything, right? So I think I'll end with that.
Excellent. I would love it if you would join me in thanking our panel for such a great conversation.
Thank you all so very much for getting us started this morning. Excellent conversation. So we have set the table on what is the state of primary care in the United States. So in a few minutes at 10:30 a.m. Eastern Time, we are going to come back and we're going to examine a law that was passed a decade ago that in part was designed to drive innovation and investment in primary care. Come back at 10:30 a.m. and we'll kick off our MACRA at 10 discussion. disappeared on me. I was getting nervous.
For the record,
I have Tim's microphone. So I'm pleased to welcome you back. So in April of 2015, Congress passed and the President enacted MACRA, a law designed to do a number of things. First and foremost was to repeal the sustainable growth rate. But inside that law were a number of provisions aimed at advancing Medicare physician payment to drive greater innovation in care delivery and efficient use of healthcare resources. So today we have the honor of having a panel of 5 individuals who were all involved in some part of either the drafting, enactment, or implementation of MACRA. And we're going to have a discussion about, did the law live up to its expectations? Is it doing what we anticipated it would do? And what are those areas that may need to be reformed to drive greater innovation and performance into the future? I'm pleased to turn it over to our moderator, Charlene McDonald, Executive Vice President of External Affairs at the Federation of American Hospitals. Charlene.
Thank you, Sean. Thank you for having us this morning. As Sean said, the Medicare and CHIP Reauthorization Act of 2015 was approved by Congress primarily because we needed to repeal the sustainable growth rate that had frustrated physicians and perplexed Congress for over 20 years. But MACRA, as we now know, also sought to fundamentally change the way that we pay physicians under Medicare through the creation of the Quality Payment Program, or QPP, which had 2 primary pathways: the Merit-Based Incentive Payment System, or MIPS, and the Advanced Alternative Payment Model Program, or APMs. This spring, MACRA turns 10, significant birthday. So today, I'm pleased to welcome an excellent panel of experts who either played a role in passing the law, implementing the law, or who are now working to reform the law. So each of us, I'm proud to say, have some battle scars from these fights. And before we get started, I want to let each of the panelists introduce themselves, but I also want to note that this panel will be off the record. So start with Marissa.
Hi, everyone. First of all, thank you for having me here today. Pleasure to be here. Marissa Salemi. I am a Senior Health Policy Advisor for Ranking Member Ron Wyden of the Senate Finance Committee. Primarily my portfolio for the purposes of today centers on Medicare Part B, so any and all clinician payment. And then the other half of my portfolio is Medicare Part C, so Medicare Advantage. I'll pass it to JP.
thank you. Thank you for having me. JP Poliskevich with Alston and Bird. I've been a senior policy advisor there for the last 4 years, but prior to that, was able to do 20 years on the Energy and Commerce Committee, including during MACRA. So served about for 10 years with members who just happened to have a healthcare background, physicians and surgeons. And then the back half of that was both line staff for the Energy and Commerce Committee, and then capped my career on the Hill as Chief Counsel and Staff Director under Greg Walden. Thank you.
Hi, I'm Per Varel. Thank you again for having me here today. Most recently, I was the Chief Strategy Officer at the CMS Innovation Center, but I spent the last 15 years in the value-based payment space, designing models with a special interest in primary care.
Hey, good morning. My name is Tim Groninger. I am the CEO of Hopscotch Primary Care. We are a value-based, senior-focused primary care business serving small towns and rural areas, currently in Western North Carolina. In prior lives, I had policy roles working with most or all of these folks, including Energy and Commerce, CMS, and White House, working on MACRA implementation and other value-based care initiatives.
Thank you. Well, let me start with an overarching question to each of you. I think we can all agree that we achieved our goal in repealing the SGR, and that was an important one. But I think it's fair to ask in 2025 whether the law is now achieving its goals with respect to transforming the physician payment system. So I'm granting each of you the opportunity to engage in some revisionist history here. What did MACRA get right and what did it get wrong? And I'll start with you, JP.
Thanks, Shar. That is a lot of history right there, picking me first. You know, I love that you actually use that term, because I use that term going over, which is revisionist history. It's not, and you could use that term. I think it's more evolutionary history. If you look at all the major reforms to the fee schedule dating back to 1965, it's roughly every 15-ish years, we realize we've got to do something different. And so if you're at 10 years, you're probably at the point where we need to build the political will to do something different. And that doesn't mean you got it wrong necessarily. You solved the problems at the time. So what did we get right? I would argue, and I will be very bold in this statement, and I will still defend a year plus of my life in a room for 20 plus hours a day in some instances, of saying we accomplished exactly what we set out to do, which was get a deal to repeal the SGR, and one that we knew by its very dynamics would spend anywhere from $200 billion to arguably $1 trillion, depending on how you dialed it. Do you know what it takes to even create that room politically? It is near impossible, which is why for 15 years it didn't happen. Because the next inevitable question, no matter who in charge is, where are you going to find the offsets? And so what did we do? We created the room that could have the conversation to repeal the SGR. And one that got 92 votes in the Senate and 392 votes in the House. That is what we worked backwards from. Now, was it perfect? No. I think anybody in that room, of the handful of us that were there, would say, we got everything we wanted? Absolutely not. You know what that's called? That's the sausage making, however you want to describe it, that gets you 392 votes in the House and 92 votes in the Senate. And what did we do? We repealed the SGR. We dealt with all the major complaints at the time, which was the pass-fail nature of all the quality programs. We consolidated them. We addressed the major provider burden issues. Did we deal with everything? No. Are those still problems out there? Are there still problems from what happened? And are some of our visions aspirational? Sure. But that is the continual evolutional nature of physician reform and Medicare payment. And certainly what I would say is we accomplished what we wanted to do at the time and reset the clock, and now it is a natural evolution for the next conversation.
Thanks, JP. Speaking of imperfections, Purva, you spent much of the last decade designing and implementing alternative payment models. So can you talk a little bit about how those provisions in MACRA have changed primary care?
Yeah, I mean, I think, JP, you hit on the right word, which is, I think you used the term evolutionary. And sometimes we're always looking at MACRA or other constructs, what's happening at Innovation Center, what's happening in primary care payment, through the lens of right now, and not thinking about it historically. And so I think this is a really interesting panel because it forces us to look at the progress that's been made. To me, one of the big wins coming out of MACRA was sort of making value-based payment the North Star for how we want to pay physicians. We've been making those kinds of inroads in other parts of Medicare payment policy, but really set that as a North Star, and it really opened up. And I think it put pressure on the Innovation Center in particular, and I think Tim can speak to this from his time there, to create and test more models and to evolve at a faster pace because people needed answers, right? If you wanted to go after that advanced APM bonus, you wanted to be in an advanced APM, you needed options and you needed endpoints. And to me, that is really critical because I would assume, and Marissa can speak to this better than I can, but if we're thinking about how to evolve physician payment further, we're not going to roll backwards on this idea that we should be moving towards value for beneficiaries, value for the system, and simplicity for providers. And so we have a new floor to work from as we move forward in this next iteration of physician payment reform. I think the places where we absolutely have to lean in more is permanence. Models aren't permanent. A lot of them aren't going to work. Pieces aren't going to work. And I think that was maybe one thing that's hard to see 10 years ago is that do we create the endpoints? I don't know that we knew what those endpoints should be, We have a huge body of evidence coming out of not only the Innovation Center, but companies like Hopscotch and others in the Medicare space as well that have been operating for several years. I think we know a lot more about what primary care payment should look like and can look like, and what enables the delivery of advanced primary care in particular. We can use that body of evidence now, both from industry and the private sector and the work that's been done at CMS to, I think, inform what happens in the future for primary care payment.
Thanks, Purva. Tim, you made an interesting pivot from government to the business of healthcare, and you've seen a lot of innovation hands-on. So can you talk a little bit about how MACRA either facilitated or incentivized innovation in primary care?
Yeah, absolutely. So I think there's good, bad, and the ugly of any law, right? And I think JP's point of like the central focus was creating political space for elimination of the SGR. Incredibly good outcome. I worked on 12 SGR bills, sometimes as short as like 28 or 30 days when I was on the Hill. Just a tremendous waste of everyone's time and energy and unnecessary friction with physicians who are the most important stakeholders in delivering care for Medicare beneficiaries. So tons of good. And the other unalloyed good that Purva mentioned, continuing the push for adoption of value-based care models. There's plenty of ways that we can do better in value-based care, plenty of problems to deal with, but the fact is that we now have wired the healthcare system. Congress has wired the healthcare system, has created the adoption of models that used to only be available in places like Kaiser and Geisinger, and a small number of kind of weirdo, quirky IPAs and a few small GOs are now spreading all over the country and putting tremendous resources into primary care practices that didn't exist before. So that MACRA is a big part of that, and so that's like a very good set of social and economic outcomes. On the bad side, I think that moment in time, there was a real straddling of the line between the sort of pay for reporting and value-based care, and members wanted to keep options open and pay for reporting and creating the MIPS program. I think that has trying to split that difference is not working great, and I think that's an area that could be picked up again. I think that, again, in the good category, creating an ecosystem of innovation and creating incentives and business models that can be used all around the country to support value-based care. MACRA is a big part of that. And then in the ugly part of it, that related to the MIPS, just the enormous administrative overhang of the MIPS program, all of the measures, hundreds of measures, most of them, directionally good, relatively good processes to have, but the apparatus required to collect on it, report on it, track it, push it back, update it, maintain it, just a ton of resources that could be better deployed towards supporting the stronger population-based models in the other part of the program.
Absolutely. Marissa, you've now inherited all of these successes and failures, so you're welcome. From where you sit now at the Finance Committee, how do you see the goals of the law and how well we're performing?
Where to begin? So I sit now in the unenviable position of where everyone comes to complain about things. I have nothing but a tremendous amount of respect for the feat that was accomplished 10 years ago, which was eliminating the SGR. It seems impossible, particularly in today's day and age where now we can't even get the 30-day or 60-day doc fix done to hold folks over. So it seems like legislating on this is getting a little bit more difficult, and I should caveat this by saying, again, this is off the record, and I'm speaking for myself and not the ranking member here. But it's so if I were to think through some of the challenges when MACRA was done, then the front end there were built-in updates. On the back end, 0% updates in the fee schedule, which now has us in a very familiar setting of clinicians coming in every year saying they're experiencing a cut, and then a food fight of sorts amongst why these cuts exist. Is it the primary care? Is it specialists, et cetera? But at the end of the day, there's no update, and for 5 years in the law, and couple that with a global pandemic and inflation, and it's physicians are the ones left there going, well, what about us? And to your point, Tim, they are the most important stakeholder in healthcare delivery for, Medicare beneficiaries, and they're sitting there every year having to come in and beg for another doc fix. So it feels very familiar. That is a challenge that we're dealing with sometimes on an annual basis, sometimes on a 30-day, 60-day basis. But we understand why it was done that way. We have to pay for these things, and that's challenge number 2 is thinking through, okay, we want something that is predictable, more long-term, so that physicians don't have to come in, and so it doesn't create this sort of food fight amongst clinicians, and that's going to cost money. So I think when I'm thinking through the challenges ahead of how to address the very acute issues of the fee schedule and an update there to the more holistic issues of administrative burden that was added through MIPS, which is adding to not just administrative burden, but also like workforce burnout. I think many people understand that, as well as how do we continue on the road to value and make APMs accessible to everyone, including those in rural America, including, specialists that want to be more involved in alternative payment, in value. How do we create that holistically? These are some of like the broad strokes that we're thinking through in terms of where to go next, but I think it's a really natural juncture, to JP's point, to be at. It's now been 10 years since MACRA. I can feel the momentum building. It's like a familiar, like, time to look at this again, time to do something here, because at the decade mark, you naturally are going to see some of the tweaks and things that need to be fixed so that we can make it more predictable. And I will add on my boss's behalf that I think looking at the Medicare program now, particularly traditional Medicare, he feels very inclined. I think the chairman of finance also wants to address chronic care issues and wants to do that in traditional Medicare. The Chronic Care Act primarily addressed that in Medicare Advantage, and looking across at traditional Medicare, ensuring that it doesn't get left behind. It's how can we more appropriately address some of the chronic care issues in folks that choose traditional Medicare. And I think a lot of that is APMs, primary care, and ensuring that that is trued up, and that will be done through whatever the next iteration of physician payment MACRA is.
Thanks, Marissa. Well, we appreciate all of the work that you're doing to manage stakeholders through this process, and I think we've all been there in one way or another, talking about physician payment and those challenges. From where you were at CMS and the Innovation Center and actually developing these models, what were some of the biggest challenges that you faced?
Yeah, and I was there at the, more the tail end of the most recent years of MACRA implementation, which probably looked very different than some of the early years. But, I was there starting in 2021. And I think the complexity of not only the law, but really the regulatory complexity at the agency was I felt that very significantly. You also, the way that the law ended up getting implemented, it was broken up. And, that's a little bit of inside baseball, but it really does matter for being able to execute on policy in an aligned way. And it makes it much more difficult, I think, to emphasize and to execute on simplicity, which I think is one of the core issues with MACRA implementation. So for instance, like the MIPS program sits in the, in one part of CMS. The shared savings program is the largest value-based care payment program in the country, the largest APM in the country. That sits in the Center for Medicare. And then you referenced, when you laid out the different pieces of MACRA at the top, Charlene, you mentioned the QPP, right, which is where all of the advanced APM work sits, and that sits in the CMS Innovation Center. So if you just think about the regulatory complexity and being able to execute on an aligned kind of set of policies, it's very, very difficult because you have 3 different centers, 3 different teams. going through annual rulemaking. And so from my perspective anyway, just being able to get a handle on where we are, what do we want to accomplish as an agency was challenging. I will say the CMS leadership at the time, that was one of the goals that they put out was let's bring all of the key people together across the different centers within CMS, and what is, within our statutory mandate and constraints, what do we want to accomplish in the next 2, 3, 4 years? How do we, again, within our, our statutory mandate, what are some of the key issues that we might be able to solve for? And how do we keep using MACRA as a push towards value? And that honestly isn't like something that can be legislated. That is, I think, about leadership and just an understanding of how to try to inject simplicity and coordination into the regulatory process. But to me, that was just one of the most challenging issues.
It's a great point. Certainly not everything can be legislated, and this is incredibly complex. And I think one of the biggest challenges for those of us in DC is figuring out how this policy translates to people on the ground that are actually delivering care. So Tim, as CEO of several primary care organizations, can you talk a little bit about how MACRA has impacted physician practice day to day?
Yeah, I think that there's a couple of different dimensions in which these policies come into light in running a primary care practice or running a practice participating in Medicare. It's a specialty practice as well. So every practice every year needs to assess whether they're going to engage with any of these quality reporting programs, how they're going to do it. And the sort of baseline, the simplest way to engage is just to look at the MIPS measures, the merit-based incentive payment system measures that are very, it's based on an old quality reporting system. You can choose several measures. There are measure sets you can choose. If you're primary care, you might have measures related to managing diabetes or managing statins or screening for depression. If you're an orthopedist, you might have measures that you can choose that are related to communicating about patient care plan following a fracture, documenting certain types of medications. These are pretty simple process-based measures. And this is really my big issue with MIPS is like there's a lot of process requirements that get very little bang for your buck from a social public perspective, but still require documentation, still require purchasing vendors. Usually do this. Track it in your EMR, document appropriately, make sure that you're following the right workflows, track it over time, and you report it to CMS through various channels. And in the following year, the measure will be sort of data wrangled, reports will be spit back out, and your payment might be plussed up or taken down a couple of points. Usually not very much, although there is some sort of black box algorithmic work going on in the background that it feels and is quite unpredictable for the physicians actually working on this day to day. The more interesting and exciting things about how you might engage with these programs would be if you do decide to join a practice transformation model, so an advanced alternative payment model, most commonly an accountable care organization. So you as a primary care provider raise your hand and say, I'm working with this team of physicians right here, and we're teaming up with this set of physicians over here, and maybe we're working with an enablement company like Alidate or my old business, Caravan and Signify, and we're going to be taking responsibility for the set of Medicare patients that are attributed to us, right? And so we are going to be collecting data on these patients. We're going to be hiring 2 nurse care managers to help us navigate care transitions for these patients, and we're going to be telling CMS on a phased in or an immediate basis, like if these patients cost the government too much this year, we pay back a part of that, or if we save money versus the benchmark, then we collect some of those savings, right? And so through that, you can check the requirement for the MIPS QPP program, and that has led to a ton of innovation. There's hundreds of companies in this space. There's tons of investment on the private side happening in primary care practices, happening in specialist practices, coordinating with these payment models. There's a whole bunch of flavors of that. So I could talk about this for a long time, but this has motivated a ton of behavior change in the real world and gotten a lot of attention to prevention, to vaccination, to chronic care management, a whole bunch of work in sort of traditional Medicare that didn't exist 15 years ago.
Can I add one other thing, Shar, that made me, I thought of this as Tim was talking. I think one of the other near-term challenges that we were facing at CMS and the Innovation Center in particular was as that advanced APM bonus started to ramp down and the MIPS payment adjustments started to get wider, we were hearing more and more that the value add of coming into an APM or alternative payment model may not be there. The business case may not be there, especially for high-performing entities that can get the +9% or do very well in MIPS. And that's where, you know, the glide path was set out. It is very logical. Things don't always work out the way, you know, move at the pace that we want them to move, especially in healthcare. And so I think that's one thing for the future state that, you know, we don't want to keep chasing and finding dollars. And I worked on the budget committee for years, so I understand how this feels like, you know, finding the money for the next AAPM bonus. You want a longer term solution, but making sure that we're setting up the incentives to make it a very logical choice for folks to go into the APMs and into the greater, you know, more into the value side of things, I think will be important moving forward.
Just a quick coda on that. The incentives matter a ton, very obviously. People, practice leaders, physician practice leaders, those affiliated with hospitals, look at all of this on a spreadsheet and say exactly as Purva said, the advanced APM bonus was 5%, is 3%, MIPS looks larger or neutral. Like, is it worth it to invest my team's time in doing this work? The APMs are harder, but they're more impactful. So it's important CMS and Congress pay attention to that differential.
Well, let me bring it back to the guy who created these incentives, JP. So you were there in the beginning, and you've been working on this in the years since. So how has your thinking evolved, and how are you advising clients on this law now?
Yeah, I mean, I think, again, I would start with, what does a unicorn look like? I know my 5-year-old could draw me a picture, but that's really what we were creating, was unicorns. We want to do things better, faster, smarter, cheaper. We want to do things that are not fee-for-service. You've got to, again, realize this is a 2015 law that was primarily written in 2013, negotiated in the first month of 2014, and then offsets hammered out, right? Like, and then it sat out there, for a year, and then we were like, hey, this fish has been laying out there for a year. How bad does it smell? And people are like, we're still pretty cool with it. Like, great, shark can help find the offsets. But my point of all that is, all we were saying is we were creating unicorns, right? We were dealing, first and foremost, deal with the problem that we had at the time, try to make it better, try to address all the physician concerns we heard at the time, and then try to do things better. But we didn't know what that was. 2013, we had first generation ACOs. That's it. The closest thing you would say to like, what does a value-based program that is officially approved by CMS look like? That's it. And I think if you look at that today, you'd be like, well, that's not the way the world works. Of course not, against the evolution. And so when I talk to people, and when I work with my clients, it is, look, this is an evolutionary thing where we wanted to open the door to create unicorns, right? This hope that we could do things better, that we could pay for value, that we could allow providers, allow these organizations, these groups, these companies and providers to come together and be given the tools and the financial incentives by which to reward not just doing things, but doing the right things at the right time in the right place. And open the door to creating all the clinical data registries, sharing information, being able to focus on appropriate use criteria, get that value-based information out there. And so what I look at now is how do we build off of the door opening? So this is very not me, as almost everybody knows, I'm usually can be the pessimistic person when I'm talking about Congress. I'm very optimistic in that the door got open, we did what we needed to do at the time. How do we build from here? And if we're all drawing our picture of a unicorn and say, hey, this unicorn is not looking so great right now over this space or this space, it's not that the unicorn's drawn wrong. It's like, how do we build the better unicorn? Now that we have a better idea of what a unicorn can look like, and we have 10 years of experience, how do we build off from there, and how do we empower physicians and others to be able to embrace value now that we've walked through that door? Because we're not going to go back, and everything does evolve, everything does change. Realize that, and how do we move forward together?
It was an incredible opportunity 10 years ago, and I think a rare one for bipartisan legislating. Marissa, you're now sitting in Washington at a very interesting and very noisy time for policymaking. So what do you see as the opportunities to address some of the things that we're talking about today and legislative opportunities perhaps this year?
Sure. Well, First of all, I'll speak momentarily to sort of the moment we're in, which is, the calendar and agenda set forth currently is, very partisan process, reconciliation, and is geared towards, in some way, shape, or form, paying for tax cuts. So the process that is currently playing out as it relates to healthcare is quite partisan, and, I don't believe will be addressing any of the challenges we're talking about today. But, I think the hope is to pick up where Senate Finance Committee left off last year, which is, we held a hearing on chronic care and physician payment reform, followed by a white paper looking at some of the issues that have cropped up since MACRA, and follow that with legislation. I said this earlier, I can feel the momentum building on this issue, maybe in part because, at the end of last year, when there was a bipartisan healthcare package, and then it got completely torpedoed by a tweet, and a lot of doctors are still out there going, wait a second, now we have this 2.83% cut, and we still have inflation, and we have all this other stuff, and what happened to that bipartisan bicameral healthcare package? And I think many people would say, let's pick back up and do the bipartisan work again, and number one on the list is probably addressing physician payment and making docs whole. And I think our hope on Senate Finance is to look at MACRA and address it more holistically. Obviously, the fee schedule has its issues, which was part, the differential updates are about to happen, but the APM bonus has gone away. And so, how do we deal with that? And how do you make it more attractive to go into value? And I'm going to steal a line here from Liz Fowler, but, how do you make MIPS the launch pad and not the landing spot? How do you get those levers right and those incentives correct so that more can participate in value-based care, and which we know is the bailiwick of a lot of primary care writ large and alternative payment models, but address chronic care and make sure that clinicians can meet their patients' needs in traditional Medicare. It's going to be tough. I will say, I think, and please, JP, you will know the number, but I think there was about $140 billion that was written off during MACRA. I don't see that happening again today.
There was some
130?
There was some creative CBO letters.
Yes, creative CBO letters. I'll go with that. I hope I can get some more creative CBO letters at some point. But I'm not sure we're in a world where that passes muster again. And so, yes, I think there's going to be an appetite to address this. I hope we return to a bipartisan stature soon. I think given the recent agita around not getting physician pay addressed in the last couple of healthcare, in the last couple of end-of-year packages is going to add to that momentum. What pays for it and how big does it look? Does it really address APMs, MIPS? Those are all questions left to be answered. I think from a finance perspective, we would like to pick up right where we left off from our white paper and see legislation that addresses all of the challenges that we've discussed here today.
That's encouraging, Marissa, in some ways. I will say I'm not sure how it passed muster when we did it either. So there are always those challenges with offsets, but we do hope that you'll find some opportunities this year. Tim and Purva, if there is that opportunity, whether it's this year or in the future, what are some of the major changes that you think are important for Congress to consider that with respect to primary care?
I guess a couple things. I would think about it a little bit thematically. So I think simplicity. Just listening you talk about the choices that individual docs, practices, companies have to make, the entire kind of MIPS quality measure construct. I think simplicity could be one of those things that guides every step of what we do legislatively, but also on the regulatory side. Is there a simpler way to do this? Are we removing burden from providers? And is this meaningfully going to change something for a patient? Because I think we lose that in a lot of our discussions, but at the end of the day, that's what family physicians are doing every day. They are seeing patients in their communities, and whatever payment construct or value construct we put into place should support and enable those relationships. That's really high level, but I think those kinds of guiding principles are really important and things that honestly are probably pretty bipartisan as well. I think, again, impact, and thinking about whether or not the changes are going to impact what I always say, the end users of the health system, right? Again, the providers and the care teams and patients. And then I'm always on the value train, so I think whatever we do has to continue to emphasize and make clearer that value-based payment is the North Star that the system is working towards for all physicians and clinicians. I think primary care is out ahead on that relative to others. Even though a little under half of primary care practices, I think a couple years ago, the Commonwealth study showed that are still not in value. That's a lot more than specialists. And so I think there's a lot more that we can do in the primary care space in particular. And then the last thing I would say is I don't think we can treat primary care APMs in the same way that we do specialty, for instance. I know, a lot of primary care docs are in ACOs. Primary care is the foundation of the ACO construct and should continue to be. But the payment needs and the work that primary care does is distinct. We, again, have learned a ton about this over the last 10 years through testing CPC, CPC Plus. And JP's right, in 2013, you had one or two innovation center primary care models. And since then, there's been a ton of evolution in terms of those payment structures. And so I think we really have to take those learnings and, think about a permanent hybrid payment option for primary care, right? That might be a way that all primary care docs should be paid. A net investment in primary care, but really those things that enable flexibility in care delivery and enable team-based care, which we know lead to better outcomes. And honestly, they help workforce burnout and stress. We saw that during COVID for those practices that were in these kinds of payment models. They were able to keep their doors open, and they did it with a lot less stress.
Yeah, I would endorse many of those recommendations. I would think about this in the categories of investing in what's working well, and a lot of that is primary care models, a lot of that is population-based models, so ACOs, kidney care models, some models that have been built around some very sick populations that put a lot of the risk on providers to manage it effectively over time. Continue to grow those and continue to try to bring in providers, patients into those programs. Redirect resources where we are having a lot of friction, administrative waste, overhead, the MIPS program, broadly speaking. I would think of I think it's really important to get specialists right and to have appropriate ambitions for specialty models. Fair does not mean equal. It's not going to be the same. And we're in a primary care room. I'm a primary care booster. But we really need to think about making sure that specialists have a good pathway for cooperating with ACOs, for instance, in a way that recognizes their special contributions to patient needs. And I think part of that, these big pictures thematically, to Marissa's point earlier, of investing in chronic care management in the fee-for-service program and fixing some of the rough edges of original Medicare that are really showing in contrast to effective Medicare Advantage and effective REACH direct contracting models, for instance, that I'd like to see spread more broadly throughout the original Medicare program.
Thanks, Tim. Well, we have a captive audience in Marissa here on this panel. So I thought since we all have some experience going through this before, if we could go down the panel and each offer a lesson learned from our experience in either developing or implementing MACRA. Well, JP, I'll start with you.
Thanks, Shar. First out of the gate. I think the lesson here is big things are possible, and they do require kind of opportunity. Look, I would love to say we have the solutions. I think we have better solutions, and we're always having better solutions. How do you build those evolutions into the trade-offs that come with a political process, right? And I think that's what we have to navigate, is we now have a better idea of what the unicorn looks like. We can build a better mousetrap, whatever. And, I love talking in analogies. Whatever you want to use, great. How do we fit that into a political process? And that as challenging as things might be, there are these windows of opportunity that do arise where bipartisanship is possible to solve big problems when the momentum is there and the direction is also agreed upon by both sides. We may not have solutions. We may just have trade-offs, right? But we want to move in a better direction. We want the launch pad, not the landing pad. We want to move forward. We don't want to be left behind. We don't want unintended consequences, and we do not want to have either regulatory or legislative burdens to be able to evolve to the next thing. So I think the biggest lesson learned is that this is possible, that we open the door to value. There is so much opportunity that has already been realized, so much opportunity to be realized, but it's how we work together to then team up and work on both the regulatory and legislative side to be able to make sure we continue forward.
Yeah, I mean, I think I'd go back to a little bit of my previous answer around like an aligned vision, right? And when you're able to get bipartisan work done, and I think we've all worked on the Hill at different times, you have to have that aligned like vision, whether the North Stars, we want to evolve, get further into value-based payment, we want to solve for X, Y, or Z, just having some of those core principles that everybody is aligned on and working towards. The details often end up becoming horse trading, or they are trade-offs and they're important details. But the market signal and the signal you're sending to the agency and the signal that you're sending to physicians and patient and beneficiaries out there is really important, and that comes from that really comes from, I think, the vision and an overarching goal for where we think the system should head. So I think that's probably my big advice.
Marissa doesn't need advice from me. She knows where to find me. So this is addressed to all the other staffers on the Hill that aren't on the panel today. Incentives are like first order approximation are everything. And so obsessing about the incentives you're providing for physicians in participating and working with Medicare is like the 95% of what's going to make or break the success of this for patient outcomes, for budget outcomes, for everything that we want to see, for all of the unicorns that we are trying to build together.
Thank you. Well, I'm going to take moderator's prerogative and answer my own question as well, but and kind of echo what JP said. But I think there are those rare moments of opportunity. But I think the reason that we were able to get something passed is because the committees were ready, and there was so much work, as JP said, in the years before we actually got to the point of legislating that was so important, and the dedication and hard work of those staffers who sat in those rooms and deliberated and negotiated even before there was any real prospect that anything would move on the floor was what was so key to the moment when we discovered those offsets and discovered that opportunity, because we knew we had to move quickly. When you're in that situation, it is very easy for things to get bogged down and for that moment to pass. But thanks to great committee staff, which I know we have again today, who made that possible, there is a chance to change the system. So thank you. I want to say thank you to this panel, and thank you to all of you for your work on this issue over the years. And I will turn it back to Sean Martin.
Thank you all so much. Outstanding panel. We're keeping the programming going. We're going to pause. We will be back at 11:30 a.m. Eastern Time, and we're going to pick up another innovation that actually came to be in around 2008, 2009 that is transforming primary care in many communities across the country, and that is direct primary care. So come back at 11:30 a.m. Eastern Time for an outstanding panel on DPC. Thank you. So welcome back. As I said before the break, our next panel is going to take on an innovation in primary care that really became into the practice model in the late 2000s, 2008, 2009. Although there were innovators before that, the model grew in popularity and certainly grew in popularity amongst primary care physicians and their patients, and that's the direct primary care model. So I am pleased to welcome Jay Keese, who is the Executive Director of the DPC Coalition, and our outstanding panel to discuss this innovative and thriving primary care model. Jay.
Thanks, Sean, and thank you for having me here, and thank you for holding this panel. I think this comes at a really, really important moment, and I'm glad we were able to follow the great panel that went before to talk about MACRA and MIPS and all that. I mentioned to some of the panelists, they made those rooms. I went in and out of them a couple of times as an advocate and as a lobbyist, and I still have PTSD from that experience. But we're really excited to be here today. As Sean mentioned, we have an excellent panel. And a little bit of background about me, and then I'll introduce our panelists. I'm really here because Sean put it, back in 2009 when we were putting the Affordable Care Act together on Capitol Hill, as a lobbyist, I run the firm Capital Advocates here in Washington, D.C., which is a lobbying firm and a healthcare policy firm. Dr. Garrison Bliss came to me, who was the founder of the first direct primary care practice in Seattle, Washington, which became a group known as Q-Liance. And he said, we have this great model in which we create a relationship between the patient and a primary care doctor, and that relationship is paid for directly by the patient with a monthly fee. And this Affordable Care Act is going to require everybody to get health insurance, and primary care is going to have to be paid for by health insurance, and that's essentially going to put us out of business. So and he said, well, you got to help me stop this thing. This Affordable Care Act thing is going to really destroy this beautiful model. And I said, well, we might probably not be able to stop the thing that's rolling down the tracks right now, which was about to go into committee for consideration. But we might be able to amend the bill to figure out a way to put a provision in the act that allows you as the primary care, direct primary care medical home for a patient to cooperate with a qualified health plan to bring a really comprehensive benefit to everybody. And so, we did get that provision in the Act. It's in the Act. It's sort of the first place direct primary care was defined in federal law. There had been a law that preceded that in Washington State that allowed Garrison Bliss to do what he did. But the model has grown by leaps and bounds since then, and I'm really pleased to have two key members of the direct primary care movement here with me today. To my immediate left is Fritz Bush, who is a principal consulting actuary with Milliman by day and a gentleman farmer by night. You may ask, why is an actuary here to talk about direct primary care? Fritz worked with the Society of Actuaries to put together the first and the major significant study around direct primary care in 2020. And so he's going to talk a little bit today about data and what that means to direct primary care. And I will say, when I walk into somebody's office, either at the state level, and we've passed legislation in 33 states, 34 now states around the country that defines direct primary care as a medical service outside of fee-for-service insurance reimbursement. It's not regulated by an insurance commissioner. The first thing they want to see is the data. Show me the data. So it's really important to talk about that, and DPC has some challenges with that, but we've really broken through that thanks to a lot of the work that Fritz has done. And then sitting next to Fritz is Jeff Davenport, who is a direct primary care doctor from Edmond, Oklahoma. He is also president of the DPC Alliance. The DPC Alliance, where the DPC coalition that I run is about public policy to advance the cause of direct primary care and getting rid of the regulatory and policy roadblocks. The Direct Primary Care Alliance functionally is there to mentor people about what DPC is and to help DPC grow by making DPC doctors. And so we're really excited to have Jeff here to really give you a firsthand experience about particularly the small direct primary care practice, the individual doctor or the smaller practices that are growing around the country. And I'm excited that this afternoon we have a panel on direct contracting, and another one of the members of our organization, both of our organizations, Clint Flanagan, is going to be here to talk about how direct primary care works in a larger scale model with employers and other constituents that want to pay for a direct primary care benefit to create that relationship, that value equation. When we're talking about value-based care, we see DPC as this, very different value equation. Rather than paying a physician a fee to do a service to you as a patient, and I will speak as a direct primary care patient as well, the value equation is that the fee is paid in a monthly basis to create a relationship with a direct primary care provider, physician, and that relationship, in my opinion, as both a patient and a government affairs strategist and a policy expert, is where the magic happens in the policy. So I'm really excited about that. So I thought I would start with Jeff, and what I'd love you guys to do is maybe take 5 minutes and just extrapolate, your experience. What does DPC mean to you? Really keep it on a patient focus. What does it mean to your patients? And then we'll move to Fritz and talk a little bit about what the data says.
Hi everybody. Thanks for having me. I'm Dr. Jeff Davenport, Edmond, Oklahoma. I've been in direct primary care, my practice, for over 11 years now. So even as a resident back in 03 and 06, 03 to 06, they were teaching us how to do coding and billing while seeing patients. I mean, first you have to learn how to take care of chronic disease, kidney disease, and then you have to figure out how to get paid for it. And I just didn't understand, why are we dealing with insurance in primary care to begin with? But it was the way the world was, so I had to learn it. So I really became an expert. My senior lectures as a third-year resident were both on coding and billing, how to get paid better for the work that you do. And so I came out of residency just an expert in tracking what I do and getting paid for it in the old system. And yet it didn't take me very long to realize that this still is no good, because I still love taking care of patients. I hate coding and billing. And I also feel like this is running my life and affecting my patient care worse. And so when I speak about direct primary care, I speak from a physician perspective so much. And yet most physicians, I know contrary to maybe popular belief, but most physicians actually care about the patients. And so if we can figure out ways to help take care of the physicians and allow them to take care of the patients, then the patient's experience and outcomes will be better, period. So at some point I heard about this model and I transitioned to it. And rather than seeing 25 people a day, I see more like 6. Rather than 7 minutes of face-to-face time with a patient, my short visits are 30 minutes. Rather than doing this, what was that again? And just typing into a computer all of the time, I'm more like this. All right, tell me what's going on. And so when I recognize those changes in my own practice, in a direct primary care practice, the patients have to have better outcomes. I always joke around. Even myself, I have a new direct primary care doctor for myself because I've taken care of myself as my own doctor for so long, and I thought, I got to get a better doctor. So I pay my own direct primary care doctor now, but what I recognize is that the patient's outcome and satisfaction and access to the direct primary care doctor is significantly different than the way it is in the system. And so those are just a few. I have 600 patients where the traditional family doctor has about 3,000. So I like to say, back to get a better doctor than myself, look, you can find better doctors than me out there. I'm just a redneck from Oklahoma. But who's better? Me with 7 minutes, or me with 30 minutes, or 60 minutes? And this is not hard, comprehensive calculus here. This is the doctor with time is going to do a better job, period. So that's kind of a short picture of direct primary care in my practice.
Yeah, that's great. And I mean, I think it's fair to say a lot of folks have come through your experience as well. When we look at the members of the Direct Primary Care Coalition, we have two big groups. And I'd say the biggest group are students and residents that look at this as, hey, this is a great way, this is a great model. We'd like to get into this model. It feels like what I'm going to take the skills I'm being trained with here in my medical education and go out and really use them. The second group, I think, is people that have, physicians that have been through the ringer in the fee-for-service environment. I hear the term hamster wheel used a lot, that are nearing the end of their careers and say, well, if I could do it this way, perhaps I could do it a little bit longer or a lot longer. So I think that's just an interesting, anecdote. It's not a fact, not data. But so we have an actuary here, and you have authored, Fritz, I think the most comprehensive study on direct primary care to date. Tell us what DPC means to you and maybe what it means to employers and their employees, their patients, perhaps filling in some of that story with the data.
Data's overrated. Jay.
Amen.
Just kidding, yeah. I get that a lot. Well, interestingly, Jeff and I were talking previously here, and we got introduced to DPC by the same person, different modes. Josh Umber is a DPC physician. He did a session at a Society of Actuaries meeting that I went to, and I saw DPC, and I said, this is it. This is, I think, something that is going to make a huge difference in healthcare. It was an opportunity to really apply some skills and feel like you're actually going to affect some change. That's how strongly I felt about it. So I started to hang around DPC conventions. I would just crash the party, and the doctors were very nice to me. They wanted to know why I was there, but they welcomed me in. So we immediately started looking for data because this is, at Milliman, we have our hands in all manner of the healthcare space. But one of the things that we do is we do evaluations of delivery models. We do evaluations of point solutions. And we set up these studies and we make them data-driven and things like that. So we immediately started looking for the data. And we did find an employer, a rather large one. And we, as Jay said, we did do a study back in 2020. It's if you put in my name, Society of Actuaries, and DPC, it'll pop right up. And basically, that study was a single employer. It was reasonably large, about 1,000 DPC members and about 1,000 non-DPC members, so nice cross-section there. And it did show savings. It showed savings that make sense, that you can attribute to the model. And so I think, we're right in the middle of another one of those studies now, one that's considerably bigger, probably about 5 times bigger. So DPC has been challenged with the data because it's small. And it's growing, but the data is now accumulating, so I think we're going to be in a good position to do that. But I wanted to echo something that Jeff said, just again, from a number standpoint. I love the partnership that we can have because when I look at the numbers, I just see the numbers. But getting the insights and the stories, this is one of the things we want to do in our new study, is getting people like Jeff and others, Clint, you'll hear from him later, to say, well, this makes sense because this is what we do. Here's a great example of that. And anecdotes are data if you get enough of them. So that connection between, and Jeff said, oh, I'm not a numbers guy. Okay, well, perfect. Or we're like Batman and Robin or something. Right. Yeah. So, really getting that data and then understanding it from the model perspective. And I would say 2 things, since, I don't know, maybe there's some people here who are not as familiar with DPC, but Jeff mentioned this. The distinctive with DPC is, number 1, the decision to limit the patient panel. So I hear the same number, 2,500 maybe is the average panel. Maybe you get down to 600, 800. I've heard a little bit higher than that. Depends on the needs of your population, I'm sure. If you did Medicare, you might have to go lower or whatever. So you immediately solve the access problem that so many people have seeing their primary care physician. Same-day appointments, next-day appointments, things like that. And they can come as much as they want. The second thing is they get rid of the insurance billing, so all of that admin time and effort goes where? Well, it goes to the patient. So now you have more visits and you have longer visits. You multiply those two together and you're just basically talking about more primary care, which isn't that what we heard from several of the panelists this morning that that's the goal. More primary care is good. It leads to lower costs. So direct primary care is really setting the model up to go directly at those two pieces. And that's really the essence of it and then it gets to the relationship. So it just leaves more time to build those relationships. So let me pause there and you can keep going.
Well, that's great, and it actually leads me to another question, and maybe I'll direct this at Jeff, but Fritz, feel free to chime in as well. So we're creating a model that functionally reduces patient panel size, lets you spend more time with a patient, and we are jumping headlong into the middle of a primary care workforce shortage. Yep. How does DPC address that?
Yeah, so I get this question all the time. Well, if you only take 600 patients, how does that help the other patients that you can't take care of? And I can get pretty antagonistic about this. I mean, we have an entire workforce of primary care physicians who are retiring because they just can't take it anymore. Also, it's a very serious, I'm not joking, I'm not being grandiose here, but physicians kill themselves too. It's a very serious problem in our country, not just primary care, of course, but all specialties. How many patients does a dead physician take care of? And so if once again, I know that we want to look at it from a patient perspective as well, but I think we have to look at it from a physician perspective as well, is if those people retire, if they go into another specialty, if they start building cabinets instead of practicing medicine, if they start another business, how many patients are they taking care of? On top of that, there's so many aspects of our current society in medical care that are there because primary care is failing. Why do we have urgent cares on every corner? Mm-hmm. It's because they can't get into their family doctor or their pediatrician or whomever. Okay, great, we can see you Tuesday. Well, that's helpful because today's Thursday and I'm sick. Okay, well, they go to urgent care. I'm not insulting urgent cares. I'm glad that they're there. They're providing a need.
Purpose.
They have a purpose, yeah. And then on top of that, I even start talking about all of the different specialties. Here at the Direct Primary Care Alliance, we are educating physicians. And one of the things that has really come to fruition over the last year or two is recognizing that the Direct Primary Care Alliance is not a family doctor organization. The DPC Coalition is not a family doctor organization. It's a primary care organization. We've got pediatricians, we've got internal medicine, we've got med peds, we've got geriatrics, we've got functional medicine, we've got lifestyle medicine. We've got emergency room physicians who are done with the emergency room who want to do primary care. We've got surgeons who are done with doing what they do. Now, we need all those specialties. We can't turn the whole world into primary care, but when you talk about, is there gonna be a primary care shortage? Imagine if all of these different specialties, hematology, endocrinology, all of these different things, imagine if they already seeing a chronic kidney disease patient literally every 3 months, what if they also ordered their colonoscopy? Ooh, that's hard. I mean, there are some primary care things that they will have to brush up on, of course, but they're already taking care of these patients to a very high level of care. What if they just added a few other things and created some of their own primary care patients? So I really don't believe there's going to be a primary care shortage if this model continues to expand.
So you're sort of saying, build it and they will come. You build a better ballpark and we're going to fill the seats.
And I have an anecdote. This is a real life anecdote. I was at Hint in last summer, and I was sitting next to a physician, and they were saying, "You see that person over there?" And it was a woman, and she said, or the one next to me said that she used to be an engineer, and she went to a direct primary care physician and signed up and had been there, and switched careers. So direct primary care was responsible for, I mean, it's like it's a career switch destination. Wow. So that was a powerful example for me that if you provide the incentives, yeah, if you build it, they will come. You provide the incentives, people are going to respond to the incentives. I mean, Jeff, you can check me on this, but I would bet that it would only take a couple of cycles of grad school graduation rates to go up because they've heard of a better model that doesn't give you burnout, that allows you to care for patients. The more they hear about this, the more that graduation, or that, what is it? What do you call it when they, anyway, they'll go into primary care. That it won't take that long to bring that number back up if this model does flourish.
Well, and Jay already described one of the largest portions of your organization is medical students and residents, right? So,
in fact, I have to say I'm going to call out Phil Eskew, DO, who is not only a great primary care physician, but a lawyer and an MBA as well, and runs Direct Primary Care Frontier. And he actually serves as the general counsel for our organization, so he wears a lot of hats. But Garrison and I were walking through the halls of Congress. I think this was 2009 or 2010. He was a fellow at the Graham Center in his residency, and he followed us in his white lab coat for the rest of the day, and has essentially dedicated his entire life to try to forward direct primary care, and I think that's just a great story. I do believe this, and I think there's a couple of policy levers, which we'll talk about a little later, that we can pull and make some changes, and I am a believer that at some point we've seen a growth curve of DPC that looks like this, but I think we'll get a hockey stick if we do the right things over the course of the next 18, 20 months in public policy. One of the biggest misnomers out there about DPC, though, is, well, this is just concierge care. It's just for rich people who can afford it. And I would say we have a bill to try to figure out how to do DPC in Medicaid, and we've done it in Medicaid. So I dismiss that notion just based on the idea about, how much it costs and the rich aspect. But there's other aspects to concierge. Jeff, help us distinguish between a concierge practice and your practice.
yeah, so there are technical differences. Technically, for direct primary care, by definition, there's no specific price point. You could charge $20,000 a month and still be direct primary care. But logistically, realistically, most of us charge what we consider an affordable price. Now, what does affordable mean to you or me? I mean, there's kind of a common notion of most of us for a family plan are in the neighborhood of, I can't name a price, but I can say, what about a cell phone bill? Does your family have a cell phone bill? Then most direct primary care doctors kind of fall in that range. And so that seems to most of us to be pretty affordable. So technically there's no price limitation, but most direct primary care doctors are affordable versus a lot of the concierge practices tend to be on the higher end. There are some other technical differences. A lot of concierge programs, without naming any names, they basically, their contract with respect to Medicare and things of this nature, they sell you non-Medicare covered services, which then allows you access to the provider. And then the provider still bills and collects insurance and co-payments during each visit. Most direct primary care doctors don't charge anything at the time of the visit. Now there are some that charge a nominal fee, but most of us, it's a membership like a gym or Netflix. We have a product. Do you like the movies we're showing on this streaming service? Then you pay the price. If you appreciate the product, then it's a good relationship. But by definition, we don't take third-party payers currently. No Medicare, no Medicaid, no insurance. And so those are some of the technical differences between concierge and direct primary care.
Can I elaborate on just one thing? The concierge and the DPC models, I think, do share, and you touched on this, they are a product, right? This is one of the few, DPC is one of the few, if not the only, aspect of healthcare coverage that's under a major medical policy that can be and is subject to true market forces. And concierge is the same. You can either choose to buy it or not buy it. Here's the product, and they put it out there, and this is what it is. the price point, relatively speaking, we've had several conversations about overall cost. The price point of $70 is going to be more than you would otherwise pay in fee for service. But the idea is better primary care does what? It reduces costs downstream. Right. You've got short-term, mid-term, long-term costs. We don't have to get into all that. But that's the whole idea behind it. Pay up front. And we've heard several conversations about, we spend 3% or 7%, depending on how you measure it, whatever how you define primary care, it's way too low. And one of the things that direct primary care does is it basically says, look, you guys are talking all about paying us more. And there's a lot of talk. We're just going to do it. This is the fee. We're going to get the fee that we think a high quality, high access primary care delivery model deserves. And you can buy it or not buy it. So that's the way DPC, I think, gets at this underinvestment problem that several of the other speakers talked about.
Yeah, and I think one of the themes of the first couple of panels today was, hey, primary care needs to be paid more. I think certainly primary care physicians agree with this. I think specialty physicians probably agree with this. And certainly, as we can see from the last conversation, policymakers agree for this. So functionally, I think DPC does provide a vehicle to allow for a higher payment for primary care, and employers really want to do this. So Fritz, I know you worked a lot with the employers. Talk about some of the experiences employers have had. And Jeff, for instance, doesn't take an aggregate payment from anybody else but the patient. And there's lots of different ways to sort of skin this cat. But to put a fine point on the legal difference between DPC and a concierge practice, too, a concierge practice is essentially a fee for a non-covered service, as you mentioned, like an executive physical, whereas DPC is actually payment for primary care services that are a part of a contract, which is a DPC agreement. So, and to your point, regardless of price, the reality is you're in a market where if you don't have an affordable product, they're going to go somewhere else. But again, going back to employers, I think employers really like this idea because I think, among other things, it kind of fixes their costs. But what's the employer experience?
Well, obviously we have I think it's 150 million, people covered by employer-sponsored insurance. A significant portion of those are self-funded employers. They're on some form of risk. So they are very interested in, all manner, really, of point solutions that will help them to improve their costs and their patient outcomes. I listened to a call maybe a month or so ago, and one of the speakers on the webinar said that there are now, I don't know how he counted this, but 470,000 different VC or PE-backed healthcare point solutions that exist right now at various stages of funding and what have you, all the way up to IPO. 470,000, right, vendors out there who are basically looking to improve the system. Their target market is employers, right, and payers, obviously, but heavy on the employers because many employers, they're paying the checks. They're writing the check. If you're self-funded, you're just paying the check every month that comes in, and they want to pay less. And the system that they have now, they continue to see the increases every year. So they're very interested in anything that will help them do that. And so, direct primary care is one of those widgets, right? I think it's the best of the widgets, if you want my personal opinion. But it is very compatible with an employer-based plan, especially a self-funded plan, because if there are these downstream savings, and there are, the employer will reap that. And so it obviously appeals to them. There are competitors, obviously, to DPC per se. You have other, in fact, Premise is going to be here. There are other on-site, near-site type things that operate on a lot of the same principles, but again, all targeted at the employer market. So the interest in that is growing, and then there are other organizations that can pair up other maybe more alternative delivery models with that DPC, direct contracting. We're going to, Clint will talk about that later, but all manner of things that are going towards, that are really directed at the employer. So I'll pause there.
Yeah, I think if you, from my experience, having worked on this issue for well over a decade now, I loved what Purva said in the last panel about value-based care being the North Star. And I think there's a lot of confusion. I think people say value-based care and they just automatically assumed ACO, shared savings model. But to JP's point, when one is trying to build unicorns, I think DPC maybe is one of these unicorns. And so the value equation here, again, isn't necessarily, improved performance with regard to fee-for-service payments. The value equation here is that stickiness, the relationship between the doctor and the patient. It's interesting because I attended a MedPAC meeting when they were evaluating one of the first ACOs shortly after the first round of ACO data, shortly after the first shared savings plans were put together. One of the MedPAC board members said in the panel, the thing that makes one of these ACOs successful is that stickiness between the doctor and the patient. The patients that had, not just a couple of months or even a year with a doctor, but had a doctor over 3 or 4 years, were the ones that were doing better in the fee-for-service world. Talk a little bit about that and the experience between patients and doctors in this relationship. And maybe if you want, just, Jeff, throw in an anecdote or a story about how it's really impacted a patient's life, too.
Yeah, so we've talked a little bit about data today. I'm not anti-data that makes sense. I'm anti-data that tortures us. Because if we, as the provider, or we have to hire people in our system to take away from our income and track data, even stuff like diabetic numbers, hemoglobin A1Cs, blood pressures, things of this nature, I think that's a total waste of the time of the primary care physician. Our job should be taking care of the patient. It should not be tracking numbers. And when we talk about value-based, sometimes I hear, well, how do you track that? Well, we got to see the objective number. Does this number improve? And that shows value. And one of my favorite stories, I mentioned it here last year. So I have a diabetic patient, or maybe I should say had, because she recently just passed away a month ago or so. But she was a bilateral amputee. She'd lost her lower legs on both legs. You would think that would be enough to get her to change her diabetic ways. But that was not enough, because she's an addict. And she was addicted to sugar. It took me 5 years to get her to quit drinking 7 liters of Sprite a day. You'd think the legs would have helped that transition, but it took me 5 years to get her to quit drinking 7 liters of Sprite. Tell me how to measure that. What number shows that? I never saw, those of you who are not physicians don't understand this, but I never saw a hemoglobin A1C less than 10 until this past year. So, that person is an addict. If I want to make my numbers better, I would fire her. But she's a person, and I get emotional. And I kept taking care of her, and I kept banging my head against the wall. And you cannot measure that with a number. That's what primary care is. So, this is why I'm anti some types of data. Let's come up with some good data like these guys have done that show the value downstream. Little example of that, let me rein back in my emotions here. I cannot tell you the number of times I have a patient come in and they say, well, I've got a cardiologist, and I say, oh my gosh, did you have a heart attack? Have you had bypass? Did they do an angiogram? No, I just got high blood pressure. Oh, really? Okay, well, tell me all your high blood pressure medicines. Well, I have lisinopril. Now, I know most of you aren't, or some of you aren't doctors, and you don't really know what I'm saying here, but that's like the most common generic blood pressure medicine, and high blood pressure is literally right in the wheelhouse of every primary care doctor of every flavor everywhere. Why do we need a cardiologist to see that patient? So the number of patients who come in my office and I am stripping I'm stripping specialists away from them, not because I don't like the specialists, I need those people, but I only need them when they actually need a specialist. Because in the fee-for-service system with 7 minutes, and one of the young ladies said earlier, we become essentially a glorified referral monkey. That's my phrasing, not hers. You know, we are not using the full breadth of our capabilities. And I also want to say I love all providers. I'm not insulting any of our physician extender colleagues, our physicians assistants and nurse practitioners and such. But there is a difference in physician training and the other providers. And in a direct primary care model, I have the time to actually reach the level of my expertise. And how much more can I take care of on that one patient? Maybe I only have 600 of them instead of 2,500 of them, but I am actually doing so much more for that person, and then that leaves the cardiologist to not fiddle around with filling a lisinopril prescription every year and taking up 15 minutes of their time. They can actually be in the cath lab saving someone's life, which is why we train them to do that. My job is to do the easy stuff and the general basic stuff. And when you're talking about downstream stuff, that's a good example of how my practice is different.
The one thing I would add is, I mean, we all know, think of anything you do as a professional, right, that involves your value-added skills, right, where you're going to do something within your license, not administrative tasks. We all know that to do that, you need significant amounts of time to think and to solve complex problems, right? Which is what these guys do. I can't think of anything like that I can do in 7 minutes, at least not regularly.
Right.
I mean, you might have to do it now and again where you got to get ready for a meeting, whatever it is. But on a regular basis, I'd quit that job, and that's precisely what's happening to primary care physicians. And when you talked about the relationship thing, how well would this go over? Honey, I got 7 minutes for you, right? I can talk to you for 7 minutes. Or son, I can sit at your bedside and hear about your day for 7.
I have a divorce lawyer friend who could tell you.
I mean, look, relationships take time. And none of the models really, other than DPC, recognize that at least fully, and then build that into the model and actually do something about it.
So I think it's probably fair to say that some good measures would be patient experience data,
Exactly.
patient satisfaction. We've had the pleasure of working with Dr. Rebecca Etz on her patient-centered measures, which candidly I'll just say I'm a huge fan of, and we're going to continue to work with her on moving those out. But so patient-centered measures, encounters with patients. So you know, how many, and I love this. Is one of the beautiful things about DPC is, you know, we talk a lot in Washington about being site neutral, and so I always tell people, if you're in DPC, you know, there's no more visit because nobody's being paid for a visit. I mean, you can interact with your clients, patients at a coffee shop. My doctor actually does do office hours at Swings Coffee, which I think is really, really cool. Or over the phone, using telehealth, you know, that sort of thing. So the modality, you know, isn't really important. And since you're not being paid, you know, you don't have to worry about telehealth fees since you're not being paid an incentive for telehealth. But, you know, so those measures, I mean, a long time ago, we thought those measures were like soft measures. I mean, you know, but Jeff, I presume those are important to you. And you know, again, Fritz, you know, how important are they to, you know, people who are looking at the data?
I'll let him
Yeah.
comment. I mean, the only way, what we would do is it is a higher quality product, and those qualitative assessments gathered in a rigorous way like that are obviously really important. I mean, the price point is higher. It's a higher quality product. So what are you getting? What is the patient experiencing them? You know, what are they experiencing them that makes them keep buying? And I think just the fact that DPC is growing is also that is an input metric, right? I mean, if it was a horrible product, poorly priced, it wouldn't be growing. That to me is also a feedback loop that probably shouldn't be ignored in all of this. So.
Yeah, so approximately 11 years ago when I started, there were approximately 400 practices across the country. just guesstimates. I don't know what Dr. Flanagan would report, but maybe 4,000 practices across the country. I believe 10 years from now, we're going to go up by a factor of 10, if not 20, probably 40,000 practices. This is my theory. Once we bring all the other specialties in, the product is growing. The physicians are begging for a change. I tell any physician I talk to, oh, you're happy in your circumstance, man? Then I'm not here to pester you. I'm not trying to convert you. Forgive me, but so my family loves Jesus. I compare DPC somewhat to the gospel. I'm like, I'm just here to spread the good news, okay? If it works for you, I want to help you do that. And if it doesn't work for you, then keep doing what you're doing. I'm not trying to convert any physician who's happy with their circumstance or convert any patients who are happy with their circumstance. But there's so many patients and physicians who are unhappy. And so they're looking for another product, if we want to use that term. And so I had one other point, but it'll come back to me.
Well, let's take it from there. I mean, so you run the...
Oh, I'm sorry. I remember what I was going to say. You asked about the product itself, and I can say that I've taken care of a folliculitis. One of my patients sent me a picture of his forehead just a while ago. I've written a doctor's note for a sick kid the last couple of days, just over here at the table with my computer and my phone right there. And so because they're not paying me to see me, I just take care of them, whatever is easiest for them and whatever is easiest for me, as long as it's medically appropriate. If it's just a cold, and I'm pretty convinced it's just a cold, then I don't have to see them face to face. But if I'm like, that might be a pneumonia, maybe we should bring you in and I can listen to you. But still, there's no requirement from some payment source that I cannot take care of them in any way, form, or fashion that they are comfortable with and that I am comfortable with. And so it really works for almost anybody of any age and any circumstance. Young, healthy people are like, well, I'm busy. I can't take half a day off of work for a cold. I'm like, awesome, just text me. Really sick people are like, well, I have to go into the doctor just constantly. And I'm like, okay, I'm ready for that. We'll set you an appointment every week on Tuesday at 1 o'clock. You know what happens after about 6 weeks? They say, do I have to come back next week? And so, their needs are just not being met in the system, but once you meet their needs, they feel more comfortable and they're no longer as needy, I guess, if you want to put it that way. There are patients, the older folks, sometimes they just want to talk. Oh, I'll tell you, just a month ago, one of my patients was like, how are you doing? And I answered honestly. Most doctors would not do that. They don't have time to, first of all. But I was like, man, I'm working too hard. And I just got these things going on. And I'm president of this organization, and things are tough. And he said, I want to pray for you. I mean, that's...
7 minutes, that won't...
No. So he took care of me for about 15 minutes. That was a good deal. Because he's still paying me, so he paid me.
Well, build off of that too. In your experience mentoring existing DPC practices, what are some of the challenges? This is hard. This is not as easy as submitting the code and getting the payment.
So we still have to realize that we're still taking care of patients, and it is a tough job. There's still somewhat a level of burnout. But what you find is when you have 80% less paperwork and 80% less headaches and 80% zero billing and coding, we're still dealing with prior authorizations. Can we do anything about that from a government perspective? Stuff like that is still difficult. But we're still taking care of people. People are hard to take care of. But we're able to support each other. I mean, Dr. Flanagan will tell you we love going to the big conferences, not because he still needs to learn how to do DPC. He's been doing it longer than I have. But we go just to interact with our colleagues and to get rejuvenated and to reinvigorated. And if you're a physician and you've never been to a direct primary care conference, do so. It's one of the few conferences where everybody's eyes are up, their eyebrows are up, there's a smile on their face, they're excited. And you can literally see at a DPC conference the new people learning about it. You can literally see a light come on in their eyes, and that is what I call hope.
And I'll attest to that because I go to a lot of them as a speaker and as a participant, and it reminds me of learning in history about the old Chautauqua movement, where you'd have a revival tent and people are actually there talking about, oh, how can we do this better and how do we feel better? We are wrapping towards the end of our our session here, and I want to take moderator's prerogative to talk about a few policy things. But Fritz, before I do that, any last thoughts about DPC and where we're headed? And
yeah, I mean, I think it's. We've touched on a lot of this. Other than I think there will be a reckoning. I think in the healthcare system, I think DPC is not going away. I don't think anybody wants it to go away, but it is going to grow, and I do think that there will have to be a reckoning with payers. We'll have to learn how to. We'll have to figure out what to do. There's X amount of physicians, and if 90% of them are fee-for-service or are DPC, which I'm not saying it is, but just hypothetically. Well, you've got some change that needs to take place there. So we might be a decade away from that. We might be a year away from that. I don't know. But I do think that there is a point at which this will have to sort of resolve itself in terms of what is the right model.
Well, I thank you both for your perspectives today. As I said, we're busy not only working with DPC practices, but here in DC trying to advance the policy agenda. And I can't let the session end without putting a plug in for a couple of our pieces of legislation that candidly we are really on the precipice of getting done. Both of these pieces of legislation have passed the House of Representatives at least once or a couple of times, and as we're considering budget reconciliation, I think a couple of these are in play. And the first is the Primary Care Enhancement Act, which would really clarify tax code, the difference between these fee-for-non-covered service agreements and DPC, and to say that DPC is fully compatible with a health savings account. Would be a really great model to take money out of the health savings account and pay your direct primary care doctor, but due to old language in the IRS code, you can't do that today. So we're going to try to fix that. The next one, and by the way, these are both bipartisan bills. Representatives Crenshaw from Texas and Kim Schreier, a pediatrician from Seattle, Washington, have sponsored the Medicaid Primary Care Improvement Act. And this would allow CMS to work with states to figure out how to get Medicaid beneficiaries, our most vulnerable patients in America, this kind of care. It doesn't set any specific rubric. It doesn't say Medicaid, you're going to have to take Medicaid patients as a DPC doc, but it says, hey, let's try to figure this out as adults, get in a room, hammer it out, and maybe make one of these unicorns really, really work for our most vulnerable. So we're not really looking just to take care of the rich and the healthy and the young. We want to take everybody. We want to take care of everybody, cradle to grave. Medicaid beneficiary to the CEO. And I think you can see we have some really good talent here helping us do this both at an actuarial level and right on the ground practicing every day with Dr. Davenport here. So a warm round of applause for our panelists.
Thank you all very much. Great discussion. We will be back. We're going to take a break. We'll be back at 1 p.m. Eastern Time. We had an incredible morning. I think the afternoon is going to equal the energy we had this morning. And we're going to kick it off at 1 o'clock with a conversation on a topic that lots of people in lots of different corners of the health policy world are talking about today, and that's the chronic disease crisis. And we're really looking forward to that panel. And then we'll move into our innovation panel in the afternoon. I am going to come back and moderate a panel on direct contracting. We're going to have an excellent panel on rural independent practices. And then we're going to close out PrimaryCare25 with a discussion about the CMMI models, both current and future. So we'll be back in about 45 minutes at 1 p.m. Eastern.
Hey, check 1 2, check 2. Hey, check 2, check 2.
Are we doing the presentation? Well, welcome back. As I said before our break, we had an exciting morning. I thought it was a really energetic and informative morning, and I think the afternoon certainly is going to match, if not exceed, that experience we had this morning. So we're going to kick off our afternoon with a discussion around the chronic disease crisis. Everyone in the health policy world understands the implications of the chronic disease crisis, both to individuals and families, but also to our healthcare systems and the viability of our healthcare system on a go-forward basis. So as we did this morning, we're going to start our afternoon with a keynote address, really looking at some data, the underlying factors driving the chronic disease crisis, and then we're going to have a panel discussion with an outstanding group of national experts that are really going to dig in to how primary care can play a role in reducing the chronic disease crisis. But first, it's my pleasure to introduce Dr. Joseph Brodeen, who's going to walk us through the data and the current situation with respect to chronic disease in the United States. Dr. Brodeen.
Good afternoon, everybody. I really want to thank the organizers of this event for inviting me today to offer these remarks and for including me on this esteemed panel. As I was preparing for this moment, I looked at the title of our session, and I just want to say how appropriate I think it is that we're calling it a chronic disease crisis, because it is true, chronic disease is now what is killing Americans more than any other cause, and it is the priority that we have to address. And I say to the folks who are in our listening audience on the other end of the podcast, you know, many of you are living in the policy space or are health leaders or are physician leaders, so I know that some of what I'm about to share is probably familiar to you, but I think that it's important to remember the magnitude of this problem. Right now, 129 million people in the US have at least one major chronic health condition. And over the past 2 decades, the prevalence has increased steadily, with an increasing proportion of folks in America that have multiple chronic conditions. I'm a family doctor. I operate up in Northeast Baltimore, and I see this every day, folks coming in with multiple chronic conditions. Right now, we see nationally that 1 in 10 have more than 5 chronic conditions. When you look at the US expenditure on healthcare, you see that a significant proportion of our GDP goes to healthcare expenditure, about 17% or more. Compared to our colleague members in the OECD, we are leading the pack. We're spending almost double what the average is for the OECD nations. So we're top in spending out of 38 high-income developed countries. And yet, we're at the back of the pack in terms of life expectancy. So where is all of this money going? The American Medical Association offered an analysis in 2023 that estimated nearly 1/3 of expense goes to hospital care. And we have to acknowledge that hospital care is not just for necessary elective surgeries, but in that spending bin is a significant amount of avoidable preventable, unnecessary ER utilization, inpatient utilization, and really that hospital expenditure is the consequence of untreated, unmanaged chronic illness. This is not just a big problem now, it's growing bigger. That price tag will get higher as the years come. And whereas in the earlier part of last century, most of the causes of illness were infectious diseases. Now, thanks to the advances in food safety, sanitation, and the advent of antibiotics, most of the leading causes of death now are chronic illnesses, as Americans are living longer, but unfortunately getting sicker. 5 of the top 10 leading causes of death in the US either are or are strongly associated with treatable and preventable chronic disease. This trend is affecting not only adults. As a family doctor, I think about our pediatric population, I think about our pregnant population. In children, we see now that nearly 1 in 3 young people live with a pediatric onset chronic condition. Asthma is the most common, prediabetes, diabetes is the second most, followed by ADD and ADHD, and other conditions as well. The complications of this are lifelong and staggering. We see impaired growth and development. We see an increased incidence of psychiatric conditions. We see decreased life expectancy once we know that a child has become very sick with a chronic illness. There's a social cost as well. Chronic school absenteeism reduces the likelihood of being successful, independent, and later in life. There's lost productivity from parents taking care of their kids with chronic illnesses. And of course, all of this contributes to the high healthcare costs that I mentioned earlier. In pregnancy, we see that not only is there an increased chronic illness in pregnancy, but we see that there's an effect of really 2 factors. One, as I've mentioned, we have people getting illnesses younger in life, but we also see over the last 40 years that the age at childbirth has gradually increased. So we see that the average age of childbirth is older, and therefore there's a greater likelihood that our pregnant patients are going to have hypertensive disorders in pregnancy, gestational diabetes, cardiovascular disease, things with rather grave and dire outcomes for mom and baby, preterm delivery, low birth weight, preeclampsia, stillbirth. This really threatens the health of our youngest people and our most vulnerable people. The last thing I'll say about chronic illness is that we know that social determinants of health are huge drivers in chronic illness. If you were to look at this map from the CDC that illustrates the prevalence of chronic illness, and if you were to get a similar map that showed where the income gap is greatest between richest and poorest Americans, you would see a very similar distribution of a heat map. And we saw from a really good article from Washington Post in 2023 that while the income gap between the richest and poorest Americans has increased marginally over the past 40 years, the death rate gap, the difference in the death rate, has increased almost 5-fold. So we can see that, again, poverty really drives forward chronic illness. I see this every day as a clinician where I have patients that have food insecurity, they don't have an ability to get to the clinic, they struggle with housing, they don't have the ability to afford medications or equipments like glucometers and scales. But I think we do have a sense of what the answer should be. I think that primary care is a most powerful tool in the arsenal of healthcare. I think that people with chronic disease who have a doctor with whom they have a relationship, someone who knows them, someone who knows their health, someone they've known for years, that person has a greater chance of living longer. They're more likely to have improved health outcomes. They're more likely to make fewer visits to hospital and incur fewer costs. But primary care needs help. And I'm echoing some of what has already been said very well today by some of our good colleagues. I would say that we are a subset of our healthcare workforce that is under-resourced. 35% of healthcare visits are to primary care, yet only 5% of spending is on primary care services. We know that access is an issue. There really is not enough of the primary care workforce to go around. The average wait for an appointment with a primary care provider can be 4 weeks or even longer in areas where there's a health provider shortage. And of course, if you're part of a team that's trying to do a big job, but there's not enough folks to shoulder the work, you'll have burnout. We know that more than half of family medicine docs said that they were feeling burnt out in 2022. And I think that jeopardizes the integrity of such an important workforce. So as I lay all of that out and get ready for our panel discussion, I'll leave us with one last point that I chose to emphasize that I thought would be interesting for the group. Many of you probably are familiar with this article, but there was a really great study that was very thought-provoking that came out about 3 years ago, where the authors attempted to estimate how many hours it would take in the day to take care of their patients. And if you have a doc that's working all by themselves alone, it might take 26 hours, which is probably very hard to do on Earth. You'd probably have to go to a planet where the solar day is a little bit longer to do that. If, however, you were to model a counterfactual scenario where you have a PCP that's got a team, care managers, nurses, community health workers, dietitians, counselors, a team that can wrap their arms around patients, especially when they have the greatest need, it might reduce that time to about 9 hours that the doc is spending each day. Still a long day, but a lot more manageable than 26 hours. And I think that that's really where I'd like to leave us with framing these results, because this talk, because I think we want to consider the importance of how we strengthen primary care to address this growing problem of chronic illness. And part of that is going to be thinking of it as a team sport, thinking of it as a solution that needs resourcing. And I really appreciate your attention today. I'll turn it back over to Sean. Thank you.
Dr. Brodin, thank you so much. I invite you to stay. We have an outstanding panel, and I'm going to invite the panel to come up, and I'm going to introduce Dr. Faisal Syed from City Block Health, who's going to moderate this panel. I will point out for everyone else, your panel's a podcast.
Yes.
Awesome. I will turn it to you. Thank you so much.
Thank you, Sean. Hi, I'm Faisal Syed. I'm the Vice President of Market Medical Practice at City Block Health. I'm a family doctor, started my career in community health, and I kind of feel like no matter what I do in life, once a community doctor, always a community doctor. So let's get the panel up over here and get a great conversation. We can sit wherever, I guess. We already have a mic. Let's make sure all the mics are working. Dr. Jonas. You go, sir. Well, first of all, thank you all for taking the time. I know you're all busy. I know Dr. Brodin's actually got clinic this afternoon. I mean, real family doctor, amazing. You know, you're just amazing. I love it. So I wanted to thank you all, and I wanted to set the tone for the conversation. I don't want to focus so much on the what, but more about the how, you know, that we've got here with America on America's health journey. So I'd like to start off with, you know, we know all the statistics. Chronic disease is swallowing up the country's health and wealth. But before we get into all the policy and the data, I'd love to ask each of you, especially for our listeners who are medical students and residents, you know, what was the moment in your own journey where the crisis hit home for you personally or professionally? So we can start with you, Dr. Shin.
Sure. So before I was at the National Association of Community Health Centers, I was a young researcher at the George Washington University, and one of my first projects was to look at family planning services, looking at reproductive health, and going out into the field. We were also studying healthcare contracting. I mean, Medicaid managed care was just coming into the fore, and when we're looking at the rates, guess how much rates were for contraceptive services? 25 cents is what we found at that time. So I think that just sort of lit a light bulb in terms of, you know, that we just needed to know more about this kind of unraveling, as well as some of the defining issues. But sort of just going back to the issues of chronic care, I think, you know, we also heard when we were in the field a lot of stories of families who were talking about how their parents or grandparents were basically deciding to die at home and not go to the ED or hospitals because they couldn't afford care for their diabetic or heart disease issues or even prescriptions at that time. So.
Hi, everybody. I'm Kate Goodrich with Humana. My story is sort of mostly personal, a little professional. So I'm a hospitalist in addition to working at Humana. And I worked as a hospitalist full-time for 10 years and then went to do a career in policy. And at that same time, my mother came to live with me. And it was because she had a whole bunch of chronic conditions and needed help caring for herself. And you think after 10 years being a hospitalist, seeing mostly seniors or everybody who had multiple chronic conditions and were in the hospital because of complications of those chronic conditions, that the crisis would have hit me already. But where it really hit me was when I became the care navigator for my mother. And over the 14 years that she lived with me, she developed more conditions, had, I've heard the statistic that I think maybe came out of AAFP, which is that seniors with chronic conditions see 7 clinicians in 4 different health systems on average. And for my mom, it was 7 and 7. And so the navigation was perilous at every moment. And it really affected me to understand what people, especially seniors, which is the population I focused on in my career, go through just to get by. She took 19 medications at the time that she passed away. And she was in the hospital the last few years of her life 4 to 5 times a year. And she actually had a wonderful primary care doctor, but in a terrible primary care system. And I really mean the national system, not so much just the singular system she was in. So that's when, I could really, also going into policy at the same time, really sort of put together the pieces of what it's like to care for these people, what the policies are that make it hard, and what the policies are that make it hard not just for clinicians like myself, but for the patients themselves. And that's when it really became a purpose for me to focus on that area.
Yeah, so I was in the fortunate situation in the first 20 years of my career to be practicing in a military system that at that time was not using RVUs as an accountability measure. And I had a panel of patients, diverse from retirees down to kids. I knew them. I knew their families. I knew what their families wanted for the older individuals in those areas. So I knew that when Mrs. Jones, 89, with major heart failure and a huge heart on a chest x-ray, ended up fainting or falling and going into the emergency room, they would call me instead of actually admitting her, which doesn't happen anymore, okay? Because if she had been admitted during COVID, it's more likely she would have died than survived that. And so the residents were running this community hospital, and it was very satisfying to be able to know what needed to be done and how to communicate with them instead of finding out, oh, she'd been admitted and the family couldn't see her, which happened to many people later on in those areas. When I got out of the military, I actually started to get engaged in more civilian sectors, and it was a wake-up call. It was a huge wake-up call. And so I said, I'm going to volunteer my time and just go back and see patients in the military where I can have that. And I've noticed over the next 20 years, yes, I've been practicing that long, the next 20 years there's been an erosion in whole person care where we were charged with not just taking care of diseases, but keeping people healthy. And in the military, you're supposed to keep them optimally performing, right, in those areas, and that means prevention. It means trying to reverse chronic illnesses if you can so that they can perform, or if that can't be done, keeping them well, keeping their well-being going through managing things like you just described in those areas. And now, even in a capitated system like that, they're using RVUs to do it, and you can see the immediate erosion in the ability to actually take care of chronic disease in those areas. So that's been sort of my fortunate and unfortunate view on what type of primary care is needed. And I think it's very important that we pay attention and focus on what type of primary care, not just cast an umbrella over all of primary care and say fund it all. That is not going to work, and it's not working.
Thank you. For me, the light bulb moment came in 3rd year of medical school, where I was working with our internal medicine service. I was in the hospital. I was admitting somebody that I had admitted a couple weeks prior, and it was a readmission. And This person had really bad heart failure, really bad diabetes. Their feet didn't fit into their shoes anymore. They were blind from diabetes. They struggled with housing. And I looked in their chart and I was putting together their history and realized this person had been admitted 8 times in the last year for really the same thing. And it was like watching a movie over and over and over again as I read through this chart and realized this guy's story is he's spending these last years of his life in and out of the hospital for the same thing. And when I was talking with him about the plan, I said, I don't want you coming back to the hospital. I want you to get well. I want you to have a better life. And we were making plans on what to do upon discharge. I said, who's your doctor? And he said, I don't have one. I said, have you ever had one? No. Nobody knew him. Nobody knew him in a primary care sense. And I think that was a moment for me that really brought home the importance of having a relationship with someone that knows the patient and can work with them and provide that whole person care.
You know, especially with how you finished, I want to ask Dr. Jonas, when he ended with talking about whole person care, you know, when we say, you know, making America healthy, what does that look like to you in a clinic, in a home, in a neighborhood?
So the phrasing is great, okay? Reduction of chronic disease is great, okay? Primary care, as I mentioned earlier, as an umbrella aspect is not going to do it. It's not a matter of more money into primary care. It's about more money into a type of primary care that can actually reduce chronic disease and make it. And I think the public doesn't understand that. We know, you know, recent surveys showed that the public, and I think most politicians, probably think, oh, gee, 50% of the budget must go into what they call primary care, okay? But not that type. And we know that the kind that we're talking about in this room is, you know, less than 5%. So there's a real misunderstanding about the type of care that we need to reduce chronic disease, which is what we're talking about. That's whole person. It's relationship-based. It's grounded in relationships. You cannot change behavior, lifestyle, compliance, whatever you want to do unless you know the person and they trust you so that they're engaged in their own care. And then I'm going to throw out a word here that is a little technical. It's called, we need a salutogenic system. We need a system that doesn't focus on just pathogenesis. I studied from the textbook of pathology and pathogenesis. We need one that looks at what drives healing, okay? What actually drives health, and have a system that focuses and is able to do that. And that means looking at the whole person in those areas, because they have to be engaged in that process.
Thank you. You know, Dr. Goodrich, I wanted to ask you about Humana leaning so much into value-based care, and we know that the success with the value-based care movement was all about influencing positive behavior change with patients, but it's had a tremendous impact on us as providers as well. I wanted to know, like, what's the most unexpected lesson that you've seen about either patient or physician behavior change when it comes to prevention or early intervention?
Well, I think it might help to sort of paint a picture, especially for your listeners, of what's the difference between sort of what I'll call traditional primary care as it has existed in this country under the fee-for-service system with what I'll call the more advanced value-based care. Value-based care is a term that has come to mean a lot of things to a lot of people. So I tend to focus on the more mature and advanced type of primary care that does get to the type of care that you were talking about, Dr. Jonas. So, and I'll use my mom as an example, right? So when my mom was alive, she saw a primary care doctor in a very busy multi-specialty practice. And this is a doctor she's had for 15 years, but it still took 6 to 9 months to get an appointment. And then when she got an appointment, half the time, well, not half, 75% of the time she saw her doctor, or the other 25% it might be a resident, and that was fine. She understood that was the system she was in. But the appointment would last about 10 to 12 minutes. And so we were conditioned to, before we went to the appointment, figure out what are the 2 things that we need to talk about. My mom actually had 5, but let's think about the 2 things that we have to prioritize for this appointment. And then she had 6 other clinicians that she needed to see outside of that system, certainly no communication between them and the primary care doctor. And when she was hospitalized, it was kind of random as to which of her 7 doctors got the discharge summary. It wasn't always her primary care doctor, even though we were always very clear about who that was. There are medication errors, all that kind of stuff. Okay, let's talk about advanced primary care, what that's like for the patient and for the clinician. And by the way, my mom's primary care physician was wonderful. I handpicked her from my mom. But she was overwhelmed in a system that worked against her. And she couldn't deal with the holistic aspects of my mom's care. So in an advanced primary care model, and the reason those exist is because of the economic model that undergirds it, that allows for prospective payments to primary care practices so that they can invest in the resources like social workers and behavioral health specialists and nutritionists and pharmacists within the brick and mortar walls of the clinic, but maybe also telehealth for where that's needed, can invest in the data and analytic insights at the point of care so that you can manage the patient in front of you as well as your population of patients. That takes a different payment system. What's that like for a clinician? Well, so for our clinicians in our CenterWell clinics, which are an advanced primary care model, they have time and they have simplicity. Now, there's still sometimes frustrations. I want to paint you a picture that isn't true, but let's start with the time. They see about 8 to 12 patients a day, and they have about 30 to 40 minutes with a patient. But often when the patient comes in, they're there for a couple of hours because they're also seeing the social worker. They might even be seeing the social worker or the behavioral health specialist first. The doctor might be ancillary to that appointment because that's who they need to see for what they need right then. If they call to get an appointment, they can usually get it by the next day, sometimes same day, but certainly within a week or two if they need to. So there's so much attention paid to making things easy for the patient, but also easy for the clinician. Another thing is it allows, because of those prospective payments, we can actually invest in resources that make things easier for the physicians, the nurses, the PAs, the MAs, the front office staff. And I'll just give you an example of 2 of those things. One is ambient AI. You may have heard of this. This is a technology that is gaining in popularity because it is making people's lives easier, that allows a clinician to effectively record the visit between them and the patient, and often the patient's caregiver as well. And at the end of that visit, I'm going to make this sound really easy, but it does feel magical. It spits out a note in the SOAP note format on the other end that the clinician then goes and just reads and makes sure is accurate, may have to make a change or 2. But it's actually pretty darn accurate. I've seen this work in real time a number of times. That really has significantly reduced in our clinic, we've been measuring this, certainly pajama time at the end of the day, but also burnout. It's not the only solution to do that, but it is an important one. And then the second one is another type of technology, which is AI-based, to allow the clinician to have, before they walk into the room to see the patient, all the information about what's happened to that patient since they were last in their clinic. Were they hospitalized? What happened at that hospitalization? So with access to various data sources, the technology can pull together as much information as it has access to about the specialty visits they had, about the lab work that they had, about whether or not they got their medications picked up. So that way the physician walking in doesn't have to go hunting and pecking for the latest hospitalization or did they pick up their meds. It's actually right there summarized for them. It's still hard to be a PCP even in those circumstances, but it gets you from that 26 hours a day closer to the 9.
Gosh, I love that, and I'm loving this era that we're in right now with so much of the busy unnecessary doctor work that gets put on us being taken over by artificial intelligence. Dr. Shin, I wanted, you're in the world of data and community health. What's a hidden statistic or trend about chronic disease or primary care that leaders in Washington, D.C. need to understand, but they don't?
Well, let me preface the answer with just talking about the health centers a little bit, and that is, there's about 1,500 health centers across 16,000 communities. We serve about 32.5 million people, which is about 1 in 10 in this country. And to your points around, whole person health and patient-centered care, when a patient comes in, I mean, we do screenings for not only the chronic issues, but also those conditions or circumstances that contributes to those conditions, really the social determinants and the social drivers, and really gets at really understanding, what it's going to take to address those major issues. Now, I think one of the things, we try to always talk about is prevention, right? So the ounce of prevention is worth a pound in cures, right? So I think one of the things that we have been looking at is some of that data, looking at, how much goes up in terms of prevention counseling. So for example, for hypertension, it could be like just a few $100s. But down the road, it's about $2,000, and then once they become hospitalized, it could be hundreds of thousands. So we just try to tell that sort of cascading story of what it means to be treated or untreated, to have control or no control, and really the importance of not only clinical care, but really, again, sort of looking at, what are those conditions that are feeding that. And so I think, one of the examples we love to talk about is, when the first health center was created 60 years ago by Dr. Jack Geiger, he was billing the federal government for food. And they came down and said, what am I supposed to do with this? And he said, well, I think as a clinician, the cure for starvation and poor nutrition is good food. So, I mean, that's the kind of things he was prescribing. So, I think in terms of just being able to look at the person's health issues, their social issues, as well as their behavioral issues, is a critical and vital component of what we're trying to think about. And I think the health center model is not just about being in the underserved or serving the underserved. I think the chronic condition is the defining condition for primary care. I mean, we are really in the throes of really trying to think about how to address that up front. We're not abandoning it in any way. And so I think, as we're thinking about multidisciplinary approaches, team-based care, and really trying to think about, how do we get at these effective solutions in a very cost-effective manner. I think that's something I think we are all trying to get on board and really thinking about honing that message of what it means for prevention, what it means for cost down the road, and that we are all in this game of really providing value to what people say is a value-based system. So thank you.
Thank you. Dr. Brodeen, what gives you hope when you're looking at the next generation of our primary care clinicians, especially those who are stepping into some of the neediest communities?
Yeah, I'm very privileged to have the honor of working with some phenomenal medical students and residents that rotate through the clinic where I work. And as I've been in healthcare since 2003, so I feel like I've seen a lot of different generations of future leaders, future doctors coming through. And as I work with folks that are coming into it, new residents about to become new family doctors, I get a tremendous sense of hope as I understand something that I might call like a generational spirit that I think is new and different than what I experienced when I was their age. And I think about the fact that they're very focused on not only taking good care of their patients and practicing good evidence-based medicine, but they also want to address underlying inequities through health. They want justice through health. And I love that, and I celebrate that, and I think that that's a new way of thinking that I don't exactly remember seeing in the same way. I think it's existed from many great leaders in the past, folks who knew that the prescription for hunger was food. We know that there's been always good inclination towards social justice. I think Foucault said, physicians are the natural attorneys of the poor. So that's always been part of our credo as physicians, but I think there's a social consciousness that seems particularly well honed in this generation of up-and-coming physicians that gives me a lot of hope. My only caveat is I hold on to that hope so long as I have confidence that we have mechanisms in place to foster that ongoing pipeline of talent coming into medicine, that we're looking to communities where there are health provider shortages and saying, who in this community can step up to become a physician, where we're making this a priority in our medical schools to go towards primary care, where we're incentivizing people into careers that say primary care is worth it, both in terms of your heart and also just being able to get through and have a good life, earning a living. I think that's part of what we need to do. We need to make it a good and safe career so that people, the right people, really embrace the right kind of medicine.
Yeah, I had to agree with you that the interactions with this generation of residents, like their focus on the doctor-patient relationship, it is incredibly refreshing. I mean, yeah. Dr. Jonas, you've championed integrative and lifestyle medicine now for years. So why do you think that those breadcrumbs of prevention and whole person care haven't turned into the main course yet?
Money. It's fascinating when you take the board exam, which I've done I don't know how many times now, and there's a question about what is the best approach for, name the chronic disease, okay? Diabetes, hypertension, obesity, heart disease, etc. And if one of the answers is behavior and lifestyle, that's the correct answer. But guess what? The next 7 questions are all about which drug to prescribe. And did you do this drug or that drug, or which procedure to do? And that's because those are the tools we have, because that's where the money is invested in terms of the research. Now, lifestyle medicine is a sword hanging over the head of every physician, not just primary care, because we know that 60% or more of the chronic diseases actually have their root causes in lifestyle. And yet, all you do is you answer that question, and then I don't learn actually how to make the change, nor do I have the resources to do that. So that sword is dropping right now, and I think the administration, the current administration, is trying to say that, okay? I don't know if they actually know how to do it, but they're trying to say that. And so we should be leaders in that area and design a system that hits at those salutogenic components that not only prevent chronic disease, but in many cases can reverse it. And that's what's really going to drop and save costs. But if you don't get paid for doing the research to give you the tools to do it, and you don't get paid for delivering it, then it's going to be sitting there over your head until the sword drops.
I have a family member I was speaking with last night who was feeling so secure about his blood work. Now he's obese, on 5 different medicines, and his blood work looked fantastic, but he can't bend over to tie his shoelaces.
Exactly. All you got to do is take a statin, and you've solved your heart disease problem, right? Okay, just get that LDL down, and forget the rest. It's about it's the Osler versus Flexner issue. Is it about the numbers or is it about the person? And we've decided it's about the numbers, and we now pay for the numbers instead of the person. We need to shift that.
I'd like to open this up to the panel. There's always been this tug of war between doing what's right and what we can afford. But we've heard it loud and clear. Investing in primary care saves money. But why isn't that message breaking through?
I can take a start. I think there's more people listening to that message than they have before. I think that there are groups out there, including some who are represented in this room, who have been very consistently and effectively making the case. And let's look at even what's been done by the Innovation Center over the last several years. There actually has been progress made in trying to change how we pay for things in order to have an economic healthcare system that supports the kinds of things that we've been talking about. So we shouldn't say that there's been no progress, but it is still, I would argue, relatively early in what is probably like a 50 to 70 year journey, frankly. So it feels like there hasn't been as much progress. We're at a point where we have to really accelerate the things that we know work. And so where you have seen that investment in the models I was talking about, by the way, I'm a huge fan of lifestyle medicine, not just because it's like a fad, because it's not, it's because the evidence is striking. about its effectiveness. And the care model that we have in CenterWell, and actually lots of other organizations have as well, that advanced primary care model that I mentioned that exists because of value-based care payment system, actually facilitates the delivery of lifestyle medicine because it does allow for the time, the training, et cetera, to be able to do that. So I don't think there has been like a shock and awe moment of suddenly we all realize we've been doing everything wrong and we just suddenly got to change things. But I do feel like we've had some successes. There are more and more voices, and there need to be even more about how, if we're going to fix or make a dent in this chronic disease problem, we have got to fix the underlying payment mechanism for primary care, and not just the payment. We got to be sure we have the right clinical models, we know how to do it well, that we can do it well with, it may not look exactly the same for everybody, but there's a lot that's going to look the same, and really be able to support that. So I'm a glass half full person at heart, but I do truly see some receptivity from our policymakers, both on the Hill and at CMS, to making some of these moves. So I actually am positive.
Actually, I was also looking at Dr. Brodeen, because we were talking about this a little bit before, about, it's like when you have patients and they're like, well, nothing happened when they see their visit. So, how do you get credit for that? But the other thing being that, there's been tons of studies around the cost savings that primary care generates, a real value. So value being defined for payers, like the total cost of care savings, for providers in terms of outcomes and their own experience and satisfaction, and for for patients in terms of their own experience and good outcomes. But, at the end of the day, it's, patients feel the shortage. They feel the wait list that they're having to be on, the wait times, the challenges of getting that appointment, and then when they get in, it's quick and turnaround time for them. They don't really get to experience what they should be experiencing in terms of having that full 29-hour time with them. So I think, if there's a way that we can get the patients and the consumers really to advocate and understand what that experience should be like, and that their experience and that what they're seeing as like nothing happened is really part of that experience. I think that also goes a long ways in terms of providing a greater perception of the value of primary care.
So I think you didn't quite go far enough in your question. The question really is, saves money for who? Because the slide that Dr. Brodeen showed, where most of the money is going into the hospital systems, if we really prevented and reversed and managed chronic disease better, we would save money for the system, but they would lose money. Okay? And so there is an internal conflict within healthcare that are pulling in different directions in those areas. And that has to be looked at head on for the country as a whole and for the individual patients that are suffering and need the kind of care we're talking about. So,
yeah, constantly we see all the time with patients going to a clinic thinking that this is a doctor's clinic, and they have no idea that it's a hospital-run practice. Well, let me ask you, Dr. Jonas, if you had a few minutes with the president or CMS leadership, how would you make the case, quick and clear, that addressing chronic disease through primary care ought to be a national priority?
I would say making America healthy again is a great effort, and reducing chronic disease is super. Let's make sure we put the investment where it's going to do it. Okay? Cut the rest. And guess what? There's a whole plan laid out how to do that. And it's very systematic. It's thought through. It was published by the National Academy of Medicine several times. And it said the investment should be removed from here because it doesn't produce health. It's not evidence-based, et cetera. And it should be put into there. And if you do that kind of shift, you will see people flourish and the wealth of the nation will grow because we'll have less need in those areas. And so that's also making America great again, right? I think. So that's what I would tell them. I wouldn't go any further than that.
Thank you so much, Dr. Jonas. Dr. Brodeen, if we do this right, if we if we embrace the technology, we embrace the ambient AI, and now we've got this movement that's focusing on the 60 to 80% of the the lifestyle changes that impact the modifiable health outcomes, like what Dr. Jonas said, 60 to 80%. What do you think America's health story will look like 10 years from now?
Yeah, I think if we're able to steer hard in that direction, I think we're going to see an inflection in terms of the trends that I was describing earlier. I certainly think it depends heavily on really everything that we've been talking about. I think Dr. Jonas is right to point out that we have to identify what are we talking about when we say primary care. What does that mean? How does that look for people? It is rooted in the relationship. And I think when Dr. Goodrich mentioned about the excellence and experience in value-based care, at my organization, I help oversee our involvement with the Maryland Primary Care Program, which is part of Maryland's total cost of care. It has been a game changer for our physicians because instead of going at it alone, they have care managers, a pharmacist, navigators, community health workers, a group that helps focus on cancer screening specifically, all of these resources that can really help them take good care of the patient and free them up to focus on what's most important in working with these patients, which often is managing chronic illness. And I think, Dr. Shen, you mentioned about the patient's experience. I think that's what it would look like, is that a patient can say, I know who my doctor is, right? It's almost like a predictor. It's like a measure, a leading indicator of health is I know who my doctor is and they know me. And I think that we'd have that relationship very well established, and it wouldn't be just restricted to a bricks and mortar location. It would be electronic, it would be virtual, it would be part of someone's device. It would be part of how they plan their year and their time and their priorities. And it's safe to talk about health because we're talking about promoting wellness and producing health. So I think that is the vision that we have to work towards.
I love that. Dr. Goodrich, for you, what's one bold but doable change that we can start tomorrow? It's the middle of the week, it's Wednesday, either in a clinic, for Dr. Brodian this afternoon, a health plan, a policy room, that would move the needle on chronic disease in a real palpable way?
I think you gave me the hardest question. I don't know that there's anything that you can do in a minute, but maybe one aspect that we haven't touched on quite as much yet, and I don't know what the thing to do in a minute is to get to this, but it's, I think, a really important piece of it is how do we make healthcare simple for people? And if I think back to my mom, and if she had an acute problem, she wasn't going to go to her doctor. We had to go to urgent care. We had to go to the ER. And I know better. As a policy person who worked at CMS for 10 years in Humana. So healthcare is so hard for patients and caregivers in their highest moments of vulnerability. That is so striking to me. They're scared, and everything about the system puts up a barrier, right? So I would start thinking about, if I were you in your clinic or me at Humana or anybody out there, what is the one thing that we can do for our patients that will at least take a little bit of edge off that burden for them? What are process flows that we can just simplify? There are big things we need to do to make healthcare simple. Big things that are going to take years. There are medium-sized things that we at Humana, you and your clinic, have control over that we can spend time trying to simplify. But there's probably also some little things that if you take it from the viewpoint of the patient and what they're experiencing, that you can simplify in your clinic that might just be a little delighter for that patient or that caregiver that we should be thinking about.
Wow. Well, I'd like to thank you all for your insights, taking the time to come over here to Washington, D.C. for this panel. I invite our listeners and our viewers to take actions in your own spheres, in your own clinics, in your own communities. We're definitely going to keep this conversation going on our podcast. I'd just like to give warm applause to our panelists. This was great. Thank you so much.
What an engaging conversation as we get our afternoon started. We're going to come back with our innovation panel here at the top of the hour, 2 p.m. Eastern Time. We're going to start off with a conversation around direct contracting. We will quickly move into a conversation around independent rural practices. And again, we're going to close out our day talking about CMMI models, both current and future. So we'll be back in about 10 minutes to kick off our innovation panel. Well, it's great to be back with you. As I said earlier, I'm going to actually join and moderate a panel this afternoon with 3 of my favorite people in primary care, but we're going to have a conversation with you about direct contracting and the relationship between primary care and businesses across the country, large and small. So welcome. Thank you for letting me join your panel. I'm going to ask just Michelle, John, and Clint if we could just go down and introduce yourselves and a little bit about the companies you work for, and then we'll dig into our topic.
Well, it's great to be here. My name is Michelle Neblett. I'm Executive Director of Healthcare Policy for the Boeing Company. I'm one of our federal lobbyists here in DC, working on health policy and other benefits issues and some other tax-related issues for the company. Boeing is a company you probably know, but we are maybe much bigger than what you're familiar with. We have 3 major business units. Our commercial aviation business, building the 737 and 787 Dreamliner. We have a defense, space, and security business that builds fighter jets, satellites, space, rockets, all those cool things. And we have a services business that does aftermarket services, both parts and maintenance, as well as digital services. We're about 160,000 employees worldwide. In the US, that translates to about 450,000 lives covered by our health plans. So we're very large. We spend several $billion annually on health and health administration. And we have a very complex system of and offerings of health plans. We've got a union population, non-union. We are in every state and have an employee in every state. So we're big, we spend a lot, and we're pretty complex on the healthcare space.
Thanks for being here. John.
Thank you, Sean. It's a pleasure to be here. I'm John Leisman, Chief Medical Officer of Premise Health. I'm a family medicine physician by training. Premise Health is a direct-to-employer healthcare company. We operate and manage 800 health centers for 275 large self-funded employers, Taft-Hartley plans, health plan. We take a broadened view of primary care, so it's not just patient-centered medical home, but it is primary care plus behavioral health, plus pharmacy, plus care management, plus care navigation. We also have our own in-house 24/7 virtual health team. We provide occupational health services and some related services as well. We do this across 45 states and Guam. Our value proposition is high quality, cost-effective care, and we've been able to realize approximately 30% savings, which equates to $2,400 or more per member per year. Our value proposition for patients is high quality, cost-effective, person-centered care with a focus on lifestyle, behavioral change, and helping people to overcome what might limit their ability to live their healthiest lives. And we do this delivered by teams and with a focus on culturally competent care. It's translated to high patient satisfaction.
Great. Go ahead.
Thanks, Sean. I'm Dr. Clint Flanagan. Appreciate the invite to be here at the Direct Primary Care 25 event. Obviously, I have a bias. I'm a recovering fee-for-service primary care physician. The last fee-for-service patient I saw was in 2017. I'm the founder of NextEra Healthcare. There's a reason our name is NextEra, because we had been in the fee-for-service area for many years, and we said we want to do better for patients and physicians in our communities. We started with 1 clinic in Colorado in the Boulder area, and now we have nearly 200 clinics across 25 states. The majority of the members that we take care of come from employer groups. And our mission at NextEra says two things. One, we want to make sure our members or patients have a good experience. And then number 2, we want to help get them to optimal health. So we've been doing that now for 16 years. And as much as I play a CMO role, I also see patients. And in a little bit of a prior chapter, I was ER doctor for 15 years as well. So kind of wore the hat of it as a primary care clinician, but also as an ER physician. So I have those experiences, and that's truthfully part of what got us to pioneering NextEra in Colorado 16 years ago.
Great. Well, thank the 3 of you. Michelle, I'm going to start with you. I've said this to you before, I haven't said it to the world many times, but I actually think of you as probably one of the most important primary care lobbyists and advocates in the country. And I thank you for that in a sincere way. But I think it's interesting to watch the evolution of really watching business, big and small, nobody's bigger than you, right? Like, come to this realization that the healthcare system wasn't necessarily working, not just for your company from a financial perspective, but for the lives and families that you're responsible for. And you start to seek out different things. And I'm wondering if you can just kind of talk to us a little bit about like Boeing's evolution in that, like when you didn't give up on the traditional healthcare system, but you really started looking for something else.
Well, thank you for that question, because I think to lay out our story, it really helps explain why we're here and why we care so much about primary care and really see it as foundational for the healthcare system and for the health of our folks, but Americans as a whole. Our story really starts in this chapter back early 2000s. Employers were all seeing double-digit % increases year over year in healthcare costs, and that was absolutely unsustainable. Boeing, being the leader that we are, we like to go disrupt things. We like to go figure out and engineer a solution. And when you have an unsustainable problem, you're going to go try and fix it. We did a study 2007 to 2009 looking at medical homes and the primary care setting, a coordinated, integrated care model. And what came out of that is really the foundation for everything we've done since then. We found 20% healthcare cost savings over 2 years with those that were in the program. These were employees with chronic conditions. Huge improvement in health outcomes, and a huge 56% increase in productivity. And so that is the business case that we use internally, continue to use internally, that we've been able to say, look, we're going to make some investments here. We're not going to see a year one return, but we're going to have a 5-year, a 10-year look here. So we took that and moved into direct contracting with hospital systems, focused on the primary care setting, perfected it, talked a lot about and incentivized behavioral health into the primary care setting, supported and paid additional payments, right, for those behaviors and those services that we were looking for. But that was only for our larger populations, where we have at least 10,000 employees or more. And as I said, we're in every state. So in 2018, we looked at direct primary care and how can we do this? How can we bring this type of primary care to every single employee across the country? And that's where we're at. We're starting to increase our contracts and spread that throughout the country, and we're looking to continue to do that.
So Clint and John, I'm going to come to you with back-to-back questions. So Boeing and people like Boeing and companies big and small are coming to this realization. So primary care has to meet the moment, and you guys are doing that. So Clint, can I start with you? Can you talk about the importance of this kind of shift that you see in the employer community, and then what you're doing to meet and exceed their expectation and investment in primary care?
Appreciate that question. And so employers are looking for solutions. And the status quo when it comes to health benefit, as Michelle talked a little bit about, is not only is it challenging for the employee to have access, convenience, and connectivity to their primary care physician or clinician, but it's really costly. I think if you look at some of the detail there, it's about $15,000 to $16,000 per employee per year that they're spending on a health benefit. And if you look at the family rate, it's around $25,000 in premium per family per year. And the majority of that is being paid by the employer, and a percentage of that's being paid by the employee. And that's the payment for a system where it's hard to find the physician, There's not a relationship like we heard about earlier. There's not continuity, and you get 7 to 10 minutes to talk about your 2 out of your 5 problems like was described earlier today. So fortunately, there are solutions, and what we see employers doing is realizing, hey, I'm not going to take that 12 or 15% increase in my premium. I'm going to restructure my benefit plan. I'm going to work with an innovative benefits advisor. We're going to put direct primary care at the core of the plan. We, the employer, are going to pay for that, and now the employee has access. It's convenient. They feel connected to their physician. Their physician or clinician has time, and they're getting primary care at a way higher level. Full scope primary care, I think, was discussed earlier by Dr. Davenport, where that physician and healthcare team has time to take care of that patient. And we're also meeting the patient where they're at. So specifically at NextEra, we have near-site clinics to that employer. We have on-site clinics that we don't charge the employer for. And we also have virtual care, because it's the 21st century, and you should be able to text, email, or call your doctor, right? So we've removed a lot of those administrative barriers, given that physician healthcare team time. And what we see when it comes to employer groups is it impacts absenteeism in the workplace, presenteeism in the workplace. You mentioned productivity, and then as we look at total spend, it definitely helps decrease total spend because that patient is no longer going to the urgent care or the ER or has 7 or 8 or 9 different specialists providing care, which their primary care physician could be and is doing for them. So it creates a tremendous value add, and as we see let's call it the business or CFO side of that, oftentimes the second highest cost outside of payroll is what they're paying for their health benefit. And with the CAA and with a fiduciary responsibility, you see HR and CFO kind of leaning into plan design, saying, how can we do this better? And we take care of employer groups that are fully insured, level funded, self-funded, but a big part of our business, kind of like John's, is the self-funded space. And they're putting direct primary care at the core. They're not putting fee-for-service, insurance-based primary care at the core, right? And that's a critical point to that design of the benefit plan.
Yeah. So John, kind of a similar question. You guys have had tremendous success, and I think you said in your opening, your team-based approach, multimodal approach to primary care. And can you talk a little bit, same question, about what you're seeing from your employer partners in all the spaces and kind of how you've met that moment at Primis and your growth? Like, you guys have really experienced tremendous growth of partnering with employers across the country.
Absolutely. And, you know, this notion of team-based care, I think, frequently comes through the lens of the provider team. And that's a critical component of it, of course. But there's a wider team. And that involves the purchaser of these healthcare services, which is the employer. So at Primis, our roots actually go back 60 years. And the company, through its predecessors and legacy units, was founded in steel mills and coal mines, doing occupational medicine, where employees were coming in with work injuries, they needed pre-employment exams, they needed surveillance. Over the years, employers realized that sometimes access is an issue, and as long as you're taking care of these occupational needs, maybe you could do some of these more acute episodic care needs. Somebody, you know, has a sore throat or they have a headache. Well, over the past 6 decades, there's been this phenomena which has paralleled this, not uncoincidentally, and that's increasing in healthcare costs. There's also increased frustration with access. There's increased frustration with quality. So we have seen a steady evolution over the past 6 decades of demand for, first off, urgent care type of services, wellness type of services, and then full service patient-centered medical home. And now that's really evolved to be advanced primary care services, integrated services. Employers now, I think, are frustrated with some of the multitude of single-point solutions. I call it tele-this and tele-that, where on the one hand, it's weight loss, and a different link takes you to erectile dysfunction, and you can find a physical therapist who's measuring the knee flexion with a phone. Well, we do have physical therapists who'll do that, and we have our own virtual health team. But our model is an integrated model where we have that provider team where we have, it can be a physician, a nurse practitioner who's side by side with a pharmacist, side by side by a behavioral health specialist, a care manager, a care navigator. And when you have all of that, you can actually have warm handoffs because we're delivering care in person. We're building those relationships. So if a behavioral health therapist is seeing an individual and is wondering if that person is responding, is perhaps he or she should, she can actually walk across the waiting room to one of our pharmacists and say, hey, how long do you typically expect it'll be that somebody's on one of these SSRIs before they're responding? And if the answer is, hey, it's been long enough, then that behavioral health therapist can go next door to talk to the primary care physician who's prescribing the medication, and they can all work together with one common goal, and that's the health of the employee or the patient who's in front of them.
It's Michelle, let me come back to you. So I think we spend a lot of our time talking about healthcare in the abstract, how to do it better. But it's come out a lot here today. At the end of the day, what we're really after is improved health and improved experience for the individual seeking and receiving that care. In your case, your employees and covered lives that you have. So when you think about the approach you're taking to primary care and your approach to healthcare generally, like, what are those goals that you're trying to accomplish for the employee or their family or the communities you serve? And what are you hoping to get out of that, near term and long term?
Well, it's certainly health outcomes, right? Improve the health of our population, and thereby we will reduce healthcare costs. But it is about the experience, and it is about this whole person integrated care model, right? There should be one place that someone can go, the primary care provider, where end to end that person's helping them navigate through the system and to provide care and, as the last panel was talking about, help alleviate anxiety and improve understanding of what their options are. That's really what we're looking for. That's the model that we envision. Everything that John just talked about, I was nodding my head, yes, 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 because it, time is precious, but understanding and access and high quality care is really, really important as well.
Yeah. So let me give the same question, Clint, to you and John. So you guys are in your recruitment, you're talking to employers. How are you positioning this concept of individual health and the benefit you bring to help people be healthier, the health versus health care concept, if you will, as you engage in these conversations? And I don't care who goes first, just Clint, I'll pick. Go ahead.
Yeah. So we stuck it in our mission statement that we want to help that person get to optimal health, and that's a little bit different for each person. Kind of want to meet them where they're at, whether they're 22 or 52, and say, hey, we have the time, let's make a plan, let's get some chemistry oftentimes, and let's move forward on objectives that you have and what we think is your doctor we should shoot for here in 2025. And we have the time to do that. So we moved completely away from the annual physical exam. We tell people, your employer and or you're paying for this monthly membership for NextEra Healthcare. Think of it like a gym membership. If you go to the gym once a year, how often are you going to hit that optimal health target, right? So we say we've changed it more so to health check-ins or touches, we call them. Those could be face-to-face, those could be virtual. Sometimes those may be an hour appointment. Sometimes they may be a 15-minute quick chat. But you have those touches, that develops, it was talked about earlier, the relationship, which develops the trust. And again, that employee or their family member, 90+% of their care can happen through us. A huge focus of ours is prevention. Most of what we have in America is not that. It's sick care, and it's very profitable for many. We're here to prevent disease state. Earlier it was talked about chronic disease. 90-some% of chronic disease is lifestyle related. So we're going to sit down and talk to you for quite some time and many times about your sleep, your nutrition, your exercise, and your emotional health. We're not going to, immediately give you Lipitor if you're going through Taco Bell every single day. Maybe we should talk about the Taco Bell, right? What I'm getting at is lifestyle medicine. It's been talked about very eloquently by Dr. Jonas earlier here today. And primary care is tremendously well positioned to help on that proactive, preventative lifestyle front. Unfortunately, most primary care clinicians in America don't have the time to do that right now because they're in fee-for-service models. We hire those doctors. We've hired about 10 here in the last 6 months or so, bring them into our system. They have the time to sit down and develop the relationship with the patient and talk about their exercise, their sleep, their nutrition, their emotional health. And while a lot of that can be handled in our clinics, and or virtually, sometimes we're throwing the pass to our behavioral health friends, sometimes we're throwing the pass to PT for strength and conditioning, et cetera, et cetera. So we're quarterbacking that care. And you know, almost 25 years of medicine, you would think for as much money as we pay in America, $4 trillion or so, that everybody would have that. But most people don't, and we're here to fix that.
Yeah. John, how about you?
So I really think that there are probably two approaches that I take in my conversations. One is the data-driven approach, and our value proposition continues to be high-quality, cost-effective healthcare in an experientially rewarding manner. And we've been fortunate. We've built models. They have worked well, where we have been able to deliver superior clinical outcomes, and it works. So we benchmark against HEDIS for outpatient ambulatory care metrics, and we're consistently 95th percentile or higher. I referenced earlier some of the cost savings, 30%, $2,400 per member per year. And we also measure patient satisfaction as well as provider satisfaction, and those metrics are all pretty hard, and they resonate generally with the employer audience. The other side of this is kind of the experiential or the more emotional pull. So if one is data-driven, two is, I think, the personal experience that we've all unfortunately had to live through. You know, call up the drugstore to figure out if the refill on your medication is ready. And you go through the phone tree, and if you haven't hung up by that point, you're in voicemail and you're waiting for a return call, and maybe you have to catch a plane, or maybe you've already missed a dose. And what if it's for an elderly parent or somebody who's not as healthcare literate as you might be? Or try and call up and schedule an appointment with a primary care physician if you don't happen to have a direct primary care relationship. I just heard the other day something along the lines of a wait time of 10 months. And that's a story that we all live through. And whether you're the chief human resources officer, or you're the chief financial officer, or the CEO of a large employer, I think that there is uniform recognition, number one, that at some point we're all patients and our families members are all patients, and we want the best for them. But no matter how financially disciplined I think that corporate America is, I am pleasantly reminded when I'm in the room with how committed corporate leaders tend to be about their employee base, and they want the best for them. And that resonates with them as well.
Yeah, I think that's right. So the academy's based in Kansas City, and I want to talk about data. But the Kansas City part of it is, you know, this Kansas City Chiefs were often criticized for the style in which they win. And Andy Reid, their coach, one time said, you know, all we do is play in Super Bowls. And it was just kind of a way of saying, like, you can criticize all you want. All we do is play in Super Bowls. And I'm curious, so you guys are having a lot of success. I mean, you speak about it from Boeing's perspective, but I want to give you an opportunity to talk about the data, talk about the, you know, your Super Bowls. Where are you seeing huge successes and wins from the approach you're taking? And then, of course, like every panel, we'll close out with like what we need to do next to be better. But, you know, let's talk about the proof points of what's happening in your individual experiences. We'll just go down the row here.
Well, I mentioned earlier the 20% healthcare cost savings and the 56% increase in productivity from our study. We, through our direct primary care initiative in Mesa, Arizona, which is the one we've had the longest since 2018, we've seen a 14% decrease in per member per month spend, right? We've seen 11% decrease in ER utilization, right? Those are the numbers that tell us that we're doing the right thing, we're helping patients, but it's also the stories. And those are not necessarily data points, but some of the quotes that we've had. We opened a new DPC in St. Louis in last June and did open houses. And the folks that came in, there's this one story about a pre-65 retiree who came into the open house to check it out to see what was going on, and started talking with the nurse practitioner about a mental health issue. And she pulled the behavioral health specialist aside, and they walked into her office and had that conversation. And I mean, that's that warm transfer, right? Those are the things that we want to see, and that our patients are, quite frankly, delighted of this new experience of how it can be.
All right, John?
Yeah, we just released a quintuple AIM report, and we focus on things like clinical metrics. I referenced those before, 95th percentile for HEDIS. We spend a lot of time focusing on cost savings because we know in the real world that does draw attention, and we've had success there, saving about 30% across a recent study that we did. We also look at patient satisfaction as well as our own employee satisfaction, and those rank very favorably with what you see in the community. We also, in 2024, surpassed 115,000 hits on our Find Help at premisehealth.org, which is a social driver of health search engine tool that we use to help identify and direct individuals to sources that might help them overcome limitations they have to reaching the care that's important to them. We conducted an analysis across our book of business that included 200,000 plus attributed patients with 26 employees across industry, across geography. It was validated independently by Milliman, and that confirmed what our cost savings is. But perhaps more important than anything else in this direct-to-employer space is we have about 275 clients, and their average tenure is 15 years. So that perhaps speaks as much to anything.
Glenn?
Yeah, I'll talk about that from the patient, maybe the physician, and the employer and community perspective. So from the patient perspective, again, I said our mission is to make sure they have a meaningful experience and help get them to optimal health. So one of the markers of meaningful experience is how do they rate you? And one of the things we do is a net promoter score. So our net promoter scores are typically in the upper 80s to low 90s. Typical healthcare is, I think, in the 10s to 20s. Number one. Number two, the patient, when the patient's paying the membership versus the employer, it's very sticky. So our churn rate, meaning people leaving NextEra, is about 2%. It's really, really low. And at the end of the day, our patient, they're a consumer, it's their choice, and they're continuing to pay us. So that tells us, I think, that we must be doing a pretty good job at the end of the day from a patient perspective. And then we also have health metrics that we look at, ranging from a variety of lanes, from high blood pressure to diabetes to obesity, depression, et cetera. So that's the patient perspective. I'd say maybe on the value of the physician or clinician perspective is, are they staying with you? Are they still working at NextEra Healthcare? And pretty much the answer to that is yes, unless they retire. So the part of the challenge with the health systems that many of us are familiar with here in Virginia or Colorado or Kansas City is the nurses, the MAs, the front office staff, the physicians, there's a churn. They're there for maybe 2 or 3 or 4 years and they leave. We don't have that churn. So from the physician perspective, and again, many of these physicians have, I call it kind of the wounds and scars and stripes and stars on their bodies from the fee-for-service system, and they come over to direct primary care, and it's a breath of fresh air and put some wind back in their sails. As I think about it from the employer perspective, we have very similar data. We save employers significant amounts of money on total per employee per year spend. How are we doing that? Less urgent care visits, less ER visits, less specialty visits, better pharmacy spend, and you go down that list. We also do a significant amount of precise care navigation. So we understand that benefit plan that the employer has, and we know where the, let's say, direct pay imaging centers are, where we can get an MRI for around $400 to $500 versus $4,000 to $5,000, or where the standalone ambulatory surgery centers are, where we can have a direct pay rate for an ACL repair versus sending that elective procedure to a big system where that care could be great, but the cost could be 2 to 3x. So that precise care navigation happens every day at NextEra, and that's because we have a direct understanding of that benefit plan, which differs from employer to employer. As I think about it from the community level, again, all healthcare should be local as much as possible, right? And preferably sending to physicians that own their own practices. So when we refer out to ortho, or refer to ophthalmology, or refer to urology, we definitely have a lane where we prefer to use our physicians that own their own practices and ASCs, and we bake that into the design of the plan. So keeping that care local, keeping that dollar local, versus a lot of the health care systems around us extract that dollar from the community. And so, again, drilling down to the patient, the physician, and or healthcare team, the community, and the employer level. Those are areas where value is provided.
Okay, we may only have time for one more question, so I'm gonna get my money's worth here. What does Boeing need from physicians and clinicians to scale this model? And what do you need from policymakers and regulators to do the same? For you guys, what do you need from Boeing or employers to scale your models, and what do you need from regulators to help make that successful?
So from providers, from physicians, we need more of you doing this, and we want to help encourage other populations, the Medicaid population and others, to be able to have access to this so that you see that there's a real demand out there for this type of care. From policymakers, it's very clear, and it is our top healthcare ask. It is that they pass the Primary Care Enhancement Act, which has to do with the first dollar coverage for those with high deductible health plans and health savings accounts. More than 40% of our employees choose that plan design of ours every year. It is our highest actuarial value plan in the company, and they know it and they use it, but we cannot offer this at no cost to them without the policy change. And we're hopeful. We know it's been introduced in the House by Lloyd Smucker and Brad Schneider. We're looking forward to Dr. Cassidy and Jean Shaheen introducing the bill potentially tomorrow in the Senate, and looking for opportunities to get it enacted this Congress.
Great. John, let me start with you. What do you need from employers, and what do you need from policymakers?
So I'll flip it to follow with what Michelle said. Same thing on the policy front. First dollar coverage makes use of on-site clinics and near-site clinics more accessible to employees. So we're big supporters of that. And from employers, really a few things. Number one, you got to invest in primary care. This works. Go ahead and do it. That's the first thing. And there are a couple of parallels that come along with that. And that would be, so the second thing would be measure your primary care spend. You know, in the United States, it's about 5% on average that gets spent on primary care, whereas in high-performing health systems, it's 2 to 3 times that. We like to target 12 to 15%. And in order to get there, you got to start by measuring. So go ahead, measure your overall primary care spend. And then the third thing is you want to drive primary care relationships. It's not enough just to invest and to know what your primary care spend is, but you want to encourage your employees. You want to encourage your employees' family members, who's ever on the plan. You want them to have primary care provider relationships. And there are a number of ways you can do that. There's some incentives, there's benefit design, but let's go ahead and let's together make that commitment and that investment in primary care.
Yeah, on the policy side, completely agree with Michelle. I have an HSA. I should be able to use my HSA account to pay for my direct primary care doctor. So for all the policy people that can fix that, or the 1 or 2 or 3, you get your NextEra for free. So just fix that. It's free, or I'll buy you a beer. So that's a huge policy issue. Outside of that, the Direct Primary Care Coalition has worked really hard across numerous states. There's legislation that has been passed that says direct primary care is not insurance. That's been tremendously helpful to help with the growth of direct primary care in this country. What would I ask of employers? Understanding 90% of our business comes from employers. I would encourage HR and or CFO to look specifically at the kind of primary care that your company is getting. And if that primary care is fee-for-service, insurance-based primary care, just know that there are other options that can give your employees better access, be more convenient, and effective and actually save you and your company money. So if you're still doing fee-for-service insurance-based primary care through a fully insured BUCA plan, you should question that, right? And if you need a 2x4 to help question that, you look at the CAA that says you have a fiduciary responsibility to say, hey, what can we do to really help our employees, and what can we do with those dollars? So I would encourage employers to look at direct primary care. This is our 16th year. We started off with 1 clinic. We have now over 200 or so across 25 states. It's working. So as we kind of look to the future, we don't necessarily, sure there will be things that will be created. And some of that may be through CMMI, et cetera, through APMs. But my gosh, direct primary care has been created. There's a whole army of us across the country that are doing this, and I would encourage employers to seek out DPC physicians in your communities.
Great. Okay, I lied. I'm going to come back to you. One closing question, Michelle. So you guys, every room you walk into, you're the most influential people in the room. You don't have to say it. I'll say it for you. So how are your colleagues, other companies, like responding? Are they calling you and asking, like, how are you doing this? Or are they still apprehensive about it? What is the reaction of your peer companies?
No, I'm glad you asked that, Sean. Last year, we began expanding direct primary care in these offerings. We started in St. Louis, but we also moved to Puget Sound, to Seattle, where we have tens of thousands of employees and dependents in the area. And we partnered with Purchaser Business Group on Health, Trade Association for plan sponsors, both private sector and public sector. And we shared Boeing's contract language with them and used them as a way to share this knowledge and allow other employers to duplicate what we're doing. eBay joined us in Seattle this year in doing similar contracts. There are other large employers in that area doing that. We're in San Antonio right now with an RFP to do an on-site clinic for our people, but also do a near-site that we're in a Port San Antonio with in the tech port with 80 other employers, including the Air Force. So, right, come join us, come see what we're doing. And so I think the energy is there, and more employers are taking notice.
That's great. Well, let me thank you on behalf of our partner organizations at Primary Care for America. Thank you for joining us today, and thanks for this wonderful conversation. Thank you.
Thank you.
Thank you.
So I believe we are ready for our next panel, which we are going to transition to. Our next panel is going to look at independent, but particularly rural independent primary care practices and how we can better support them and build an ecosystem around them for their success. And I'm going to turn it over to our moderator, Dr. Dan McCarter. Oh, we're going to take a picture. We're going to take a
Thanks, Sean. So if the other panelists could join me up here, it would be great. I'm Dan McCarter. I'm Professor of Family Medicine at UVA and Medical Director of Practice Innovation for UVA Physicians Group. Most of my career, I've been a country doctor, and rural medicine has always been about adaptability, whether it was making house calls on horseback in the early 1900s or by pickup trucks in the early 1990s when I started, are leveraging technology and new care models today to expand access and improve outcomes. I recently heard innovation defined as creating results by doing new things. That perfectly frames our discussion. Today, our panelists will highlight the challenges of delivering healthcare in rural communities and the innovative ways they're tackling these obstacles. And I'll let each of the panelists introduce themselves. I know One of our other panelists is a little bit behind, Tim Groninger, but he should be along shortly. So I'll just let everybody introduce themselves.
Great. Well, hi, everybody. I'm Carrie Cochran-McLean. I'm the Chief Policy Officer at the National Rural Health Association.
Good afternoon. I'm Dr. Sonia Bruton, the CEO and President of CCI Health Services, a federally qualified health center operating in Maryland.
Just in time, Tim. Go ahead.
Hello. Hello again. Tim Groninger. I am the CEO of Hopscotch Primary Care, a company bringing value-based advanced primary care to small towns and rural parts of the country.
And good afternoon. I'm Dr. Jim Lancaster. I'm a Regional Chief Medical Officer with Main Street Health. Our mission is supporting primary care in rural America.
So to get started, Carrie, can you provide an overview of rural primary care in the U.S.? What are we seeing as far as the challenges for both the workforce and the populations in the rural areas?
Thank you. Well, you all know that primary care, along with public health and emergency services, are really the essential backbone of how we provide care in our rural communities. And, you know, when you think about it, primary care really is the first point of entry into the health system, which is particularly important for rural residents that oftentimes have limited access. So as we think about rural parts of the country, primary quick care and workforce shortages are not a new thing. It is, I think, an issue folks have been struggling with for decades and has been a source of innovation in many parts of the country, but also has been a persistent challenge and remains a key challenge for today. And so a couple of just statistics to throw at you to help frame this. So 70% of the health professional shortage areas in this country are located in rural areas. That is a disproportionate number, just as a heads up. And while we have about 20% of our population living in rural areas, we only have about 10% of our physician workforce practicing there. And we continue to see closures of independent primary care practices or consolidations of those practices, which have impacts on individuals' access to care. So when you think about some of those challenges and disparities, it really aligns with what we see in our rural areas in terms of growing medical deserts and challenges of accessing a whole range of healthcare services. And that maldistribution really is reflected in kind of not only the wait times and kind of services provided in communities, but also very much in the rural health outcomes and life expectancies that we see, which are disproportionately worse in rural communities than are urban. So a couple of just thoughts on challenges or why some of these things are persistent or exist, and then I will turn it over to others. But you know, when you think about how we get our workforce into rural areas, training is such a huge component of it, and I know we'll talk a lot about that today. But despite kind of knowing that that is a solution that works, only 2% of our Medicare-funded residency training occurs in rural areas. Again, we have 20% of the population living there. So we definitely, you know, that's an area we need to look at. We also have seen increased levels of burnout that have really caused many health professionals to decrease their work hours, leave their practice, choose to practice in less challenging settings in some cases, further straining the rural workforce. And last but not least, we're definitely seeing the number of rural physicians that are age 50, let's say 50% too. That's a nice way to think of the age 50. Age 50 or older, you know, we've got about half of our rural physicians in that bucket, which really highlights, you know, we've got an issue now, but it's definitely a growing issue as well.
Great, thank you. That really sets the stage. And the other part of the issue is a lot of times they have less access to resources, like many people will have a family farm that they can't sell, but it makes them ineligible for Medicaid or for other benefits that they might have. So it can make a huge difference. And Sonia, what are your thoughts? What do you agree with, and what do you have to add to this?
I think I agree with everything that was said, and what I do what I will do is add to that. I have to say that my voice is kind of channeling a couple of partner health centers in Maryland on the Eastern Shore and a health center in the eastern part of North Carolina. But looking from that lens, which is really the ground level, the things that kind of churn underneath those big statistics are things like increased disparities, having the opportunity to generate additional income and to demonstrate your great work through value-based metrics that then have you having to outdo yourself every year, coming within the acceptable ranges, but then you're not up against the range anymore, you're up against you. And when you're having to outdo yourself over and over, it's like that perpetual last 5 or 3 pounds that just won't go off the body. And I would also say the things that make practice harder, no broadband bus services that allows people to actually get to their appointments with transportation, no affordable housing for staff that want to move into rural areas and to live, or no available housing. And so all those things are what's underneath the statistics that Carrie's giving.
And I know by training you're a behavioralist. What's behavioral health care like in the rural areas?
The picture gets even darker. I'm a clinical psychologist, and in terms of that workforce, the ability to meet the language needs of the folks in the rural communities, which are more and more occupied by folks who are not necessarily English as their first language speakers. There is all the high demand and the high salaries that can't be met in the rural environments. And there is, as we have talked about, as the workforce ages and the new early career professionals are going in, it's very difficult to find the fullness of life that you're looking for in those rural environments, which make those professionals go to larger markets.
Tim, what are your
a lot of waterfront to cover. Yeah, where would you like to go? So, from my perspective, that totally agree. Lots of problems that are very well documented by NRHA and in a number of other research publications. From my perspective, what you really see in rural areas, small towns, that's different from urban, larger clusters is, it's very cliched. Healthcare is super local, hyper local. It's especially local in rural areas, and by which I mean the spread out population, the different types of workforces available manifest. You're sort of trying to build a business and bring, in my case, bring access to seniors, and on the margin, you're going to be heavily influenced by, well, is the nearest hospital that you can recruit nurses, is it 30 minutes away or is it like 90 minutes away? Right? And so those pieces end up making it a little bit more complicated to figure out not just the markets you're in now, but your next 5 markets. And it makes it more complicated to bring access consistently in the same way across states. And that's compounded by different policies for supporting workforce access. We make good use of things like National Health Service Corps, other incentives to bring physicians to rural areas. But some states will have strong incentives for and reasonable rates in Medicaid managed care. Other states, it's a more mixed bag. You really have to get more creative to put together and run a clinic successfully in a rural market.
And Jim, what are you finding at Main Street?
I find it's hard to follow up these 3. Those were great comments, right? And I just have to say thanks to Sean and Bethany for allowing me to be here to speak on such an important topic. Like you, Dan, I've been a primary care doc my entire career from a small town, very dear subject. Dr. Flanagan, the comment about care should be local, right? And for Main Street, we're serving seniors, and having access to good whole person primary care and the resources they need is so challenging in rural America. Primary care is challenged as a specialty as a rule. It's what we've been speaking about today. There are changes that need to happen to remedy that. I would say the theme of today is see the possibilities. Well, the possibilities for rural primary care are honestly, there are great possibilities on the horizon. The innovations in quality and value-based care and value-based renovation give me great hope. I joined Main Street because of, I'd done primary care for 20 years in a traditional practice. I struggled, just like we've talked about primary care being hard today. We were talking about average family practice panel. The doctor was speaking about earlier today. Mine was 3,800 patients when I left practice to lead value-based relationships. And I struggled. What I've been so happy about is Main Street bringing health navigators to small towns across the nation, embedded into practices to help seniors find those resources that they don't know about. They don't know those extra benefits are out there. They don't know who to call. There's no one transportation number in some of our small towns. It may be run by the local church. So helping seniors, helping take some of the burden off primary care doctors to let them focus on clinical practice. Carrie, thank you for sharing some statistics a second ago. 3,300 plus independent practices closed between 2019 and 2024 in rural America. That's a lot. That's a lot of practices closed in our small towns. The payment challenges. 1 in 5 physicians considering leaving practice in the next 2 years, an aging workforce. We're going to talk about how do we get that next generation, but I feel like the underlying theme is how do we get primary care and, the residents of rural America, how do we get them more help?
Good point. And Carrie, so what's your interest in why are you so interested in rural health care?
Like individually as a person? Oh, that's a nice question. Well, I am originally from Montana. I'm actually a fifth generation Montanan, believe it or not. And so, it's like many here on the stage who've practiced in the setting, it's home, right? And it's, I think a really important part as we think about how we deliver care in this country, geography is something that folks don't always think about, but makes a huge difference in people's access. So that's my driver.
And Sonia, how about you? Because you've done most of your work in the city, but now you're looking into the rural areas. So what's driving you that direction?
Yeah, I too am a small town girl. I'm from a small town called Chapel Hill, North Carolina, where you can walk from one side of the town to the next. It's really about access. It's making sure that there are resources available in these areas where so many things are leaving. The health center that I work closest with is Bertie County Rural Health Association, which is in a very small Windsor, North Carolina, in eastern North Carolina, not far from ECU. They still have one Subway as their restaurant, and they have more people dying every year than they have being born. And so there has to be that local fire, that wanting to maintain relationships, values. If you go to Chapel Hill, North Carolina, there's a community health center called Piedmont Health Services. I was a patient of Piedmont Health Services from the moment I was released from the NICU, and all of my care has been at federally qualified health centers. They are so proud of me. You can walk in there. At one point, they had a photo, in the health center. And so it's that ability to change the trajectory of lives and know the change you made because you can actually follow that child for their lifetime. It's having continuity of care that comes from someone having treated your mother and your aunt and knowing the things that run in your family so you don't have to. Those things are critically important. Good medicine includes the independent knowledge and empowerment that comes from a patient matched with the academic training that folks get from medicine, bringing those two lenses together and the synergy from both knowledge groups coming together. That's how you change health outcomes. And so making sure that that's still possible. In those little small towns, it's not just having the medical facilities that are there and serving them and being available, but having them run by people who are from there and understand them and want to raise the livelihoods of the people who are there, use health as an economic generator, and not just be there to transact a business.
So how are you innovating and investing in this work with your group?
Many different ways. I think the first way is by strategic partnerships and recognizing that those partnerships have to extend beyond those rural borders. So in Maryland, for example, 2 of the health centers on the Eastern Shore, Chesapeake Health Services and Chop Tank Community Health Systems, they are partnered with my health center in a more in a more urban area, and 4 other health centers on our own health plan, our own Medicaid managed care plan, so that we have half ownership and Johns Hopkins has the other half, which gives us access to that broader array of resources, but coming together so that we can begin to design and control our fates and the lives of our participants.
So I'm going to move on to Tim, and then this having control of the health plan, would like to know what your interest in rural care is, but then how you're investing in the rural care.
Absolutely, and that was a great answer, Sonia. Thank you. My journey was more born out of frustration, I would say, than anything quite so inspirational as that. But I would say I had the pleasure of working with hundreds of health systems, rural health clinics, critical access hospitals, independent practice physicians in rural medicine, in prior lives, both in policy, but then especially when I worked at Caravan Health and Signify, bringing value-based enablement solutions, bringing technology, wraparound services, and it was so hard to get progress, right? And it's working with extremely well-meaning clients, people who want to do the right thing. Payment systems are telling them to do something else or something that's like sideways to the right thing. And so it's like the rural health clinics where like, okay, you've got the patient in front of you. Now's the chance to do comprehensive health risk assessment. Now's the chance to do everything that, all the things that the patient's behind on. It's like, well, I'm going to get paid another few $100s if they come back next week though. And it's like, yes, that is what the payment system says to do, but 50% of them won't come back next week. And so like that's just reality right now in the sort of core fee-for-service Medicare. And so coming back, having another chance to regroup, seeing what has been done in these advanced primary care models. We were founded by Oak Street and a number of other incubators, saw what Oak Street did, what Chen and Iora and another of others have done. This model, it's just like first order providing access in these towns to extremely high quality, high touch, tech-enabled primary care produces such incredible improvements in patient experience and quality and avoidance of hospitalizations. Chance to build something brand new from scratch where you can avoid and make choices about all of those decisions on the margin about you don't have to bring the patient back, you can have a longer visit. You've got to build it around a different type of economic model, but it can really work wonders, right, as I know you know personally. So that was the real excitement here, and working in a space where it hasn't really been figured out. The big operators haven't really figured it out. It's just really exciting opportunity. I love problem solving. My job is to make my providers, my physicians, and APPs jobs as easy as possible with tools and support, and so we're investing as much as we can in making their lives easier and making it as easy as possible to run a clinic effectively in a small town.
So, obviously, it's your turn.
Thanks, Dan. And Tim's comments, Tim was one of the first panelists I heard this morning. And it does bring to light the fact that good work is happening. I think for a long time, value-based care and value-based solutions were happening in a trickle-down methodology from the largest metropolitan areas, and maybe they could trickle down to medium communities. Very little got to the smallest communities in America, the communities that may need it the most. For myself, my personal motivations have been the fact I'm from a small town. I'm from a small town. Grew up, and I think about the mother rule. I spoke to Dr. Goodrich after her comments earlier, sharing about her mother's care, right, in the lack of navigation, the extra care that was needed, and the frustrations of, despite having a great doc, the frustrations of getting that for her mother. And so I've always used in practice kind of the mother rule. What kind of care would I want my mother and father to have? And I know that I was fortunate to be in a large independent medical group of approximately 25 physicians. We were able, in challenging primary care reimbursement, which we've discussed at length today, to stay afloat because of size and leverage. Well, you don't have enough docs to have a 25 physician group in small town America. So how do we support those smaller practices, but let them stay independent if they so choose? And that's really what drew me to the innovation of Main Street when I heard the model. I had been leading value-based relationships for approximately a decade. But again, those solutions often weren't a good fit for smaller towns and smaller practices. When I heard the innovation with Main Street, able to support the smallest of physician practices in the smallest of towns, but was so innovative and logical that it worked upstream as well. With real help, when we talk about the investments, you mentioned investments and innovations, I knew I didn't have enough help in primary care. 3 of the top 5 burnout specialties by the AMA study last year are primary care specialties because they don't have enough help, but they also can't afford help, right? They're barely keeping their head above water. So our mission of investing in primary care by supplying health navigators that we pay for in small towns across America, and making value-based revenue reliable as opposed to a very complex puzzle that requires a lot of investment by the practice is really what drew me to the point I am now.
And neither you nor Tim mentioned this, but when you're working in these accountable care models, you get more of the financial information. And financial information is evidence, just like clinical information is. How are you using that information to help inform the care you're providing the patients?
Yeah, no, I mean, the data available, and again, I think this is something we take for granted now, but this is inconceivable 20 years ago when some of these reforms hadn't been even put into law yet, of access to claims data, visibility into where patients are going, where they're seeking care, not just with you, but with others in the community, others when they travel. That gives you visibility into their risk, their relative likelihood of admitting. If they're not filling a script, then you can know that within a matter of a couple of days, sometimes less, depending on how you're setting it up. So there's the claims data, layering it together with other sources of information, phone call data, like what they're calling us about, and then, of course, clinical data in the EMR allows you to really get a much more rich and holistic picture of a patient's experience and needs than was ever possible, certainly 20 years ago, but even 5 years ago, the ecosystem has really matured a lot. So that allows you to be intelligent about where you're putting resources and who needs to be coming in every month rather than just when they escalate, who needs special attention from care navigators and nurses and other members of the care team to solve problems that may be escalating. How do you track down a patient within a day or 2 after they're discharged from the hospital rather than waiting for them to show up again or waiting for the payer to feed you the data? So tremendously important part of the work that we do is work that our data and engineering and product teams do to push information to our clinical teams for direct management of patient needs.
And Jim, how do you, I'm sure when you start working with a practice and you suddenly start showing them this data, it's a little bit of a culture shock. So how do you work with them to understand the pearls, nuggets that can come in that data?
Well, I think as a physician, what I really wanted to know is which of my patients do I need to be worried about, right? I think one of the things that I've had the pleasure of telling PCPs, which we serve primary care practices across the spectrum of value-based care naive, who didn't realize the money was out there, to sophisticated practices who are like, yeah, we've been investing, but the money hasn't necessarily been reliable to help us fund the clinic. And we're overwhelmed with data and lists coming in from everywhere, from every plan, and we can't keep up with it. So again, our model is fairly simple, and it's why I joined Main Street. Basically, all the data the clinician needs to know is fed through our navigator. I tell them, we're not giving you a portal, there's a person. When I go live with clinics, they're like, well, how do we log in? I'm like, you don't log in. Susie will be here tomorrow, and she's going to give you all the information you need, and the discharge data and the preventive health data and who hasn't been in the practice. That's all on our shoulders, her shoulders. But she's a member of your team, and she's a community health worker. I met with one of our navigators yesterday in Northwest Alabama, who's a seasoned navigator, but she was new to this practice. And the first med adherence, Tim mentioned med adherence, one of the first med adherence calls she made yesterday, she was calling the patient because she hadn't picked up her medication, and the patient told her her lights were about to be cut off. So she went to work getting the light bill paid by the local community, because if our seniors, if they can't pay their light bill, they're not going to pick up their blood pressure medicines. So it's really the whole care of the person
Right.
and the real help.
Figuring out what the most important thing is. And a lot of times that doesn't involve the prescription pad. So what, how do we address the workforce shortage going on in rural areas? I mean, do you, I guess we can start with Carrie from sort of the policy standpoint, but then would like to know the people working in these practices, how do we address this going forward?
Yeah, I mean, when I think about workforce, you think about training, distribution, and retention as kind of your three big buckets, right? So kind of going back to some of the earlier comments I made about training, we really, we've learned over time that place really matters when we're talking about physician training. And when there was a study that came out a couple years ago that had some great data that showed individuals who do their residency training or some level of training within a rural setting are 5 times more likely to practice there. If you're from a rural area, even if you don't get that residency done there, you're still 4 and change times more likely to practice there. And even later in the careers, that continues. So, we really need to think about how we are investing and supporting those training opportunities. And we all know kind of the pipeline all the way up to residency and how important all of that is. But I think that's, so often when I talk to folks in the field, the capacity to do that kind of training is so challenging when you are a small practice, when you are when you're already strapped in terms of your workforce, having to choose between providing clinical care and taking on a student is a really challenging thing. And so thinking about how we invest in programs to do that is really important, and to how to lift up those successes. And I think another area I would hit on that Sonia started to talk about is just how do we wrap around the experience of individuals who are trying to set up practices and live in rural areas. So often, we don't think about the investment of what it takes to run a small business as a physician, right? And so where are there opportunities where we can offer tax credits or incentives to have clinical practice, whether that's, if you're practicing in a HIPSA, or if you're serving as a preceptor, or if you are kind of creating a new capacity in a rural community, how do we kind of reward that? And then, again, wrapping around things like housing shortages and childcare shortages and so much that's needed in our rural communities. Rural communities on the whole are struggling, and so we need to think about kind of the economic development that goes not only with healthcare, and the role healthcare plays in that, but also in the broader community, so people can continue to live healthy lives in those settings.
Sonia, what do you think? I mean, again, Eastern North Carolina and the Eastern Shore you've got to be a special person to want to live in those areas, right?
Absolutely.
A wonderful person.
Some of it is stopping those little cuts. And so some of the cuts come from things like 24-hour call. And many clinicians not wanting to do 24-hour call and not having the hospitalist model as an option. And so it's having different options for that. It's making sure that when you are on call that there are companies that are, through standing orders and through the clinical teams that they employ, able to take as many things off of what has to actually go to the physician as possible. It's little things like having and being willing and having a relationship to have a 3-month hotel stay until you can actually find housing that you want to live in or that you can afford. It's really increasing the workforce by looking at those 50-plus age providers who've been running a business for a long time and they still want to practice medicine, but they need a little bit of a break, and merging with them. There's a lot of those kind of acquisition type things that are happening in both of the areas. It's also looking back at the people who did come up from there and did become physicians and maybe have lived elsewhere, and they have their spouse and their children have gotten through school, and saying, how about coming back home? It's time to now that parents are getting a little bit older, or you're at a part in life where you maybe are a little bit more interested in being around your family, a lot of those kind of outreaches and beginning to track folks that got away and convincing them to come on back home.
Yeah, but it's talking about spouses. So I was practicing in a rural area when I got married, and my wife, the biggest shock to her was going to the grocery store, going anywhere. Everybody in town knew who she was, and they knew that she was my wife, and that was something that really got pretty difficult for her. She wasn't used to it. She had grown up in a larger area, and so that was something that we had to sort of have our boundaries as to who could show up at the house unannounced and who couldn't show up at the house unannounced.
A little bit of those culture shifts. I know the folks at Chop Tank even talked about residents like to see their physicians in the grocery store. They like to see them walking around, and that kind of People magazine, they're just like us, seeing them do those things just like you, and they appreciate those connections.
Tim, how are you all handling the workforce?
I think that it's a really good point Sonia made, and I think of this as like related to expectations from the physician workforce for a more modern practice ownership and management experience. And so we have a few practices where we acquired the practice, and thinking of like Dr. McCormick works with us in Tryon, North Carolina, absolute pillar of the community. Everybody knows her. It's daunting for another physician to come in and have to be Dr. McCormick, right? And so we've partnered with her and brought her more team members. We've brought her a physician's assistant. We've brought more team members to support the panel. We're able to recruit someone who, it's a very, a lot of these places are very nice places to live, able to bring someone in who wants to be there, but is not going to have that same level that Dr. McCormick had to, going through the transition of getting her own IT and doing HR forever and contracting, right? And all those things have gotten more complicated. That's true across healthcare, but it's especially acute when you have like a 3,000, 3,500 patient panel to manage, and you're the only show in town, right? So I think what we're able to do is bring an experience where the physician can still practice and see the patients, have full accountability and that full relationship practice top of license with a really well-supported team, the best technology, really good economic arrangements for them and their families long term, but be able to do it in a way that's more in accordance with the way they want to practice today versus the way it was 30 years ago.
And Jim?
Well, I'll say, Tim, I love that support you're speaking about for new clinicians coming into communities that Hopscotch is providing. That's wonderful. And I love Carrie and Sonia, y'all's comments about both the challenges and also the opportunities. The fact is, like being from a small town, Dan, we know that, physicians are still thought of as, kind of the pillars in the community. They're very respected, especially primary care physicians. It's such an honor to be a primary care physician because it's truly that one specialty where people consider you their doctor, right? I mean, it's almost a possession of you as their doctor in the grocery store, right? At Main Street, we don't acquire practices or employ physicians, but I think what we do that we're hoping helps is value-based revenue. If we can supply them predictable, reliable, a simpler solution to value-based revenue that they can count on, hopefully they can use that to help fund the next clinician that joins them. Maybe a physician, maybe a nurse practitioner. That's okay, but it's primary care. And I think the other thing is trying to make their life better with health navigators to take some of those administrative burdens and non-clinical needs of patients off their shoulders to make their life better. Perhaps they can get their head above water and actually be able to think about how they survive and grow in primary care.
Great points. Now we're going to give Carrie the tough question. So proposed budget cuts significantly impact rural health care programs and training. What are the risks there, and what can be done to mitigate those risks?
Yeah, well, we can hope for a miracle that the detailed president's budget comes out with lots of changes. But just for as a reminder for folks, we saw a leaked version, an early version of the FY26 president's budget, and it did not look good for rural health or for some of the workforce training programs that we have within HHS. I think it's really important, just as a quick synopsis of that. And again, I want to reiterate that while we've seen a skinny version of the high-level numbers that's been officially released, we still don't know the weeds of what's below that. But based on what we saw in the leaked version, core rural healthcare programs that help to support the infrastructure in rural areas, like the state offices of rural health, the Medicare flexibility program that supports small rural hospitals and EMS, the rural residency planning and development program, which is a program that has been immensely successful. It's a pilot out of the Federal Office of Rural Health Policy that's been operating since 2019. And in that time period, it has helped to stand up 54 accredited residency programs in rural areas and create over 650 new residency slots in rural, and about 2/3 of those are full. So we are really seeing progress with that program, and it has been zeroed out. So those are really kind of targeted rural efforts that we need to bring back. And then in the Bureau of Health Workforce, or what is formerly currently in process of the Bureau of Health Workforce, we saw a bunch of some of the core training programs that target rural or underserved communities, like the AHEC program, faculty loan and faculty support programs, geriatric programs, the list goes on and on. So in terms of what we need to do, we need to all collectively raise our voice and work with your members of Congress. The way the president's budget works every year is that, the president puts this out as his or her priorities for what they want to accomplish in the administration, and then Congress comes back and kind of debates that and comes up with their own proposal. This being the first year of this term, I think there's a lot of interest in trying to support the president's budget as much as the Republicans in Congress can, but they need to hear from us collectively about what impact this would have on our communities.
Thank you. So we'll go just sort of a quick round with a magic wand question. So if I could hand you a magic wand and you could get the payers, the policymakers, or the providers to make one change in rural health care, what would it be? And we'll go the reverse order this time. Jim, what's...
I think we've talked about kind of the understanding that reimbursements for primary care, especially independent primary care, is a very challenging proposition. And primary care now, to stay independent, those independent practices and small community hospital practices and large practices depend on value-based income to stay viable. But it's a very complicated system. It's ever-changing. It's incredibly hard to manage, especially when it's not just one value-based system, it's multiple. So if the payers and Medicare and the commercial payers could get on the same page and make that a simpler program so that it was not such a maze to navigate, so that clinicians could focus more on the patient care and improving patient outcomes, that would be my one wish.
That's great. Tim?
I have a very long list, actually, but I'm going to attempt to give one, like making a wish for more wishes type of thing, where if we could have I've seen some states do regional planning really well, and it's hard to do because they don't have enough power, and you end up needing things from Medicare, and you need things from different parts of the government. If we had a way to create empowered, funded regional planning collaboratives that could sort of intelligently engineer the relationships between urban centers and the rural needs, I think you can get a lot of work done. And I think that some states like Pennsylvania, state of Washington, Vermont, I think that they've made some progress doing that, and I think we should turbocharge that and do it widespread.
Sounds like a great idea. Sonia?
I think for me it would be force them to follow the rules and just do what's right. There's so often things that are required to be reimbursed or paid aren't. You have to fight to get the actual claims paid, or they're greatly delayed. So it would really be about the structure of the process of putting in a claim and actually having it paid and getting that payment to you on a timely basis. That could go a long way for the cash flow that's necessary to keep the rural health care going and growth to happen.
I am going to go political because that's my job, but I think as much as I would like to be forward-thinking about what we could do to fix rural, I am definitely in a defensive crouch right now. The decisions that are going to be made over the next several months between reconciliation and the president and the appropriations for FY26 really have the potential to devastate rural communities. And you mentioned early on, kind of, we're so reliant in our rural communities on public payers, so Medicaid, the marketplace, Medicare, and as we're talking about the potential policy changes that are being discussed in reconciliation, especially around Medicaid, that is going to have not only significant consequences for the individuals that are losing or changing coverage and benefits, but the people who are caring for them in their rural communities are going to have to take on debt. They're going to have to turn people away. It'll be a rippling effect. So I would like policymakers to really, as they're looking at these things, really understand the impact that will have on access to care in their rural communities and make sure that that's the decision that they want to support.
Okay. Thank you. Great thought. So first, thank you to my fellow panelists today for a dynamic and insightful discussion. Many view rural and urban healthcare as separate spheres, each with its own unique challenges. In some ways, I think this rural healthcare we're talking about might be the canary in the coal mine. If the rural areas struggle, the other areas are going to have a difficult time. So innovations emerging here have the potential to transcend geography, shaping solutions that benefit all the populations. And so on behalf of the panel, I want to thank Primary Care for America for bringing us together for this important conversation, PrimaryCare25.
Thank you, Dan.
Thank you guys so much. Outstanding conversation. So we're going to close out Primary Care 25 with an incredible group of individuals who have extensive knowledge around the models that have been put forth from innovation from the Innovation Center. CMMI was created as part of the Affordable Care Act. Over the last several years, 15 years, it has driven innovation, not just in primary care, but across physician services, hospitals, and specialty care. I'm going to invite Ipsita Smolinski, founder of Capital Street, to come up and be joined by her fellow panelists, and we're going to have a robust discussion about CMMI models current and into the future. Ipsita, it's in your chair.
All right. Well, fellow panelists, come on up. We are saving the best for last. I should mention that we're a man down, so we should have had a fourth.
Literally a man down.
Literally a man down. But don't worry, he's okay, just a bit of the flu. So thank you, all of you, for being on this panel. Our panel today is called the Primary Care Innovation CMMI Models panel, and guess what? We're going to talk about primary care innovation and CMMI models. So truth in advertising. I'd love for my panelists to just give a brief intro. It doesn't have to be long, 30 seconds. I know, Purva, you spoke earlier today, and you're basically famous anyway, but why don't we start with you, and then we'll jump into some questions.
So I feel better because I went to sit on the end, because I swear, I thought there were four of us. Purva Rao, I most recently was the Chief Strategy Officer at the CMS Innovation Center. Really excited to be here and be part of so much of the day today. Prior to that, spent almost a decade teaching, writing, and doing business strategy, policy consulting, and also spent time on the Hill working on the Affordable Care Act before that.
Hi, good afternoon. Ruth Pollard. I have the honor and the privilege to serve as the president and CEO of the DC Primary Care Association and our clinically integrated network, the DC Connected Care Network. I'm a native Washingtonian, though I went to school in Chapel Hill, so I know lots about that, and excited to be here today to share.
Great, and I am Kristen McGovern. I'm a partner at Serona Strategies. We are a DC-based policy and government affairs firm. I run a coalition called the Partnership to Empower Physician-Led Care, which includes AAFP as a member, and we are focused on value-based care as a path to sustainability for independent practices and physicians.
Awesome, and then Ipsitas Belinsky Capitol Street, our firm is a research-based organization on all things policy, really, and how that impacts providers and all stakeholders in the system. And we're just down the street and also serve on the faculty at Georgetown, and really excited to talk about primary care. So let's just dive right in. Purva, why don't we start with you, since we're talking about CMMI. And I guess just taking a step back quickly, you know, there's a new sheriff in town. So we've got a new CMMI leader and other, of course, agency leaders that are just getting seated here and should be hearing some sort of, I would think, strategic reset, goals, vision. So would love to hear from your perspective what that might entail, and also, again, reflecting on your last few years there, what it should entail.
So, like, first I'll say that taking a kind of a historical view and perspective on where we've been in this journey, I think is really important. And we opened up, at least part of the morning today, opened up talking about MACRA and really putting that in historical perspective. And I think that's really helpful. So when I started at the Innovation Center in 2021, we'd already been, you know, testing advanced primary care models, ACO models for nearly a decade at that point. And so it was really about, well, what should the future state look like? And one of the big goals that the Biden-Harris administration put out was to get all of our beneficiaries into accountable care relationships, right? Mostly primary care-based relationships for the most part, where beneficiaries have longitudinal care relationships with their providers. And the question, because if that's your vision, your goal for what a beneficiary should experience as they navigate the health system, well, how do you get there? And so we looked at what were all the, some of the biggest lessons that we had learned across administrations, across, the Obama administration, the first Trump administration, what should this next administration do? And I'll say just a very high level, what we take for granted now, we didn't know back in 2010, 2011, 2012. And so I just, similar to the MACRA discussion this morning, I think it's important to remember how far we've come and what all of the learnings that we actually really do have. And so some of the things that we really honed in on were that when you change primary care payment, when it becomes more flexible, when you increase payment levels, you see care delivery reorganize itself and change. So across, multiple models and administrations, what you saw was that practices that were in these value-based payment models, they were changing the way that they delivered care. They were using risk stratification to deliver care management. They were providing 24/7 access. They were engaging in team-based care, hiring those community health workers, social workers, integrating behavioral health, because you are creating payment systems that support and enable that kind of care. We also found that a lot of the models that had been running were not in areas where you had underserved, lower income populations. They were running in more affluent areas. So if you want to increase population health at scale, we want America to be healthier, then we've got to increase the reach of high quality primary care in all communities. And so that meant a real focus on equity. And then the third point is multi-payer alignment and permanence. Practices that were in these models were reporting that these changes that we are making are sustainable if the payment changes are permanent, right? And I think that's a really important point for this next administration moving forward, is that there are a lot of lessons learned. How do you take what we know is working, and how do you make it permanent? And that was part of what we had wanted to do. So when we think about primary care, both independent practices, which I know we were talking about in the previous panel, ACO work, a lot of which we had done with Kristen, even when I was at the Innovation Center, there were three main principles that we wanted to apply across our portfolio when it came to primary care. One is change the payment structure, increase the investment in primary care, and move towards hybrid payments that, again, enable flexible care delivery, allow for team-based care, the things that we know are working. The second was increase the reach of advanced primary care in all communities. So a focus on safety net providers and community health centers and bringing more people into that tent to make it possible for them to participate in these kinds of models. And then the third is the point around permanence. How do we create models that are multi-payer in nature, bringing Medicaid and states to the table, hopefully commercial as well. That's a very difficult nut to crack, I will tell you, but I think we were making some inroads actually with the Making Care primary model. And then permanence also in terms of regulation, right? We've got a shared savings program. We have a physician fee schedule. How do we start to utilize those and innovate into them? It doesn't have to be an entire model that gets certified. There are lots of learnings that can translate into incremental change through those existing permanent structures in the program. In terms of where we are moving forward, I think hopefully this, a new strategy will be released soon, so the picture becomes clearer for advanced primary care as it sits outside ACOs. I think, I think it was last month. The announcement of the model terminations, I think, does call into question what the future of standalone advanced primary care models are outside of ACOs. Primary Care First was slated to end at the end of next year, 2026, and it has been losing money or has not been able to demonstrate savings. We can talk about evaluation until we're blue in the face. But and then Making Care Primary, I mean, there was no data on the model. It had just really gotten off the ground. And so I think those are big questions. We know that a lot of primary care providers are not yet in value-based payment models. ACOs may not be the place that they want to start or end. And so having these other opportunities and options, I think, is important. And I think that's going to be something that we should all watch closely to understand how to engage, what are the options that we need to continue building to strengthen the primary care infrastructure, both inside and outside ACOs. I think a couple of positive points, at least, that it looks like the ACO primary care flex model is going to continue. And then I think we're all wondering what happens after ACO reach as well. So more questions outside of the ACO world, but those are some of the things that I think we all have to watch.
Awesome. I guess building off of one point you made around multi-payer, Ruth, I would love to hear sort of your perspective. Of course, there were certainly some CMMI models that you all were interested in and participated in, but is that a real sort of step forward to be able to kind of take it beyond Medicare, Medicaid, commercial, and sort of do that multi-payer perspective?
Yeah, well, I think it's definitely meaningful progress there. You talked about the ACO primary care flex. We have to think, we're all here because we know primary care works, right? And we know that we need to be better resourced in primary care. And federally qualified health centers are the largest primary care network. 32.5 million, I think, is what Peter quoted. And I think what we've had challenges with is that federally qualified health centers were underrepresented in the CMS innovation models, and even those that they were able to participate in, there were a lot of barriers. And we've talked about them, things like administrative barriers. There are barriers around the risk capacity, right? Barriers around data. And so we think that there's probably a lot more to talk about in terms of how we move forward together versus sort of like what's happened in the past. One of my favorite books, What Got You Here Won't Get You There. And so I think that that's more of what we definitely want to talk about. Primary care associations have been engaging with their community health centers to create these clinically integrated networks. And we are approaching probably 40 to 50% of primary care owned or aligned clinically integrated networks. In the District of Columbia, we serve 184,000 patients in our clinically integrated network. We have 7 federally qualified health centers, 7 of the 8 federally qualified health centers, and the Primary Care Association. And we really do think that bringing together this clinically integrated network that, again, is led by the community health centers will help to overcome some of the obstacles and the barriers that we've seen in so the previous CMMI innovation models and learn together. Like, we really do believe we can be a good partner with CMMI as we move forward around value-based care. Excited to say that just last month in DC, our DC Connected Care Network, which is our clinically integrated network, announced its first value-based contract with the Mayor Group DC. So there's definitely movement, definitely way to go. That, you know, the multi-payer will be very important to help support consistency, I think, and standardization, so that, again, we can overcome some of those barriers that we've seen.
Awesome. I realize I'm going a little off script, but you know, I was thinking about the rural health young lady who was sitting at the end, and she was talking about Medicaid and kind of this situation we're in with reconciliation and work requirements and so many other policies under consideration. And you know, I remember that sort of phrase of like, well, value-based care and Medicaid is like the Wild West or early days, or you know, whatever phrase you want to use. Is that something that we could see out of a CMMI, since we're talking about innovation, is innovating around Medicaid specifically? And I'd love to hear from anybody on that.
And I'm happy to jump in. I think it's hard to think about meeting, you know, big picture goals around prevention, health outcomes, without including Medicaid. And so I think in primary care, when you're thinking about multi-payer alignment, our strategy was to start with Medicaid and really align with state Medicaid programs, especially when you look at the payer mix for many family practices in particular. I do think, though, that the reality is that there's real emphasis on health savings and cost savings, and so these things are going to be these are tensions that are already butting up against each other. So, you know, do I think there should be more innovation in Medicaid? Yes. Will we see it? I don't know under the current sort of emphasis and drive to have cost savings.
I think. You know, someone on the earlier panel said they were in a defensive crouch, and I think Medicaid programs are in a defensive crouch right now. So really trying to protect what they have, and not necessarily in a place where they're sort of forward thinking about new opportunities and new possibilities, unfortunately.
Yeah, I think you're right. You know, just one other, since we're going off script anyway, like, one other thought I had was that, you know, you had COVID and the PHE and then the unwinding, and that really was the focus of a lot of what was happening at the federal level in Medicaid and at state Medicaid programs. And so at that time, you did see a little bit of a lull in terms of Medicaid's movement to value and value-based payment. They didn't have the bandwidth to do it. State Medicaid programs are strapped anyway. What we were starting to see in the last, I would say, 12 to 18 months was a reemergence of those issues. We were starting to hear again from state Medicaid directors who you know, felt like they were starting to have the bandwidth to think about value. There was more state interest. I am afraid, though, that as they go into defensive posture, we're going to see that, you know, that trend go the other direction again.
Which I think will be really problematic if we do that, because regardless of, you know, I always say that, you know, the work that we do in community health centers, it's not partisan. It's work that we do. Primary care is not partisan. Like, it's work that we do. And primary, you know, community health centers have been doing this work for a really long time, and it should be agnostic to what's happening in Medicaid or what's happening in administration. We still need to be thinking about how we get value, drive value base in our Medicaid populations, regardless of what's happening in administration, executive, legislative, et cetera. We need to be thinking that kind of way.
One last thing I'll say on this is that, you know, sort of to go full circle to multi-payer models, the Biden administration announced the AHEAD model, which did have a Medicaid primary care component, does have a Medicaid primary care component. I think the strategy there was to plus up the low Medicaid rates to incentivize providers to offer, you know, to have Medicaid patients and to enter into multi-payer arrangements that included Medicaid. Obviously, in addition to sort of the big picture philosophical thoughts on who and what and how the Medicaid program should be operating, there is intense cost sensitivity, and so it does seem unlikely. Again, ahead as far as we know is continuing, and those policies will remain in place. But it seems unlikely that there will be a desire to do anything new that would add cost and incentivize Medicaid offerings through like a plus up to the base Medicaid rate.
That's great color, thank you. The AHEAD model, I believe, is that 10 years, 11 years? It's a pretty long Is that something, it feels like that's something we could see again over the next 2 years, 3 years, 4 years, or longer models, potentially ones that are, like in the fee schedules themselves, the physician fee schedule or IPPS or whatnot. Is that something that you all are thinking about, or any observations there as to whether that's good or bad, or any other color?
I think longer models are, and we've kind of run the gamut. So some models have been pretty short, like 3 to 5 year models. We've had some 8-year models, and we have some longer 10-year models. I think the data is pretty clear at this point, like 10, 15 years in, that it does take a while to show savings, particularly from ACO models. I think most ACOs don't really start to show savings until about 3 years in. And so it takes a while. You have to endure some losses before you can, reap the rewards of the shared savings. And I think longer models allow for, one, those models to be, those savings to be demonstrated, but also to see how they are sustained and how they grow over time. And so I do think longer models have some real benefits in terms of the evaluations, which we've sort of alluded to. There's a lot to say about the pros and cons of the evaluations and whether they actually measure model success. But a longer model does allow for those evaluations to pull out the bright spots and really build up the evidence that the model is or is not working.
Yeah, I think it depends on the area, right? So I think Kristen's absolutely right. The data are clear in the ECO space and even in the standalone primary care models that you really start to see an acceleration of changes in utilization, quality changes, and savings accelerate in years 4 and 5. That tells you that it takes time to invest in patients, to build up care teams, and to see some results. And we have to be realistic about that, and hence this move towards some of the longer models, like AHEAD, where you're really restructuring. The primary care piece is one component of a restructuring of healthcare financing in a state. But we tried that with Making Care Primary. There's a dementia model that's 8 years. So definitely, I think in other places, a long model may not make sense, right? There are places where you're more directly maybe driving efficiency through payment changes. Those probably lend themselves to something shorter. I will say, again, the emphasis on savings is going to mean probably, if you're thinking about portfolio management for the Innovation Center, there's probably going to be a mix of things that are longer term where you need a longer time horizon to realize the savings, and then probably some narrower, more discrete models that drive savings in the near term, given the need to produce those.
I think from an independent practice and physician standpoint, I think we heard Jim on the earlier panel emphasize the importance of stability and consistency. And so if you're an independent or a smaller practice out there deciding to move from fee-for-service to value, you want a longer runway because you don't want to have to make a lot of investments and practice upgrades and enhancements without knowing that you'll have some runway to bear the fruit of those investments. And so from that perspective, a longer timeline where appropriate and warranted is good for an independent practice or a smaller practice thinking about coming into these models, because it does provide for that stability, and you will have a return for a certain period of time.
And I think that's the same for us. I think that it's we want to be sure that it's built with an understanding of how we operate. And that's really important. So like you said, there may be some options that are more short-term and some to ramp us up, and then some that are more long-term that really do understand, look at the total cost of care, look at how we align quality measures, look at potential capitated rate, et cetera. I don't think that we're concerned about what it's called. We're more concerned about how it's built with us in mind to be participants.
No, I think that's a great point. And even as I I missed the morning sessions, but the afternoon sessions here, I feel like we're all kind of talking about the same thing at some level, right? Like more prevention, more upfront care, and reducing expensive downstream care, and obviously at a lower cost. So whether it's DPC or ACOs, it's healthcare. We've got a lot of acronyms, but they all seem to end up with we all want the same result. Is that fair? And I feel like we don't have Karthik on our panel from Agilon, but I know that the private sector has been extremely excited in a lot of these models, and to the extent that they extend, ACO REACH does sunset, I guess, next year, at the end of next year. So are there any thoughts on whether that model may continue and be modified? I know we've talked about longer term models, maybe mandatory models. We can talk about the pros and cons of those, but I'd love to hear, Kristen, what is your take on ACO REACH? Has had
I speak it, will it happen? I don't know. Superstition coming to play here. So ACO REACH, I think everybody knows, started out as the Global and Professional Direct Contracting model. That was its title. For the first 2 years, it was then evolved into ACO REACH, which it has been now for several years. And I think the early evaluations, at least of the GPDC, the original model construct, have not been good. The model has not demonstrated quality improvements and has lost a lot of money. So I think this current administration will be grappling with what to do with the model, and whether the changes that were made in the evolution from GPDC to ACO REACH, what the comparisons are across the evaluations, whether any of those model changes had an impact positively or negatively on the evaluations, and where they go from here. I think there are a lot of folks out there that are hopeful that the model will be extended maybe for an additional year. Again, I think a lot of that is going to hinge on what this next evaluation shows, because it will be the first evaluation under the ACO REACH construct. I do believe they will make changes to the model for 2026 to try to take some cost out of the model, and also to double down on quality. So I think there are a lot of open questions with respect to that model, and a lot of it hinges on CMMI's authority, what they can and can't do under their mandate to test models that are promising and that are delivering on their intended goal. So I think we'll have to stay tuned. We should know something very soon, I think, about what will be coming for 2026. They already have placeholder white papers up on the website, in case you were wondering. So definitely some new methodology papers coming from that model for 2026, and we should know soon.
And you said that we have an evaluation coming kind of soon-ish, or we don't know, on the latest iteration?
Yeah, so I think the general timeline is summer for releasing the evaluations. Could come a little bit sooner, could come a little bit later. Historically, it's sort of been end of July into August when those evaluations have been released. So in the next couple of months, I'd say.
Excellent. I don't have a watch on, so I don't know how much time we have.
We have 15 minutes.
Oh, awesome. All right. What are we missing here? I know that we talked about having a little bit of a, if I could give CMMI 3 words of wisdom or advice as they embark on their journey, maybe we can go down the row and then riff on that. Mm-hmm. Do you want to start, Purva?
Yeah. I was just saying, as Kristen was talking about REACH, I'll just add one thing, that a lot of times in these conversations we get very focused, and it makes sense, like what's going to happen to a CMMI model. It's really hard to get a model certified and expanded. Again, we could talk about why, but that's not why we're here right now. But what I found myself as I've left over the last few months, and even when I was there, is thinking about what is it that we're learning in each model. So we think about REACH and whether it saves money. I think actually some of the more recent the quarterly quality performance has actually been pretty good. It's what is it that it's helping though, and I wish Karthik was here to talk about this, what is it that it's helping providers do differently, and primary care providers specifically, right? And what we hear about, it's the prospective cash flows, it's the prospective dollars, it's the flexibility, it's fewer quality measures. And, the evaluations can tell us big picture, is this going to be expanded or certified? But in the case of ACO REACH, we have a shared savings program. We have a permanent ACO program that we can innovate into. And when those teams are working together, you can make change in the permanent program by using regulatory mechanisms and regulation to make changes. So if we know that what's really valuable to primary care providers and to patients is being able to innovate on care delivery and having the flexibility and the prospective cash flows, and let's find a way to make that part of the shared savings program, if that makes sense. And I think that also helps us not think about individual model by model, but again, how are we impacting permanent change? If that's what's working for practices, then it shouldn't just work for 5 years and then the model ends, right? We really should be thinking about how to make that a permanent part of the primary care infrastructure and payment infrastructure in the country. In terms of I guess just advice, it's, one thing that I think I became increasingly aware of over my time, prior to the Innovation Center working on APM and value issues, but definitely in my time at the Innovation Center were what one of my colleagues, Dr. Bruce Fink, who I know several of you know, would call the hidden risks of being in a model. So we talk a lot about financial risk, and I think we will see probably a greater emphasis on financial risk-taking maybe in the portfolio moving forward. But there are a lot of other things that practices have to sign on to, and Kristen, you know this from the independent practice perspective. You already alluded to it, but there's the administrative burden of being in a model. There's changing your care delivery. There's all of the things you have to do to meet a model's requirements. And then there's the financial risk on top of that. And I'm just naming a couple of those hidden risks. But you have to take all of those into account when you're thinking about whether or not a model is viable for folks. I also think one of the other tensions that I don't think we ever resolved, I don't know if it's resolvable or if that's a word, is the need for kind of simplicity and harmonizing and streamlining the portfolio and options, with having options for practices that are in different places and have different needs, right? So on the one hand, we know that we need kind of multiple pathways and on-ramps for people. On the other hand, when you have too many on-ramps, everybody gets confused. And so I think kind of working with, AFP, Primary Care from and other organizations, I think is helpful to understand what that right balance is between making sure you have enough options for all the different practice types out there and organizations out there, while not overwhelming the market and the landscape. So those are just a couple of thoughts in terms of, I think, tensions moving forward in model development. And actually, the last thing I'll also say is the fee schedule, and really thinking about that as a tool moving forward in this environment, because models aren't always going to be a place people jump into. SSP may not be a place everyone jumps into, but all providers, bill the fee schedule for the most part. And so one of the things that we had started to do with our colleagues in the Center for Medicare was starting to think about, it started the APCM, the Advanced Primary Care Management Bundle, a small code set that actually started to build on some of the learnings from the first 10 years and thinking within CMS's statutory authority, can you over time potentially build that code set out to look a little bit more like a hybrid payment in the fee schedule? Like, how do we raise the bar or raise the floor for primary care payment using the tools that the agency has available, which also nicely connects to the MACRA discussion. If Congress really does make a push there, there's real opportunity, I think, to make a big leap forward on primary care payment.
Ruth. Yeah, Perva, I don't think I have much to add to that. I think they're excellent. I would say, when I think about the largest, again, primary care network and federally qualified health centers, I would say two things. Be sure that as we're thinking about these models, whether expanding or creating new or extending, that we think about supporting upfront infrastructure because of the past under-resource and under-investment in federally qualified health centers to participate in these type of models. We really do need upfront infrastructure support through, PMPM, care coordination, PPM, upfront, other types of upfront infrastructure to make sure we have the right data, that, the capacity to do these things, to take on risk. And then I would say the second point would be to ensure that we have opportunity to build for that risk, right? You have to enter into risk relationships with payers. And so let's be sure that we have the FQs have the ability to build that risk so that they can be prepared, not just for upside, but for downside risk in value-based contracts. So again, I think through clinically integrated networks, we can be a really great partner with CMMI as they think about what you're going to do moving forward.
I think I have 3 things to say. One aligns with where Purva started us, which is that the CMMI models are great. They are terrific opportunities for some entities, but they may not be the starting point for all entities. And there is a layer of complexity that comes with a CMMI model that might make it not the right starting point for many primary care practices. And I think, one of the things that our coalition, the Partnership to Empower Physician-Led Care, has always advocated for is a glide path. So not, there may be a tendency, for example, to double down on ACOs. Some providers might not want to be in an ACO for many reasons, and that doesn't mean they shouldn't be able to participate in accountable care relationships. It just means that there is a different starting point for them. That starting point might be the, new APCM code bundle and the fee schedule, or it might be something else. And so really thinking about, not jumping into a model because you want to do value-based care or accountable care, but really thinking about the full range of accountable care options and where is the best starting point, whether it's a CMMI model or not. I think the second thing I would say is I think there is a real operational agenda for CMMI to consider. And it is difficult because CMMI uses, in many instances, the existing CMS fee-for-service chassis to run its models. And I'll just speak from the independent practice perspective. As independent practices, get into these models, they want consistency and they want to know that CMS is going to be a good business partner. There are lots of ways for CMS to be a good business partner, but it is sometimes operationally challenging for them to be a good business partner because the infrastructure is not set up for them to be so. So for example, the ACO REACH model allows practices to elect into claims reductions, claims deductions, and for different providers in one ACO to have different claims deductions. The MACs have to process those. The MACs are not really set up to do some of this detailed claims processing work. They get a claim, they pay the claim. Now they have developed some more sophisticated capabilities, I think, but this is just one example of how the existing infrastructure, there is not sometimes nuance in the existing infrastructure needed to adjust to the difference in payment policies, whether that's claims processing or waiver policies or attribution, voluntary or claims-based. There's just not always the infrastructure set up to do it. And so I think one thing the new leadership could do is really focus on operations to demonstrate that they have the capability to be a good business partner to people electing these new types of arrangements. The last thing I will say is that, and this is maybe not, I don't know if this is a directive to CMMI leadership or just a comment, but I think your experience in these models really depends on who you choose to partner with, because the models allow flexibility in terms of implementation, and like an ACO will enter into contracts with its providers, or a convener may enter into contracts with its providers, and within the constraints of whatever program they're participating in, they are allowed some flexibility in terms of what that looks like. And so I think one thing that's really important is recognizing if you're a practice or a provider out there, is really vetting carefully your partners and thinking carefully about what they are offering you, what you are offering them, and how that compares to what other model participants are doing. So there is that layer of complexity, sort of the rules that CMMI sets, and then the additional sort of contractual layer or other sorts of policies that different participants adopt depending on their own business needs.
Wonderful. Maybe 2 quick final questions, unless we're going to go over time. I wanted to, you were talking, I liked your 3 points there. Sean told me once, Martin, that when they surveyed their membership, that it was 17 different sets of quality measures, and it's such an administrative burden. So I just wanted to build on that point that you were mentioning from the physician perspective, is the administrative simplification coming down? Is that something that we could see going forward?
I think there are a lot of potentially a lot of deregulatory opportunities there. I did. This is just one example. I had a call with someone today who said, "Oh, there's a new requirement for advanced alternative payment model participants. Now, instead of 75% of your participants on a certified EHR technology, you have to have 100%." And I went through this, health IT product, and it's certified for G4, G5, and G8 criteria, but not G6, G7, and G10. There's no check mark next to those. What does it mean? Does it mean that they don't have it, or they do have it? And how do I figure out, so there's a lot of complexity, I think, in these models and in the model requirements. And so lots of deregulatory opportunity. I think on the quality side, one thing we hear is, there's a program quality metrics, and then there's the MIPS MACRA quality metrics, and they don't align, and you have to report to both, and it can be challenging. We do hear that people really like the ACO REACH quality metric construct because it is a short list of measures that matter. Now there's a lot of detail around like panel size and sampling, statistical, one patient gets a bad score and your whole score tanks. There's a lot of details like that, but people do like a shorter list of measures, more aligned measures, and I do think that this administration will be thinking about and may be more willing to just sort of like redline some things and see what happens. Whereas, maybe not so willing to just sort of take a let's see what happens approach under previous leadership. So yes, lots of opportunity, I think, to reduce administrative burden in a lot of different ways, whether that's technology, quality, or even other areas like claims processing and IT infrastructure and all that.
Great. I think we are out of time. Thank you so much, and let's have cocktails.
It's literally a mic drop. Yeah. Thank you all very much. Thank you for joining us today for PrimaryCare25. I think we had a lot of really meaningful and impactful conversations. The one thing I'm taking away from today is that there's a lot of optimism about the opportunities that are available for primary care, but also the fact that primary care is innovating amongst itself to meet the moment and serve communities. If you would like to learn more about Primary Care for America and our work, you can visit our website at primarycareforamerica.org. Please follow us on social media. All of the sessions from today will be recorded and posted on our website in a matter of a few days. And we look forward to seeing you at Primary Care 26. Thank you so much.